really good. And keeping the quiz in the first week also.
It has started. Please come. So your breakfast is there.
వాళ్ళు ఓడిపోతారు, బయటికి పిలిచి వాళ్ళిద్దరిని బయటికి తీసుకున్న తర్వాత ఇక మీ పని మీరు చేసుకున్నారు. ఒకసారి రౌండ్ చేసిన మొత్తం
ఎక్కడ మీరే ఇటు సైడ్ ఫస్ట్ అన్నారు కదా.
Next question. Name the deformity of second toe in patients with severe hallux valgus. Next question. A patient presents after a fall and X-ray demonstrate lateral talar shift and proximal fibula fracture. What is the eponymous name of this injury? As per Hawkins' classification of fracture neck talus, in X-ray shown is classified as A type 1, B type 2, C type 3, D type 4. Next, 14th question. Which of the following statements in CTEV is true? A. Teratological clubfoot is more common than idiopathic clubfoot. B. Operative treatment is the mainstay of treatment in idiopathic clubfoot. C. Rocker bottom foot is a complication. D. Open tenotomy of tendocles is performed in Ponseti method. Name the deformity of great toe.
శోభన్ స్క్రీన్ అంతనే ఉన్నారు.
Back question later. Back.
Name the deformity of grade 2. Most probable diagnosis.
Wait.
17th question. And common peroneal nerve are normal. Diagnosis.
Again, like it.
కాలేదు సార్.
మీరు ఇద్దరు నిలబడి సిరిసార్ మీరు నిలబడక బయట ఇస్తే దీని గురించి ఒక్కసారి చెప్తే అది లైవ్కి వెళ్ళిపోతుంది. అట్లా ఆల్రెడీ సైట్లో చాలా మంది చాటింగ్ చేస్తున్నారు.
అవునా ఈయన కమలాకర్
Modernity. Prakash. తెలుసు కదా మీకు ఏం స్కిల్ యూజీ యూజీ కూడా యూజీ పీజీ ఆ ముగ్గురు అయితే సేమ్
కార్తీక్ వచ్చిండా
లోపల అది నడుస్తున్నా నాకు
లైవ్ స్ట్రీమ్ సార్
ఓకే స్టార్ట్ Yeah. Good morning to you all. Today we are going for the basic workshop and basic course on foot and ankle at Rohi Hospital, Hanamkonda. And we are having good faculty, Girish Motwani, Rahul Upadhyaya, Prakash and Kamlakar from different places. And you know, foot and ankle is a rapidly developing specialty with a lot of opportunities in that. And we have registered about 110 delegates for that, and the program has already started, and it's going on well. Everything is fine, and I wish, as a chairman, I am Dr. Srinivas Reddy, and organizing secretary Dr. Sirish Ramkumar Reddy, Professor and HOD, Takatiya Medical College. We are here, and everything is going on well. I wish the workshop and the basic course a grand success.
On behalf of the organizing committee, we welcome all the delegates who came far away from the Telangana and AP. And it is an academic feast for as a foot and ankle is a subspecialty which is rapidly growing nowadays. Now the faculty has come far away from one faculty from Jaipur, one is from Nagpur, and two faculty from the Hyderabad. So it is a very essential for the young ortho surgeons and the postgraduates. So please utilize this opportunity and welcome all the delegates. Thank you.
Good morning, friends. The Warangal Orthopaedic Association under Telangana Orthopaedic Association is conducting one-day academic program in orthopedics at this Warangal hospital. So the topic is foot and ankle. Chala very important and very apt to the younger students where there are many complex procedures are there, and the trauma is very calm and the food and very useful to all the orthopedic fraternity. So I congratulate the Warangal Orthopaedic Surgeons Association team for conducting this nice conference. Thank you.
Last question, 25th question. 10 years old male child who is an athlete presents with pain in the posterior aspect of bilateral heel since 6 weeks with limp and aggravated with jumping. Pain worsened with training and prevented return to sports activity. There is no history of trauma. Diagnosis. Thank you. Quiz is completed. Hand over your answer sheets.
Sir, Mike, you can take the pads with you. No need to give back. Sir, here.
HDMI కి దీనికి కనెక్ట్ చేస్తాం. డైరెక్ట్ స్క్రీన్ కనెక్ట్ చేసి దీనికి చేసినావు కదా, దీనికి కనెక్ట్ చేసినావు కదా, డబల్ HDMI కి అక్కడ ఏమన్నా అక్కడ వాళ్ళు నాకు డబల్ HDMI డబ్బులు ఉంటుంది కానీ ఏదైనా ఒకటే వస్తుంది, రెండు రావు. సరే చూపించుకుందాం.
ఓకే, అది చూడండి. మనమైతే
Good morning to all the delegates who have attended foot and ankle course. Now I invite Dr. Srinivas Reddy sir for the welcome message.
Yeah, good morning to you all. I welcome you for the much awaited foot and ankle basic course and workshop. You know well, foot and ankle is a rapidly developing subspecialty in orthopedics, and which is having lot of opportunities in it. And we are having very good and esteemed faculty from Nagpur, Dr. Girish Motwani sir, and Rahul from Jaipur, and Prakash from Armoor, and our own student from Kakatiya Medical College, Dr. Kamlakar, have come from different places to deliver their lectures. All these are very eminent masters in foot and ankle, and the topics are designed in such a way they are so comprehensive. They are the basic day-to-day problems in our practice, maybe the surgical or maybe the OP, and they are such a way they are designed and very useful to all of us. And even in the afternoon session we are having workshop, and which is the common topics like posterior malleolus fixation, tender Achilles issues, fracture calcaneum, disc franks. All these are very common topics, and I request all of you to utilize the opportunity and become enriched in your academics. And I'm very happy to say you that after the announcement of the course, we have registered almost within 10 days span about 100. Our target had reached 10 days. We have got 100 delegates got registered for the basic course. That shows the interest towards the specialty. So I request you, all of you, to concentrate on the topics which are going to be delivered by the esteemed faculty. And the other part is after every session in the morning, pre-lunch session, we are having a 10 to 15 minutes of question and answers. And all of you, whoever, maybe the postgraduate or the surgeons, feel free to participate and interact with the masters. So I request you, all of you, to utilize the opportunity, which is very essential for all of us. And I'm very much thankful to all the supporting team for this meeting. I wish all the best to the successful conduction of the foot and ankle basic course. Thank you, and I request Dr. Karthik to take the proceedings.
Thank you, sir. Now I invite Dr. Srikruta to give a brief introduction about Dr. G. Prakash sir.
Good morning, everyone. Dr. G. Prakash sir.
ఇక్కడ ఏముందో అక్షయ పెట్టాము అక్కడ పెట్టి స్క్రీన్స్ వచ్చి లైవ్ పెట్టాలి స్టాండ్స్
Good morning to all professors. Dr. G. Prakash sir did his MBBS in 1989 batch from KMC Warangal and did his MS Orthopaedics in 1997 batch from Gandhi Medical College, Secunderabad. Did fellowship in foot and ankle surgery in Sunshine Hospital, Baroda under guidance of the foot and ankle surgeon past president Dr. Raju Shah sir in 2018. And he received Shanta and Gold Medalist award for the year 1994 of KMC Warangal. Received Best Doctor Award by Telangana Government 2 times in 2015 and 2022 under private hospitals Aravishri Healthcare. Presently working as a private ortho and foot and ankle society consultant at the Aparna Hospital, Arun Municipality of Nizamabad.
Now I invite Dr. G. Prakash sir to give his lecture on anatomy and biomechanics of hand.
Good morning to you all. Thanks to the Warangal Association. Special thanks to Dr. Srinivas Reddy sir for giving me this chance. My today's topic is anatomy and biomechanics of the foot and ankle. Now it consists of 48 bones, 2 sesamoids, and 27 articulations and 100 ligaments. It includes distal tibiofibular joint, ankle joint, and the foot also. The foot consists The foot has 3 parts: hind foot, mid foot, and the forefoot. The hind foot we have talus in the calcaneus, in the mid foot navicular. In the mid foot we have navicular, cuneiform, and the cuboid folds. In the forefoot we have metatarsals and phalanges. And our topic with anatomy will also include movements and the biomechanics of the foot and ankle. Coming to the bones, lateral malleus and the medial malleus and the talus. Inferior surface of the talus has 3 articular facets: anterior, medial, and posterior. The next is calcaneum. Calcaneum consists of the tuberosity, 6 surfaces, and the medial side sustentacle and tali. And the superior surface has got 3 articular facets. These unite to form 2 angles: Bowler's angle and Giselle angle. The Bowler's angle is the angle between the superior surface of the calcaneum and the line connecting the posterior and anterior surface, and it's around 20 to 40 degrees. And this Bowler's angle is decreased in the depressive fractures of the calcaneum. Second is the Giselle angle. It is an angle formed between the posterior and anterior facets of the ankle. It is around 120 to 140 degrees. It widens in the fractures of the calcaneum. Second is next to the calcaneal pitch. This is the oblique of inclination of the calcaneum. It's around 20 to 40 degrees. This is also decreased in calcaneal fractures. Next is navicular, which is board shaped, and the 3 cuneiforms, cuboid, metatarsals, and the phalanges. With coalition, and point about it, abnormal connection between the 2 or more bones is called coalition. Common is talocalcaneal coalition and the calcaneal navicular coalition. And coming to the joints, start with the distal tibiofibular joint. It's a syndesmotic joint. In this, fibula is directed from the posterior to the anterior with 30 degrees. Hence, when the fractures of the syndesmosis, we have to fix the screw from the posterior to the anterior with 30 degrees, and it is supported with syndesmotic ligament. Next is the ankle joint. In this ankle joint, the dome, convex dome, the talus fits into the concave mortis formed by the distal tibioid fibula. It's a hinge joint. It only sagittal plane movements are possible, that is dorsiflexion up to 20 degrees, plantar flexion up to 50 degrees. Next is circular joint. It's an articulation between the talus and the calcaneum. It has 3 articular facets, posterior being the largest, around 70%. In the middle, head of the talus sits on the sustentaculum tali, and anterior continues with the talonavicular joint. The movements in the circular joint are inversion and eversion. In the boot foot, we have the chopard joint. It has two parts: talonavicular joint and the calcaneal cuboid joint. The talonavicular joint is supported with the spring ligament. The other joints are between navicular and cuneiform cuboid, and the navicular and the intercuneiform and cuneiform cuboid joint. Lisfranc joint. This is called transmetatarsal joints. Medial lead is rigid and the lateral lead is mobile. It is divided into 3 columns. The medial column from first metatarsal to the medial cuneiform. It is heaviest and less mobile. Lateral is 5th metatarsal to the cuboid. It is most mobile. In the middle we have 2nd and 3rd metatarsals to the intermediate and lateral cuneiform. It is supported by the Lisfranc ligament. Forefoot joint, metatarsophalangeal joints and interphalangeal joints. The first ray of the foot consists of the first metatarsal and medial cuneiform. The 5th ray consists of the 5th metatarsal and cuboid bone. The ligaments, there are important 6 ligaments in the foot. To start with syndesmotic ligament. Syndesmosis is a joint, it is a fibrous joint into which 2 adjacent bones are linked with strong membrane. Distal tibiofibular joint is a syndesmotic joint. It has anteriorly AITFL injury. It has got AITFL ligament anteriorly. This is injured in high ankle sprain. PITFL of the posterior stride, which is a very strong ligament, but it is injured in the posterior malleolar fracture. It is injured in the posterior malleolar fractures. The other parts are transverse ligament and the intraosseous ligament. Normal tibia fibula clear space is around 5 mm, and the overlap of the tibia and fibula is 10 mm. If the clear space is more than 5 mm, it is called syndesmotic injury. This injury is clinically identified by the squeeze test, that is compression of the tibia and fibula at the distal tibial level produces pain. In external rotation test, where the foot, on external rotation of the foot in dorsiflexion, keeping the knee in flexion produces the pain. Anterior fibular translation, anterior or posterior drawing of the fibula produces anterior translation of the fibula and causes the pain. Cotton test, and perioperatively, when you pull the fibula with a hook, laterally there is a widening of the syndesmosis. It is called cotton test. Coming to the other ligaments, deltoid ligament, it is a medial cell ligament. It has two parts, superficial part and the deep part. Superficial is larger and fan shaped. It crosses the both ankle and subtalar joint, inserts onto the navicular sustentally, and the deeper part it extends. It crosses only ankle joint. It is medial stabilizer of the ankle. In deltoid ligament injury, the medial clear space of the ankle increases. This is a diagnostic point. In the lateral side, we have ATFL, that is anterior tibial ligament. This injury, ATFL injury, leads to the anterior translation of the fibula more than 8 mm. PTFL being the strongest ligament, less commonly injured, and the CFL, it prevents the talar tilt in the ankle. Next is spring ligament. It is calcaneonavicular ligament. It attaches from the sustentator tali to the calcaneum. It supports the head of the talus and stabilizes the medial longitudinal arch. Injury to this ligament leads to the flat foot deformity. Lisfranc ligament. It is an oblique ligament which extends from the medial cuneiform to the base of the second metatarsal. It has three parts: dorsal, interosseous, and the strongest plantar part. Next is the plantar fascia. It extends from the base of the calcaneal tuberosity to insert onto the first and second metatarsals. First to 1 to 5 metatarsals, and the fraginal phalanx is from 1 to 5 toes. The function of the plantar fascia is to support the arches of the foot and increase the arch of the height like a windlass mechanism while walking. Next, muscles. It is divided into 4 compartments: anterior, posterior, posterior medial, and lateral. In the anterior compartment, we have tibialis anterior, extensor distorum longus, extensor halsis longus, and peroneus tertius. These are the 4. These are very strong dorsiflexors of the foot. Medial goes to the middle and distal phalanges of these 2 to 5 toes. EHL to the great toe. And the lateral side, we have 2 muscles, peroneus longus and brevis. These are strong everters and the dorsiflexors. Peroneus longus passes underneath the foot and inserts under the first metatarsal and the medial cuneiform. Peroneus brevis is short and inserts under the fifth metatarsal. The posterior compartment, we have gastrocnemius, soleus, and plantaris. The gastrocnemius and soleus unite to form a tendoachilles which inserts onto the posterior surface of the calcaneum. This is a strong plantar flexor and inverter of the foot. Now coming to the important post immuscle of the foot is post-tibialis posterior. It passes posterior to the medial malleus. It is a dynamic stabilizer of the medial longitudinal arch of the foot. It has multiple attachments. One attachment to the navicular elevates the foot, and the other attachment to the sustentaculum keep the head of the talus into the position, and the insertions onto the second and fifth metatarsals forms a rigid lever for the supination of the foot. Tibialis posterior is very active in the stance phase of the foot. In the gait cycle, the role of the tibialis posterior is it acts as the shock absorber in heel strike. In the mid stance phase, it keeps the foot flat. At heel rise, that is in the terminal stance phase, with the concentric contraction of the cuneiform bones, it forms a rigid lever arm, helps in the push of the foot. In the injury of the post-tibial ligament leads to the flat foot. Arches of the foot. When segmented structure supports the weight if it is built in the form of an arch. In the foot, there are three arches: medial, lateral, and the transverse arches. The medial longitudinal arch. It is formed by the calcaneum, thallus, medial cuneiform, and first metatarsal. The key bone is the head of the talus. It is established by the static and dynamic forces. The static is shape of the bones and the spring ligament in the plantar arch. Dynamic is tibialis posterior. And it forms a Meyer's angle, that is, the long axis of the first metatarsal and the long axis of the talus are parallel to each other. They form a 0 degree. But in case of flat foot, when due to the sagging of the talus downwards, this angle becomes ever in negative direction. Calcaneal pitch is it's an oblique inclination of the foot, which also decreases in the flat foot. Lateral longitudinal arch. It is formed by the calcaneum, cuboid in the 4th and 5th metatarsals. It is supported by peroneus longus and brevis. This lateral arch is less adjustable than the medial longitudinal arch. Transverse arch. It is formed by cuboid bone, 3 cuneiform bones, and the base of the metatarsals. Here the key bone is intermediate cuneiform bone, and the distal it is formed by the heads of the metatarsals. Tripod foot. The weight bearing areas in the foot are 2 in the head of the metatarsals with 1 at the heel to facilitate the weight balance in the foot. Altered tripod mechanism produces pressure points, callosities, and the ulcers. Coming to the movements: inversion, inside movement; eversion, outside movement of the subtalar joint. Supination. Supination is a combination of plantar flexion, inversion, and adduction at the different joints. That is, in pronation, dorsiflexion at the ankle joint, eversion at the subtalar joint, and abduction at the forefoot. Supination twist, that is, inside twist of the foot. It produces ATFL injury and CFL injury. Supination with external rotation causes, in addition to the ligament injury, produces fractures. We have type 1 and type 2, that is fractures of the fibula at the level of the syndesmosis and below the syndesmosis. Pronation, outside pronation twist, outside twist. In this, there is a deltoid ligament injury. In pronation, external rotation injury, there is deltoid ligament injury. Along with this, we have type 3 fractures, that is fractures of the fibula above the level of the syndesmosis. Other movements, open chain movements. This is non-weight bearing when the patient is not walking, non-weight bearing movement. In this, calcaneum moves on the talus, whether it is supination or pronation. Closed chain movement, that is when the patient is walking or the foot is on the ground. In this, talus moves on the calcaneum. In the gait cycle, the closed movements are when the foot is flat on the ground, it is supple. The mid-tarsal joints are unlocked. The talus goes into internal rotation and the tibia goes into internal rotation, but calcaneum is everted. These are the foot movements. And when heel goes to the rise, in late stance phase, foot becomes rigid due to the contraction of the mid-tarsal joints and they become locked. Talus and the tibia goes into external rotation and the calcaneum goes into inversion. With all these functions, to conclude, foot functions are, it adapts to the different surfaces and uneven terrains. It provides stability and base for the locomotion. It acts as a shock absorber through its flexibility. At the same time, it forms a strong lever arm during the push-off phase of the gait cycle. Thank you. Thank you.
Thank you, sir, for very informative talk. Now I invite Dr. Shikruda to give a brief introduction about Dr. Rahul Upadhyay, sir.
Dr. Rahul Upadhyay sir is a consultant in orthopedic and foot and ankle reconstruction at Rajasthan Hospital, Jaipur. He is the only qualified foot and ankle surgeon in Rajasthan, has over 10 years of clinical experience and has trained from top institutes in country and the world. He did his MBBS in 2008 from Stanley Medical College, Chennai, in Tamil Nadu. DNP in 2014 from Indian Spinal Injury Center in New Delhi. Did his diploma in orthopedics and traumatology in 2014 from Sickert, Belgium. Did his fellowship foot and ankle reconstruction 2016 from Tanto Singh Hospital, Singapore. Is a founder secretary of Jaipur Foot and Ankle Society, executive committee member of Indian Foot and Ankle Society, executive member of the Sickert International Foot and Ankle Committee. Thank you, sir.
Now I invite Dr. Rahul Upadhyay sir for his lecture on clinical examination of foot and ankle.
Good morning, everyone. I would like to thank the Warangal Orthopaedic Society, especially Shirish and Dr. Srinivas sir for giving me this opportunity. So for clinical examination, I suggest rather than going for the slide presentation, may I have a postgraduate to volunteer and please come over the stage so that we can do a live clinical demonstration. That will be more useful. So anyone to please volunteer, any of the postgraduates to please come. I mean, I'll be doing examination. You don't have to do anything. You just come and stand here.
You have to tell them clearly, you're not examining them as you'll be examining their feet.
I will be examining. You don't have to do anything. Right, thank you so much. So, we'll be having this examination for just for 15 minutes. So 5 to 7 minutes we'll spend on how to do the basic examination about the inspection, palpation, and then a couple of specific diseases or the conditions that presents in the OPD clinics, which are very, very frequent, so how not to miss them. As much as the need possible. Okay. Yeah, when you just stand. Yeah. So we'll start with the examination. The minimum basic is that the patient's knee should be exposed. So that is how we will start, and we'll make sure when we are trying to examine the patient, his knees are at least exposed, from knee to ankle and everything should be exposed. And if we can have a more exposure to the upper joints, it is even better, but that's the minimum. As the patient walks into the clinic, we have to start by understanding his gait. So we'll not go into the detail because Dr. Prakash has already explained a lot about the gait cycle. So we'll just look at the patient's gait specific to the ankle. We'll just make sure if it is a high stepping gait in case of a foot drop, it is an antalgic gait. So that is the first thing. Now important part is inspection. So we have to make sure that we see this patient from front, from side and from back. We don't miss from any side. So in inspection, what are the important things we are supposed to look? So we have to look for the first, the bulk of the muscle. If he has any difference between the bulk of muscle on the both sides, affected side is large, affected side is small. You look for the skin. If it is fine, if it is red, swollen, if you look for any scars, any sinuses that are present over there, you look for any bulging veins are there or not. Then you look for any obvious deformity is present in the ankle or not. If there is any obvious deformity, what kind of obvious deformity that you can see? So when you are looking from the front, yes. So when you are looking from the front, you look whether the alignment of ankle is well aligned with the tibia or not, whether there is any deviation in varus or valgus planes, whether the arch support or the medial arch is obliterated or not obliterated. whether there is deviation of the toes, whether the foot is plantigrade or not plantigrade. So these are the obvious findings which you can easily see. Apart from that, if you could see any obvious swelling over the foot, whether there is anterior swelling, there is a medial swelling, there are bony prominences that you can see. So you just have to highlight that. Just to give you an example, in case of a flat foot, you will see that the medial arch is completely collapsed. You will see that the forefoot is abducted, it is externally rotated. If it is an os navicular, you will see that there is a prominent navicular bone on the medial side. So this will give you some idea. Then while we have already taken the history of the patient, he has already told you where exactly is the site of pain, whether he was a diabetic or non-diabetic. So that was the background history that we have taken. And we have to correlate the history with the clinical examination. So once you are seeing from the front, you have observed all these clinical findings from the front, you ask the patient to stand on the side. So can you face that side? Yeah. And take 1 foot back. 1 foot. Yes. So 1 foot at a time we will examine. So if you want to examine left foot, first from the medial side. Now again it is very easy to differentiate whether the arch is normal or arch is not normal. In case of a collapsed arch, you will see that the entire medial space that is present will not be there, it will be obliterated completely. So you can see that is very easily visible from the medial side. Now in case of a cavus foot, the same arch will be increased. The patient will have a higher arch on the medial examination. Now you ask the patient to turn back. So if you could look on the side. Yeah, thank you. Now from behind, you will again examine this patient. You will look at the bulk of the calf muscles. You will look at the alignment. Also, now that is very, very important that you look for a few special signs from behind. You look at the heel valgus and heel varus. These are two very important things that are going to guide us about various pathologies which are associated with foot and ankle. The most common pathologies that walk into the clinic are usually a flat foot which will present with a heel valgus, or a cavus foot which will present with a heel varus. Now, normally if you see up to 0 to 6 degrees is a normal acceptable angle. Anything more than that is very clinically evident in case of a valgus foot. Now there is a certain thing called as a too many toes sign. So what is a too many toes sign? If you look from behind when the patient is standing, and from behind at the level of his ankle, you have to just stand behind, you have to go down and see. If you can see more than 2.5 toes, it is a too many toes sign, which is an indicative of a progressive or a collapsing arch. Similarly, if you see a medial side, in case of a varus foot, you will see a more part of a big toe or a lateral or the second toe on the medial side. That is indicative of a varus foot. So that is important thing that you will see from behind. Okay, now turn back. So these are the important inspectory findings. Now we'll come on to the next thing, how to palpate this. Again, so when we are talking about the palpation, once you have looked for any obvious tenderness into the muscles, any tightness of the muscle compartment you have to check for, then you have to try and palpate each and every tendon. So you can make your own hierarchy as to how you want to go. You want to go from medial to lateral or lateral to medial, that is up to you. But you just have to make sure that you are able to palpate the tendons, important structures being tibialis anterior tendon, EHL, peroneal, and almost all medial is your tibialis posterior tendon. Posterior to it is your FHL and FTL. So you palpate all these to make sure if there is any tenderness on either of these tendons. So the patients might present to you, especially sports people, with a tibialis anterior synovitis that presents with that pain on the anterior medial angle. So you look for any tenderness or synovitis over the anterior medial angle, which might be significant of a tibialis anterior tenosynovitis. Similarly, we look for EHL, extensor hallucis longus, synovitis and tenderness. Look for peroneal tendons. Now the peroneal are very, very prone to get tenosynovitis, especially in cases of a chronic lateral ankle instability, in cases of unstable ankles. So you have to look for tenderness over the subfibular region, just distal and half a centimeter posterior to the tip of fibula. You have the peroneal tendons. Can you just rotate it? Okay. Or just keep this. So this is where we look at the peroneal tendons. So you have peroneus longus, you have peroneus brevis. Now how it works is that the peroneus brevis is between the peroneus longus and the tip of fibula. And in cases of chronic lateral ankle instability, there is a persistent injury over the peroneus tendons, and peroneus brevis tends to get impinged between the two, between the longus and the fibula, and it is very easily injured. So you are going to see tenosynovitis, swelling, tenderness over the peroneal tendon. Okay. Then important, just keep it back. Get it first. Tendon, one of the most important tendon to feel, to touch, and to palpate is the tibialis posterior tendon. Now, as we saw in the previous lecture, the insertion of tibialis posterior is mainly over the navicular. Apart from that, it is on the cuneiform. It is on the second to fifth metatarsals. So, feel for the navicular. Feel whether there is a tenderness on the insertion of the tibialis posterior tendon, which signifies the insertional tendinitis of the tibialis posterior. See if the tenderness is only on the insertion of the navicular or it is also going further upwards. That will tell you the involvement of the extension of the disease. If there is a tendinosis which is going further, that is an indicative of a progressive disease which might lead to a progressive collapsing foot or an adult flat foot. So that is important. Third, you have to another important tendon is your tendo Achilles. Now this is also a very frequent finding in a OPD, that a patient will come with a heel pain. Now there are multiple causes of a heel pain, and we have to try and locate each of those causes. So a tendo Achilles is an important cause of heel pain. You have to look for the insertional pain or a non-insertional pain of the tendo Achilles. So any pain within insertion to 2 centimeters is an insertion, and beyond is a non-insertion tendonitis. Look whether the tendon is directly tender over its insertion, or the pain or tenderness is between the tendon and between the posterior tuberosity of the calcaneus. If it is directly over the tendon, it is insertional tendonitis. If it is posterior to the posterior tuberosity of calcaneus and anterior to the tendo Achilles, it is a retrocalcaneal bursitis. So that is how we are supposed to differentiate between the two. So just to stress again, if the tenderness is directly over the tibialis, tendo Achilles attachment, it's an insertion tendonitis. If it is anterior to it and posterior to the calcaneus tuberosity, it is a retrocalcaneal bursitis. So this is important differentiating feature. Then in cases of heel pain, we'll be looking at the, just keep it here. Yeah. So we'll be looking at the plantar aspect of the hip foot. Look where is exactly the tenderness over the plantar aspect, whether it is medial plantar fascia, whether it is lateral plantar fascia, whether it is mid-foot over the plantar arch. Now, if it is on the medial plantar fascia, it is most likely because of the medial plantar fasciitis. If it is in the mid-foot over the plantar fascia, it could be the non-insertional plantar fasciitis. If it is on the lateral aspect, it's a lateral plantar fasciitis. Now look for any bony tenderness of the calcaneus. Usually in cases of athletes, army recruits who are running or in high impact activities, you might see a few cases of a stress fracture of the calcaneus, and in those cases we will see tenderness over the calcaneus body. So that is called as a squeeze test. You try to squeeze the calcaneus body between the two fingers and the patient will have pain. That is pathognomic of the calcaneus stress fracture. And the last to differentiate is look for any pain over the lateral calcaneus, and it might be as a result of the peroneal tubercle and the peroneal synovitis also, just below the peroneal tubercle. The other differentials may be your Baxter's neuritis, which will more present like a sural nerve pain. So that is also we have to see. The other uncommon causes may be your apachal. So now your apachal is just posterior to the tibialis posterior, and the patient does present with the FHL tendinitis or the impingement of the FHL tendon because of the os trigonum. So that is the last very uncommon cause of pain. But again, if the patient has a deep tenderness behind the tibialis posterior, inside the just above the level of subtalar joint, it might be because of the FHL tendinitis. So once we have palpated all this, we will be examining for the muscle power. And again, like I said, we have to go in the same sequence of the muscles and in the same sequence of tendons. So again, I will just examine how to check for the muscle power of the major muscles, and then we will see a couple of important tendons, and finally we will finish with the few of the important tests. I think I'll be audible like this. Yes. So, okay. So we'll start from medial, and we'll look for the muscle power of the tibialis posterior tendon. Now, tibialis posterior is a very important muscle because again it is one of the strongest inverter. It is maintaining the plantar arch of the foot, and it plantar flex the foot. So what you have to do is you have to check one without resistance, second against resistance. It is going to give us if there is a pathology in the patient. So you explain the patient what exact function he needs to do.
Okay,
I'll ask you to do this movement. Okay, to do it by you can direct with the finger that the patient is supposed to touch your finger with his toe. Just touch it. Yes. So this is a movement which is mostly because of the tibialis posterior. Now we will ask the patient to do the same movement against resistance. Now proceed. And look if the patient has any pain while doing this kind of inversion movement. If the patient has pain, it is significant of a tendinitis or a insertion tendinosis of the tibialis posterior. Similarly, we will look for the tibialis anterior tendon. Now this tendon is very easily palpable and easily reproducible when the patient is trying to contract. Now tibialis anterior is a strong dorsiflexor. It helps the patient to walk, and weak inverter of the foot. So we will explain the patient that he has to dorsiflex his foot. So take it out. Yeah. So while he is trying to do dorsiflex, the associated tendon which is also doing this work is your EHL. So we have to counter this. So what we can do is to counter this, we have to lock the foot in midfoot and then ask the patient to dorsiflex and look for the power here. The more contracted tendon would be the tibialis anterior, and this EHL is not going to function. Now at the same time you are trying to examine the EHL, you can ask the patient to do the movement against your resistance, and you can see the power of EHL, and the whole tendon can be seen visible. So this is the EHL, this is your tibialis anterior tendon. The next is the peroneal, the everters of the foot. Now that is very important function. Now you again, just like we explained him to do the inversion, we'll explain him to do the eversion. So you come here, yeah, ask him to invert. Now you see if he's trying to invert, is also doing the plantar flexion. So everter of the foot, against we will do the test against the gravity, against the resistance. Just try to invert again. Push my thumb. So this is the eversion test that we have to see. Now any pain patient has while he is trying to do this movement is indicative of the pathology of the same tendon. Now there is another way also to do this test. You can place this foot in eversion and ask the patient to keep it here while you are trying to get it back into the eversion. So this is another way to test your everters. And once you have done that, finally we have to look for the strong plantar flexion force. So we'll ask the patient to do a plantar flexion and check it against the resistance whether the force is stable enough or not. So this is the muscle power basically. The next is the important ligaments, especially the lateral ligaments. So the patients who have a history of a chronic ankle sprain, recurrent twisting of the ankle, they can present with the instability which leads to recurrent sprains which may lead to the osteochondral defects in the talus or an early osteoarthritis. So for that we have to examine that whether the lateral ligaments, especially the ATFL, CFL, are they functioning well or not functioning well. For the ATFL, there is a test called as anterior drawer test, just like the Latchman test that we do, or the anterior drawer test of the knee that we do. We have to look for the anterior drawer test of the ankle. Now there are many ways to do the anterior drawer test. The basic concept is we have to look for the ankle motives or the talus moving out of the ankle mortar is when we are giving the anterior drawer test. So for that, what we have to do is you have to stabilize the heel with one hand, you have to stabilize the tibia with one hand, and you have to do a posterior stress on the tibia and anterior stress on the heel, and look for any abnormal movement over the ankle. This you can differentiate with a big sulcus that will be formed here if the patient has a deficient anterior ATFL ligament or the lateral ligament. If there is just a minor sulcus, you cannot appreciate much movement. It's a grade 1. If there is associated abnormal movement, it is a grade 2. If the ankle literally comes out of it, the sulcus is very deep, it's a grade 3. Also look for the associated talar tilt, which is indicative of instability of the calcaneofibular ligament. So these two ligaments, they combine to give the stability to the lateral ankle. Similarly, we have to look for the medial side, which is the deltoid ligament. Now, deltoid injury is not as common as the lateral ankle ligaments, but in sports people, in the athletes, we have to make sure, because athletes, they tend to have a long deltoid injury and chronic pain because of the deltoid. So again, at the same time, you look for any tenderness over the deltoid, you look for any medial instability while you are trying to open up the ankle. So the deltoid, and just inferior to the deltoid is a spring ligament. Now, a spring ligament is a very important component in the flat foot, especially the adult flat foot. So also look for the spring ligament, which is just inferior to the deltoid.
On the right side.
Yeah. So spring ligament is just inferior to the deltoid. It is from the so if you see from the sustentaculum talae, spring ligament goes to the navicular, and you have to palpate over the sustentaculum and look for any tenderness of the spring ligament. Now, the functional movement of the spring ligament cannot be examined clinically. That can only be examined by the radiological assessment. So this is important assessment of the ligaments. After that, we have to check for few special tests. One of the most important tests is the silver skewer test, because a tight gastrocnemius is an integral part of almost all foot and ankle pathologies, be it plantar fasciitis, be it flat foot, be it metatarsalgia. So you have to look for a silver skewer test. Now, what is a silver skewer test? In an extended knee, you lock the talonavicular joint. So, in an extended knee, you lock the talonavicular joint. There are various ways to do it. Either you can support the entire palm on your forearm, entire foot on your forearm and do it, or you can hold the talonavicular joint, extended ankle, and try to dorsiflex the foot. You explain it to the patient what you are going to do. Make sure that the patient himself does not do it. So you don't have to do it, Lakshman. I'll be doing it. Just be relaxed. Okay? So I'll lock the talonavicular joint, because around 15 to 20% of the dorsiflexion, plantar flexion also takes place at the talonavicular joint. So you have to lock it so that whatever movement we are seeing is happening only on the ankle joint, and try to do the dorsiflexion. Once you reach the maximum dorsiflexion, what next you are supposed to do is you will ask the patient to flex his knee joint. Okay. Once you flex the knee joint, you will see that there is a further increase in the range of dorsiflexion. Now, any further increase of more than 5 degrees in the range of dorsiflexion is a symbolic of a tightness of the gastrocnemius muscle. Now, out of all the calf muscles, gastrocnemius is the one which crosses the knee joint. So once you have flexed the knee joint and there is increase in the dorsiflexion, it signifies that there is a tight or the contracture isolated of the gastrocnemius, which is a very, very integral part of almost all pathologies. Once you have done that, you come for the forefoot, look for the metatarsalgia if the patient has a metatarsalgia, tenderness over each metatarsal heads, and try to differentiate that tenderness of the metatarsal head from the MTP joints. In case of a metatarsalgia, the tenderness would be at the metatarsal head, especially plantarverts. So you try to look at each metatarsal plantarverts. Again, in MTP joint arthritis, the joint pain would not be at the head but at the MTP joint. Especially in a dorsiflexion, the patient might have pain because of the dorsal osteophytes in the first MTP joint arthritis. In case of a forefoot pathology like a turf toe, the pain would more be located on the plantar aspect of the MTP joint. So look whether the pain is more on dorsal aspect, or the dorsiflexion, and the tenderness is more on the plantar aspect. One more important and common pathology is a Morton's neuroma. The patient will come, he'll give a history of a vague pain in the forefoot, which gives a burning sensation, especially after walking. Drivers who are driving for a long time, they also present with such pain. Now, Morton's neuroma is a small neuritic pain because of a small nodular swelling of the plantar nerves. It is more common between the third web space, then second web space, and fourth web space. So look for a tenderness in the web space, and if that neuritic kind of pain progresses proximally when you are doing the doing the palpation of the web space. So look for the tenderness and look at the patient's face when you are doing the tenderness, whether there is any wince on it. Also, the other way to assess is this is called as a Morder's sign. So you hold the forefoot in your hand and try to compress the forefoot. So while we are trying to compress the forefoot, the neuroma, when it is compressed in the web space, it produces the pain. It is called as the Morder's sign. So you hold the forefoot, compress it, it will produce the pain, the wincing pain. It is a Morder's sign. Sometimes when the neuroma is big, it is big enough, and you are trying to compress the forefoot, you will even hear a click because of that neuroma will move out of the web space. That is called as a Morton's click. So the patient will have a Morder's click with the pain. It is a very, very pathognomic sign of a Morton's neuroma. So once we have checked Morton's, then you finish by seeing any other abnormalities. Maybe look for the sensory abnormality of the foot. So we have to examine in all the sensory branches. So look for the sural nerve, look for the tibialis anterior nerve, look for the staphnous nerve, and after the sensory examination, look for any abnormal veins, and then once you've done, you will finish by examining the knee joint and hip joint, just to make sure that the pain of the forefoot or the foot is not coming from the spine, and that is how you will finish your foot and ankle examination. Okay, thank you.
Thank you, Rahul sir, for the excellent demonstration. Now I invite Dr. Abhilash to give a brief introduction about Dr. Girish Modwani sir.
In medicine in Northwestern University in Chicago, and he has quite a good number of publications in Index Journal, about 10. He is a faculty in more than 30 national and state orthopedic conferences. He is a course director of in Indian Orthopaedic Association, Indian Foot and Ankle Society for Foot and Ankle course in Ahmedabad 2022. He is an executive committee member in the Indian Foot and Ankle Society, also an organizing secretary in the US Foot and Ankle Workshop 2019, organizing secretary in MOA Fracture Fixation Course 2022, organizing secretary in IFS Con 2023 Nagpur. He is presently the director of Civil Hospital, Narendranagar, Nagpur, and also the director of Foot and Ankle Orthocare, Ramdas Street, Nagpur. Welcome, sir. We are happy to have you here. Thank you.
Thank you, sir. Now I invite Dr. Girish Modwani sir for his lecture on radiology in foot and ankle.
Yeah, good morning everyone. Thanks to Dr. N.S. Reddy sir, Dr. Shreyas for inviting me again to the Warangal platform, and thanks to whole Warangal Orthopaedic Association for bringing me again. So my job after two fantastic lectures about the clinical examination, the anatomy, is how to execute this anatomy and the clinical examination and to find out the cause of the disease or to find out the etiology of the disease on the radiology. So in next 10 minutes we will try to understand that what is important in the radiology in foot and ankle. Many times in your x-rays this is important for the PGs. When your uncle and your auntie or anybody send you the x-ray on the WhatsApp and they say dekh ke batana kuch hai kya. This is very common. Or this sometime general orthopedic surgeon sends to foot and ankle surgeon that I have sent an x-ray to your WhatsApp, please check and let me know what is. And when you find that senior surgeon has sent me the x-ray, you see all cuneiform is normal, talus is normal, medial malus is normal. Is not like that. To make this simplified, how to go for the actual reading of the x-ray in foot and ankle, let's understand the thing. Always divide the x-ray in three parts. Always see the forefoot, then midfoot and then hindfoot. So very important is divide your foot. If you see navicular first and the calcaneum later and the metatarsal, you will miss the pathology. Otherwise you have to see it clinically and then you have to correlate with the radiology, which is ideal practice. But I am just telling you how to read an x-ray or the radiology in general. So everyone from the previous two lectures, we all are aware that the foot is made up of lot many bones and the joints. So that's why practicing the reading the foot and ankle x-rays in three parts is very important. Either you are seeing the AP view or in the lateral view. We all are aware that what is the forefoot, it is up to the TMT joint. What is hindfoot and what is the midfoot, it is up to talonavicular joint. So in between these two structures, if you find anything, these comes in that part of the foot. So here we have divided into forefoot, midfoot and let's see what is the interpretations. Three things you have to interpret. You don't say anything apart from these three things. One is how is the bones, whether there is any fracture, irregularity, sesamoids. Talk about the spaces, clear spaces. Is it joint space normal, alignment normal? Is there any angle which you want to describe, particularly in related to this pathology, and the soft tissues? Because soft tissues are also the part of the x-rays, whether it is an edema or you get some foreign body. Now the basic, these three slides are only for the PG students. Now, how to take an ideal foot AP view? Because you don't know how much, where to keep the beam and what should be the angle of the foot. So flex the knee at 70 degree of flexion, so that the foot should be touched to the beam, to the plates, and the beam of the X-ray, it should be centered at the third metatarsal. Then only it is the foot AP view. If it is anywhere in the talonavicular joint or at the MTP joint, it is not a foot AP view. It is something else. So you may miss the pathology. And what to see in the foot AP? Don't comment about the calcaneum on the foot AP. The foot AP is meant for medial forefoot, midfoot and the talonavicular joint. Only these three parts you can describe in the foot AP view. Okay. What is the foot oblique view? Same. Keep the knee in the 70-degree flexion and tell the patient to rotate the middle of the foot. I mean, the foot rotation, the eversion is possible up to 80-degree. But tell the patient to rotate in between. The eversion of the foot should be 40-degree. And the beam of the X-ray, it should be at the CC joint. Then only it is the oblique view. And why the oblique view is important? Don't comment about the talonavicular joint is looking normal, or that there is a talus fracture, or there is a medial navicular fracture. No. Oblique view of the foot lateral, the foot oblique view is for the lateral forefoot. Only comment on 4th or 5th metatarsal, or max to max 3rd metatarsal. But don't comment on 1st metatarsal if you are seeing this view. Otherwise you will do the mistakes. Or you can talk about the lateral part of the midfoot. The lateral cuneiform. So these are the things that you have to see. Now what are the things you see on the lateral view? Forefoot? No. So what to see on the lateral view? You can see this is a view for hindfoot. So talk about the calcaneum, talk about the talus, and talk about the navicular, talk about your midfoot region in the lateral view. So these are the things, these are important, that which view and what to see in that view. Harris axial view, we all are aware that this is basically to see this is a maximum degree of dorsiflexion which the patient can do, and the beam should be focused at 45 to 50 degree of subtalar joint. And this is a view to see various things, whether the heel is in varus, valgus, whether the tuberosity angulation is normal or not, and what is the sustentacular fracture, whether it is displaced, what is the alignment with the lateral joint, and about the heel height. So look for all bones in all views, but specific things in specific views. Look at all the joints, start from distal, go to proximal. This will give you the ideal reading and you can have some conclusion. So always see the DIP joint, then PIP joint, then metatarsalophalangeal joint, then go proximally and then see the Chopper's joints. So this is how you have to start your reading the X-rays. Now there are few things which are also important. There are 18 accessory bones in the foot. That is variable. Some patients have 16, some have 18. But if you don't know that tubercles or that accessory bones, you may miss with the avulsion fracture or calcification of the tendons. You may say there is a peroneal tendon calcification, or you may write this as a fracture of 5th metatarsal. She doesn't have a history of fracture, no twisting injury. She will write down stress fracture of tuberosity of 5th metatarsal. This is wrong. So that's why it's very important to know whether to correlate this thing clinically if you are finding some abnormal bones. So always try to understand about the accessory or the sesamoid bone, because there are many numbers in foot and ankle. So these are all the accessory bones. Sometimes this is many times confused with the posterior tibiotalar impingement, but they don't have any pain. Sometimes the Achilles pain or the retroclavicular bursa, many of the surgeons they say that there is some impingement. There is a big ossicle, you need a removal of that. No, it's a sesamoid. This is non-tender many times and they may not be the cause of pain. So in radiology it's very important to find out the ossicles. Okay, so don't miss this ossicle. See, this could be the avulsion fracture. Look at here, this could be the avulsion fracture of peroneal tubercle, the peroneal tendon, but it's basically os peroneum. Now the tarsometatarsal imaging, this is very important. So that is it, sometimes it's called midfoot imaging also. So the 30-degree medial oblique view, as we were discussing on the oblique view, this is very important to know what is the TMT joint. Now why I am talking about the TMT joint is because we all are talking about Lisfranc. What is Lisfranc joint? So Lisfranc joint means it is TMT joint, tarsometatarsal joints. from 1st to 5th. They allow the supination and the pronation of the foot, and they are made up of TMT ligaments, tarsometatarsal ligaments, like this. They are made up of intermetatarsal ligaments, like this, and a Lisfranc ligaments. So don't get confused with the Lisfranc joint and the Lisfranc ligament. So Lisfranc joint means 1st to 5th, and they are made up of lot of structures. What is the best view? Medial oblique view, 30-degree medial oblique view. So these are all the things which are important to us to assess about the stability of the midfoot. Why? Let's see an example here. This is the Lisfranc injury. This is a different talk. Let's see what are the radiological perspective of this injury. 20% of the injury is missed. It is the subluxation of the second TMT joint. And 50% of the patients they develop the post-traumatic arthritis. That's why it's not to be from the radiology. Radiology is very important in this injury. If you want to avoid this injury, now see the same patient who has a twisting injury. He undergone some non-weight bearing X-ray to some general orthopedic surgeon, and he thought that everything is okay. There is no problem. There is just a sprain, and he applied a crepe bandage. 15 days down the line, when he have continuous pain, they came to us. We got done the weight bearing X-ray. You can see the clear difference between the non-weight bearing X-ray where everything is looking okay, but reading of the X-ray was not, X-ray taken was not right, and it should be the weight bearing X-ray. Now what are the impact of the weight bearing X-ray? Let's see how to take the weight bearing X-ray first. Tell the patient to stand on one limb and make an arrangement like this. It hardly take few thousand rupees. Okay, so make a step of the wooden material, and these are normal the X-ray stands of all where you take the chest X-ray and all, and you make the arrangement like this. You have to rotate your beam, and the center of 3rd and 4th TMT, patient on the single limb, opposite side totally non-weight bearing. This is the ideal way to take a stress view, or the weight bearing X-ray. But these are for the patients who are comfortable. You cannot take these X-ray on day 1 of the injury. Okay, so tell the patient to be comfortable. How to take the foot AP? Take a wooden block, simple, 500 rupees, and put a cassette under it. Same, tell the patients to keep a foot straight and a beam at the center of 3rd metatarsal. So this is how you take a foot AP. Same patients 40 days down the line when everything was, it was missed on the weight bearing X-ray. Now you can see what is happening, and now you can assess what is happening at the level of TMT joint. It is basically a broken Lisfranc ligament which is now missed on the X-ray, and now you can see what is the instability going at the TMT joint. Now look at the instability pattern. Everything is disrupted from 1st, 2nd, 3rd, 4th and 5th, and that has created a cuboid fracture as well. So these all are things missed on the first X-ray, just because the X-ray was not weight bearing and the perception towards the X-ray was, towards the injury was not perfect. So a same injury 4 months down the line, everything is disrupted. Now he has entered into the space of painful midfoot instability. Always get in the weight bearing lateral views also when you are suspecting the midfoot injuries, because what is our 2 best X-ray for the foot? Foot AP and oblique. How many of us write down the lateral view on examination? After lateral view on examination, how many of the people write lateral view? No, nobody. Because it's our routine practice that AP and oblique can give us every idea. No. In the lateral view, as I said, it's for the hind foot and the midfoot. So subluxation, dorsal subluxation is very common, and that can be only picked up on the lateral view. So these are the some obvious injuries. They are the obvious injuries, and they are the subtle injuries. For the subtle injuries, you need weight bearing X-rays. Okay, this injury you cannot miss, but this injury, yes, you can miss. Our job as a foot and ankle, why we are here on Sunday morning, we want to pick these cases. These 2 cases anyone can pick. Even the X-ray technician can come to us saying that there are a lot of fracture in the midfoot, sir. Please do something. But this is our job. Lateral view, few angles, Giessen angle, Bowler angle. Now everybody is aware about these 2 angles. This gives us an idea, dimension about the hind foot, subtalar alignment, and these are usually disrupted in fractures of the hind foot, talus fracture, calcaneal fracture. We get the variations in this angle. Soft tissues shadows. These are also important. So you may find a calcification either at insertion level, non-insertion level, and sometime when you are treating a gout condition or alkaptonuria, you may have a calcification in the whole tendon. So these are also our job, to see the calcification in the soft tissue, pathological rupture. When I was putting a kick to the bike, doctor, I got some snapping sound, and what to do? And you suspect that this is a tear rupture. Can you send the patient to MRI? No, it's a useless 6,000 rupees waste. Just get the X-ray and examine the clinically. You will find equal information like the MRI. So no need. Unless you want to see that vascularity of the tendon, these are all different. And when you expose this tendon, you will find that everything is disrupted. So the big injury you can suspect on the X-ray. Okay, so soft tissue avulsion, calcification of the soft tissue, these are also important. Broaden view is important to see your subtalar joint. And why this joint is important? Because the only joint where you can see the sinus tarsi as well as your subtalar joint. So this view is very important when you are fixing the calcaneal fracture. So whenever you are coming out from the operation theatre, always see this X-ray, because this is the only X-ray which gives you the idea about the restoration of the subtalar joint and the sinus tarsi. This is a canal ke view, 15 degree internal rotation in the 75 degree beam position. This is important for the talus. This is the only X-ray where you can see the talus, like what you can see in your hand. The whole talus you can see on this view. There are few angles like hallux valgus angles, intermetatarsal angles. I will not go in the details, but these are also important. We are looking for that pathology. Angle in the flat foot. If you are new in foot and ankle, just understand these two angles. Meary's angle, I mean the angle between the talus and the first metatarsal. Any foot pathology, if this angle is disrupted, that means the foot has a problem. Any foot pathology, KORS foot, flat foot, foot drop, mid-foot arthritis, anything. If talus and the first metatarsal alignment is dropped, it means he or she has some problem. Second is the calcaneal pitch. So these are the two angles that at least to begin in the foot and ankle, you should know these two angles. There are the various positions in the ankle. Like same we have read in the foot. AP view, mortise view and the lateral view. Clear space we already Dr. Prakash have clearly mentioned that what are the clear spaces. But how to look at these clear spaces on the X-ray? And what is the important? As long as the medial deltoid is stabilized, there cannot be increase in the medial clear space, because there is a strong pull from the deltoid. But if suppose the fracture of the fibula is associated with the increase in the medial clear space, what is our understanding? That the medial pull is gone, and that indicates the deltoid injury with or without a syndesmotic injury. So the simple stress X-ray or the simple weight bearing X-ray, medial clear space widening for more than 5 mm is always pathological, and they may need surgery. They always need surgery, sir. How to see the syndesmotic injuries? Widening of the tibiofibular space, increase in the medial clear space. These are all the way we can identify the syndesmotic injuries. 3 common malalignment angles in ankle. This is called TAS, tibia anterior surface angle, tibia talar tilt angle, and the TLS. How it is important clinically? When you are having a malunited ankle fracture. Okay, so what is to know the deformity with pre-operative and the post-operative, how much correction you achieve, you want at least these 3 angles. Now here see the tibia talar tilt angle is 16 degree and here it is normal. Lateral distal tibial surface angle, so look at here, it is 104, ideally it should be around 89. How to see whether the recurvatum or procurvatum of the distal tibia? By looking at the tibial lateral surface angle. Now look at here, pre-operative it was 90 and post-operative it was 81, which is normal. So this is how you can assess whether you have done a good job or bad job. So this is how you can, radiology part in ankle instability, although Rahul has beautifully covered, but just what to see on the radiology in anterior drawer stress fluid, you can draw more than 5 mm of the talus, that means it is unstable as compared to the opposite side. CFL get given, if the CFL ligament is broken, that talar tilt test is positive, keep the ankle in dorsiflexion, tilt it towards the varus. If the talus rotates within the mortise, you can document the injury in the radiology, and post-operatively you can assess whether you have done a good job or not. Weight bearing X-ray we have already taught. These are the two X-ray which you can easily understand what is the ankle instability in a non-weight bearing X-ray on the right, and the left is the weight bearing X-ray. Send me all the questions to my email ID if you have any problem, for all PG students. Thank you so much.
Thank you, Girish sir, for the excellent talk. Now, the house is open for questions.
Any questions from the delegates? Nothing. I think everything is clear. Anatomy, Prakash, Rahul and Girish has told everything clear. So we'll...
Now I invite Dr. Rahul Upadhyay sir for his lecture on ankle fractures.
Right, so in this topic we'll talk about the ankle fractures. Now, like one of the most common orthopedic injury that we see, operate on a daily basis. And my idea is that after this talk, when most of the postgraduates, when you go home, you should be clear about one thing: what is the Lodge-Hansen classification. I think most of us are disturbed by this classification a lot, and we always tend to confuse, and we try to just remember everything about it word by word. But we'll try after this lecture that we understand the various basic mechanism of injury and how to put each injury into a specific classification. So while they are working, all the postgraduates, anyone who thinks that he is very good with the Lodge-Hansen classification, I'm very sure no one will say yes. Anyone who just wants to come up and try about, explain what is the Lodge-Hansen classification, or from there only you can tell me what are the various types of a Lodge-Hansen classification. Anyone? It's an interactive session. Come on, guys. I'll be asking you a lot of questions, otherwise I'll point out at you and I'll ask you. And they are not making your job easy, they are still doing something, so I'll keep asking. Any third years there? No third years. All second years. Alright, so like we had a start of this talk that we'll try to explain what is an ankle fracture. We'll try to understand the basic classification, how to anatomically place each ankle fracture in a particular classification, so that it helps us with the treatment, the planning of the treatment, management, intraoperative reductions of the fractures. Also important thing is to differentiate an ankle fracture from the pilon fracture. So that is also an important part, because the management of both the fractures is absolutely different. So we'll try to look at this. Okay. So this is what we are discussing. This is the objective of our talks today. You have to understand the basic mechanism of the injury, the Jensen classification, and relevant characteristics of each fracture type or each classification. So again, for any ankle injury, these are the two important forces that act on your ankle. It could be a rotational force and a bending force. Now, the rotational force travels all around the ankle. So you have to understand your ankle is as a ring. Exactly like how we learn about pelvis as a ring, ankle is also a ring which is surrounded by ligaments all around. So a rotational fracture, it breaks all the balancing structures around the ankle, whether it is a bone, whether it is a ligament. So you have a lateral malleolus, then with the lateral malleolus you have an ATFL. Then you have AITFL, which is anterior syndesmotic, you have a PITFL, which is posterior syndesmotic, then you have a posterior malleolus, then you have a medial malleolus, then you have a deltoid ligament. So this is a complete ring, and any break in this ring can cause a rotational ankle fracture. Also, we have to understand that ankle fracture doesn't just mean a bony injury. There could be an associated ligament injury, and the force has traveled in a similar fashion. Now, the bending force is a unidirectional force. It is not a circumferential force. So that is the reason why we have a different fracture patterns depending on the position of the foot at the time of injury. So again, important thing, we have to distinguish it from the pilon fractures. Now, pilon fractures are a very high velocity and axial impaction fractures. So the pilon always involves the articular surface, especially the plafond area of the ankle. So now the management of pilon is altogether different from the ankle fracture. So we will distinguish it from the pilon fractures. Again, the basic Dennis Weber classification, I'm very sure all the PGs are clear about it. Type A is a fibula fracture which is infrasyndesmotic, means below the level of syndesmosis. Type B, the Weber's type is a transsyndesmotic, means the fracture is at the level of syndesmosis. And type C is a suprasyndesmotic fracture which is above the level of syndesmosis. Now we'll try to understand these two. Now the important is the Lodge-Hansen classification. We have to understand this classification always has two words when we talk about whether it's a supination, adduction or a SAD type, supination external rotation or SER, pronation type which is a pronation abduction or a pronation external rotation. Now these two words if we see, the supination and pronation are the position of the foot at the time of injury. So that is how you will classify that supination is the position of foot at the time of injury. Next word which is adduction or an external rotation is the type of force which is applied on the foot at the time of injury. So you don't have to just try to cram up and forget whether supination was with adduction or supination was with abduction. It is a very clear. Supination is the position of the foot. Now we are trying to see these are the four types of fracture pattern that Lodge-Hansen has classified. A supinated foot. What is a supinated foot? Now you have to understand the basic difference between both the feet. So you have a pronated feet, you have a supinated feet. Now you clearly understand the supination and pronation in forearm. Just equate it with your foot. It is exactly the same position. There is nothing difficult from it. The way forearm supinates, that's the same with a foot supinates. So if you see in a supinated foot, if you have a rotational injury, which is an external rotation force, in a supination force, you think any further internal rotation force can cause much damage? No, because it is well associated, well supported. All the medial structures are lax. So any further internal rotation force is not going to damage. But an external rotation force is what is going to damage this. And now we are talking about an external rotation force. So this is from where most of the injury starts. Now the injury, it could be at the level of fibula, the injury could be at the level of ATFL, or the injury could be at the level of AITFL. So this is the initial point of injury which starts. So in a type 1, the injury is focused here at the level of fibula. In a type 2, the force further propagates, it goes behind, and it might involve the posterior part of the syndesmosis. In a type 3, it goes right to the posterior and involves the posterior malleolus. And type 4, the force has made a complete circle and it has come back to the medial anterior structure, which is the medial malleolus fracture. So that is how you will classify your SER type of injuries. In a type 1, you will only have a lateral injury. In a type 2, you will have a lateral and a posterior lateral. Type 3, you will have a posterior malleolus involvement. And type 4, you will also have a medial side involvement. Again, let us try to combine both the classification Weber with the Lodge-Hansen classification, and trust me, it becomes very easy to understand. So Weber type A is an infrasyndesmotic injury. It is always associated with a supination adduction form of injury. So Weber type A will have a infrasyndesmotic injury of your lateral malleolus or an ATFL associated. Now what happens is, the only restraining force on the lateral aspect was your lateral malleolus and the ATFL. Now once it is broken, the talus will continue to move. It will continue to move medially, it will go and it will hit the medial malleolus. Now that's a shearing force which is going unopposed, it hits the medial malleolus and it causes a shear fracture of the medial malleolus egg because this force is unopposed. So that is how the type 1 will have only this, but unopposed force will cause a type 2 fracture which will always involve the medial malleolus. So this is a supination adduction type of injury which is associated with Weber A classification. So this is a combination of it. It is very easy. It's a Weber's A classification. So you can easily classify a fracture lateral malleolus while a Weber A. With a Weber A classification, most likely you are going to have a supination adduction injury. Nothing to worry about it. Very easy. We'll go to the next slide. This is just a video which will tell you. Not there. Okay, this tells the mechanism of injury. Again, so this is how I was trying to explain you. So this is what we were discussing. It could be ligamentous injury or a fibula fracture. Unopposed force causes a shear, medial infection or shearing fracture. So this is a type A. So some of the examples of these injury. Now if you see, the shearing force sometimes lead to the intercalary fragment there. So there is always an intercalary fragment on the medial side, and once we are trying to reduce it, we have to make sure that we reduce that fragment also along this. On the lateral or the sagittal view also you see there is a medial fragment which is quite up impacted. You have to take it down. This is a type A, and if you open it, you will see something like this. Okay. So we'll move on to the next, which is the supination action. This is how typically you fix these kind of injury. Yeah. So mostly because of the shearing fracture, the medial malleolus will need a buttress plating here. We do not attempt to do a KY, TBW kind of things because this is a different fracture pattern. There's a different deforming force. You need a buttress to push this back to its normal position. Then only you will get a good reduction of this. Next we come to the supination external rotation force. Now, like we discussed, SCR pattern will always be a transsyndesmotic injury. We'll try to combine this now. So we come to the next type, which is a Weber type 2 or a Weber B. Weber B is usually associated with a transsyndesmotic injury pattern. That is, the fracture of fibula is at the level of syndesmosis. Now the force will rotate. It's an external rotation force, so it is going from anterior to lateral to posterior lateral to posterior and the medial structures. So the level of fibula fracture will tell you what kind of injury. Now we know it is a transsyndesmotic injury, so this is going to be either an supination external rotation or a pronation abduction injury. So you don't have to confuse with other Lorentzian classification. If it is a transsyndesmotic, only two variables are left with you. It's a supination external rotation or a pronation abduction injury. How to differentiate between the two? One, with the direction of force, how it has gone. Second, with the kind of fibula fracture. So now if you have a transsyndesmotic fibula fracture which is short oblique or a long oblique or even a translation fracture, it is a supination type of injury. But if it is a comminuted fibula, it is going to be a pronation kind of injury. So just focus on how the fibula is acting, how is the fibula fracture. If it is a short oblique, long oblique fracture of a fibula at a transsyndesmotic level, it is a supination external rotation kind of injury. If it is a comminuted fracture, badly comminuted fracture of fibula at a transsyndesmotic level, it is a pronation abduction kind of injury. So again, nothing much to worry about. You don't have to just try to cram up everything. Level of fibula fracture, infrasyndesmotic, supination abduction injury. Level of fibula fracture, transsyndesmotic, non-comminuted, SER type of injury, comminuted, pronation abduction injury. Okay. We'll move on to the next, which is a Weber type C. Very easy. Suprasyndesmotic fracture. Any suprasyndesmotic fracture, high level, is a pronation action rotation injury. Nothing to worry about it. So you see a suprasyndesmotic high level of injury, it's a pronation abduction injury. These are just showing how the force travels. Again, now various type of fracture patterns that we are discussing, SER fractures, these are just the examples of them. We'll move on ahead because we have to finish fast. Okay, these two important things that we have to remember, SER2 versus SER4, how to differentiate in a subtle injury pattern. So always look, as I said, 4 means the force has gone a complete circle and it has ended medially. So if the patient also has a medial tenderness, has a medial swelling, has a medial ecchymosis, it's a SCR type 4 injury. It is not SCR type 2 injury. Okay. Now coming up to the last, pronation external rotation kind of injury pattern. So you have a Weber C classification. A suprasyndesmotic level of fibula fracture is always associated with a Weber C and a pronation external rotation. Now the differentiating point is the force is starting from the medial aspect and going a rotation. Earlier it was starting from the lateral aspect. Here it starts to the medial. So we'll start with the medial malleolus fracture, then we'll have an AITFL injury, then we have a suprasyndesmotic fibula fracture, and finally a posterior malleolus fracture. So thus again the force starts and goes a full circle. Okay. Now any third year, tell me which classification is this? Very easy, pronation external rotation. Suprasyndesmotic medial injury pattern, posterior malleolus injury, it's a pronation external rotation type 4. This is what you are talking about, a PER type 4. Okay, so I hope this should be clear. Pronation abduction I was talking to you about. The videos will unfortunately not play, but you have to understand that the medial malleolus will be a small transverse fracture, but because it's an abduction injury, the fibula will have a bending force. So you will have a badly comminuted fibula fracture. So any badly comminuted fibula fracture transsyndesmotic level is a pronation abduction injury pattern. Okay. Again, when we are talking about this, a pronation abduction injury, this is one of the example where you have to do a medial fixation first and a lateral fixation later. Because it's a comminuted fibula fracture, you cannot gain the length of this fibula without you give a medial stability. So one of the only example where when you have a comminuted fibula, pronation abduction injury, get the medial stability in a medial length, it will automatically help you to gain the fibula length. Any other type of injury pattern, go lateral, get the fibula length, and then sequentially follow the course of injury. So again, as I said, a Weber A, just to finalize this, a Weber A is a supination adduction. It's an infrasyndesmotic fibula fracture. Weber B is a supination external rotation. Weber C is a pronation injury pattern. That's it. Again, sometimes when you are in a confusion, always do a stress view. So you see these two X-rays. Is this a SCR type 2 injury pattern just because we have a simple fibula fracture and slight opening of the lateral of the syndesmosis? No, because when you will do a stress radiograph of the same patient, you will get this. And this is a SCR type 4 injury pattern. So stress radiographs are very important. Girish had already explained what is the significance of stress radiograph in every situation. Only difference is such cases you cannot make a patient weight bear. So what you can do is you can do a gravity stress view in such patients. You can have a patient on the X-ray table with his foot just below the level of knee hanging in the air, and then you take the AP view with fibula on the downside. So the gravity will produce the stress and it will cause the opening and give you this picture. So gravity stress view is a very, very important test. So the take home message again is this. Okay, so the take home message is basically that we have to differentiate any rotational ankle injury or bending injury from the tibial phelon fracture, because the mechanism of injury is different, so is the treatment and fixation plan of this injury. Second, classify these injuries. Every single injury you have to classify before you go, because the rotation and the progression of force has to be countered to get your reduction. An external rotation force has to be turned into an internal rotation, then only you will get your reduction. And fix as per the fracture pattern. If you have an abduction comminuted injury, go medial first. If you have non-comminuted injury, external rotation injury, go lateral first. Thank you.
Thank you, Rahul sir, for his excellent presentation. Now I invite Dr. Girish sir for his lecture on talus fractures.
Good morning again. So in next 10 minutes now, let's learn something about the talus fracture. I'm making it more interactive rather than theoretical. So let's everyone participate about these 10 learning points about the talus fracture, and let's add your knowledge so that we can have a brief understanding about this complex injuries. So before I go, this was a wonderful memories. Just 3 months before, we conducted a IFASCon in Nagpur. This was the biggest international program of the Indian Foot and Ankle Society, and we were fortunate to have the delegates from the 18 countries and the wonderful faculties. Dr. Reddy sir is a witness. Thank you. So let's go about this injury. Sorry, I don't have an X-ray, but this is how the patient presented to me, sent by an orthopedic surgeon, saying that there are a lot of fracture dislocation. So, what should be our management in such injuries? So, he was a 35-year-old male. He had a history of trauma due to fall from height, and he presented immediately after the injury to a surgeon with a good soft tissue status. So there are no blisters, no ecchymosis, soft tissues were supple because it was a recent injury. We all know there was a quiz also, so everyone is aware about the Hawkins classification, dislocation of all the joints, talar neck as well as body fracture. So that was the reason why I kept one case, and we are extracting 10 learning points. These are not your learning point, this is my learning point. So just wanted to share that what we should understand, these 10 points in the talus. So the neck is broken, body is broken. So let's understand what are the principles. This patient came to you at 8 o'clock in night time. Okay, 8 o'clock he presented to you in a pantalar dislocation. So when to operate? How many of us wants to bring the patient immediately to the operation theatre? Immediate. Rahul, Dr. Rao, you sir. Only 3 people. Baki sab conserve karenge. You want to conserve this fracture? Or you operate tomorrow because you are lazy? Let's celebrate 8 o'clock in the night time.
No, you have to do it.
You have to do it. Okay. So 4 people, they wants to operate it immediately. They wants to bring the patient to the operation theatre. Rest of the people will operate on second day. Let's see what the literature says. If there is a frank dislocation or there is a open injury, you have to take the patient immediately to the operation theatre. Okay? Don't keep everything ready at 8 o'clock. Just try to reduce the fracture. See, this is not a definitive fixation you are doing at 8 o'clock in the night. You have to reduce the fracture and just apply a external fixator or a slab. If the fracture is irreducible, then you have to do the emergency ORF. So tell your friend that if the reduction is okay after the short GA manipulation, I'll come to the party. Otherwise, I'll not come. If the joint is reduced inside, just apply a slab or whatever you want, K wires or the fixator, but wait for the open reduction and interfixation. Don't jump in the mid-evening on the late nights. Take a help of the friend. Call your friend and keep this patient for the plan OT with every stuff ready, because you don't know which fragment will give you the problem intraoperatively. So this is the literature. If it is frank dislocation, you have to bring this patient immediately. If it is the reduction is not coming inside the operation theatre, you have to open immediately. Otherwise, you do a surgery in a plan. This is how a talar fracture dislocation, after a randomized controlled trial of 450 people, this was the final conclusion of those papers. So first learning point, LP is a learning point. Okay, so first learning point is urgent reduction is must. Okay, if there is a dislocation. If there is no dislocation, we'll go for the plan surgery. What is more important to see on the CT scan? When you send the patient for the CT scan, they give you the 72 small images. Does it make the sense for you? What to read in those 72 images? And finally you see the report में क्या लिखा है? Report. This is not an ideal way to read the CT scan. So what are important to see in the CT scan are the area of comminution. See, it is not important to see the dislocation on the CT scan. How the CT scan is helpful to us? Just see the area of comminution. Where you get more fragments, that is your approach. So if suppose you are getting more fragments in the anteromedial, your approach is anteromedial incision. If you are getting more fracture fragments, I mean the avulsion fractures, multiple bag of bones in posteromedial, you have to open through that way. So how to decide the approach? Through CT scan and through area of comminution. So second learning point is sagittal view and the axial view of the CT scan of the X-rays are very important. So how the axial view and the sagittal view are important to decide many things. For example, here, look at here, the fracture was fixed by me, and here you can see that in this view, you will find that the talus is rotated medially. So the problem here was we have not taken the proper views, and in the canal view here you can see that the talonavicular alignment is shifted medially. Also, the dorsal body malunion is very important. So because of these two malunions, talar medial malunion, I mean the varus malunion, and the dorsal body malunion, seeing these two views on the CT scans are very important. Now, how to decide the approach? Suppose if you are new for the talus and you are confused about the approaches, it is always better to take the dual approach, because that is a friend of the surgeon. It gives you the idea about anteromedial and the anterolateral structures, and that give us the 80% of the bone in your hand to do the manipulative work. So dual approach, if you try to access both the side of the bone through single approach, it increases the tissue strapping, and it is very difficult to reduce the fracture patellar dislocation through one approach. So the third learning point is dual approach is a friend of surgeon. Always approach medially as well as laterally. Medially you can do the middle malar osteotomy if it is required, or the anteromedial approach, and laterally is a standard anterolateral incision, cutting the ATFL. Cut the ATFL and stitch it, no problem. So these are the standard approaches for the complex talar fracture dislocation. When is the need of middle malar osteotomy? When the fractures are irreducible. Body fractures, when you want to see posteriorly, if your anterior talus is broken, you can do it through anterolateral approach without breaking the middle malus. But if your posterior body are injured, are irreducible fractures, you have to do the middle malar osteotomy. And how to do the middle malar osteotomy? Pre-drilling with two guide wires, and this is the osteotomy. It's very simple. There are lot many osteotomy described, but just take 60 degree from the center. This is the final this thing. There are many osteotomies described. Even the chevron osteotomy is also described. None make the difference. If you find the the comparative osteotomy, everything is same. So just make it simple. Take a central axis 60 degree. This is your axis. Mark it in the preoperative X-ray, and then you can mark on the intraoperative X-ray. Do pre-drilling with 2 wires and just do the osteotomy. Okay. Then how to manipulate this fragment? So you can manipulate this medial malar osteotomy fragment with either towel clip or with 2 sutures. You can take a ethylone or the proline and just pass through the pre-drill holes, and you can tie to the nearby skin, or I use the towel clip. It's very easy because you can see the deep deltoid. But fourth learning point is don't cut the deep deltoid ligament. So whatever the fragment you are seeing medially, it is only this structure do the closure of the osteotomy, I don't use a compression screw. I use the towel clip for the compression and use a fully threaded screws. But anyway, you can do. And this is how the fixation was done. And this is a follow-up X-ray where the things were consolidating. No sign of arthritis in the AVN. And this is how the case was completed. Now there is another case, 30-year-old male having a road traffic accident. Now here you can see whole of the talus is comminuted. And it is very difficult to fix this talus with 2 screws or the C screws. Now in such situation, particularly when the comminution is involving more than 50% of the body of the talus, always apply a buttress plate. The plate can be applied on the medial side as well as on the lateral side. There are the extra articular spaces below the malleolus, either below the medial malleus or below the lateral malleus. These are the 2 plateable area for the talus. So whenever you have a comminuted fracture, non-fixable with the screws, put a plate. And that are the only indications of putting a plate. 10th learning point and the last learning point is always keep a watch on complications. When the complication arises, whenever you have done a good job in talus, see the patient up to 10 months at least. It is only after that around 9 to 10 months you may get some complications. So at least minimum time is 10 months. Talus is a bone which has a high complication rate. So the patient education is very important. Tell them about the delayed union, non-union, varus malunion, osteonecrosis of the AVN and the post-traumatic arthritis. Talar AVN overall 31% incidence rate. What are the high risk factors? If we are dealing with the open fractures, Hawkins higher type, degree of the displacement is high and the degree of the comminution is high. Always explain to your patient that see 1 out of 3 patients they develop the talar AVN and you are in the high risk. But the timing of or if open reduction interfixation timing is not shown to be correlated. So don't jump in the emergency. There are huge number of the literature which say that even if you fix the talus after 7 days, it doesn't make the difference in terms of risk of AVN if you are fixing on day 1. Mean time of the onset to get the talar AVN is 7 months. Overall arthritis is 50%. Many times you get subtalar arthritis, but sometime up to ankle you may get arthritis or talonavicular is very rare. Thank you so much. So apology to Kamlakar sir. The organizer wants me to finish the Liz Frank talk as well. So after that you know. So I am having the continuation of my next talk. So next is to learn about the midfoot injuries. Although some part I have covered in the radiology, but let's learn more in detail about what is Lisfranc injury. And as I said that this injury is very commonly missed, 20 to 30% missed by us, and 50% of the time this injury leads to the post-traumatic arthritis. So that is the reason that we are here to learn these complex injuries. Meanwhile, we can have some questions to the previous speakers also if anybody has questions. And PGs, please don't shy, ask the questions like any. We are happy to give the answers to the silly questions also. Yeah, please. Yeah, Dr. Kamlakar, he wants to add. Can I have a mic, please?
Basically, we are taking this talus fixation. Routinely, we'll go with the canally view, where we get in 15 degrees of internal rotation and 70 degrees of plantar flexion. But that is not alone sufficient to see whether we are going into a varus fixation or not. Because the most common complication with the talus fixation is not avian. It is the malunion. Because most of the time the avian is decided when the injury happens. The amount of displacement what happens, that itself will decide what is the vascular injury going to happen. Your dissection is not going to cause much of it unless you are going into the territory of the medial gel. So the most common issue was the malunion. How to prevent that malunion when you are operating is, when you are taking the canally view, instead of alone 15 degrees, if you increase the degrees of rotation, you can know the amount of malunion if anything is happening. Because the malunion what we are seeing is on the top and most of the times the down. They can even go down also. So when you are rotating your view beyond to 40-45 degrees also, in the obliquity you will see the total curvature of the talus, whether it is running nice or not. The second point was the Saima line. The Saima line is the talonavicular and the calcaneocuboid interjunction of the joint spaces. If that should be a nice sinus curve. If it is not happening, then you are in varus. If you can avoid these two, majority of the times our talus will not be into malleable. 90% of the problems what we have is only with the malleable. Avian is what is being fed into our brains, but it is not the prime thing. It happens at the time of injury. That is done. Nothing a surgeon can do for the avian unless he goes in a very radical way all around the talus. So anything which is grossly displaced out of the ankle, then we are having that risk. But most of the times the body is like, if we have a posteromedial component as a separate fragment, it saves the blood supply for the talus. So when you fix that, you will get the blood supply from that. That is one.
Completely agree. And see, the talar malunion is very easily, if you don't want to depend on the radiology, or if you knew how to take the canal view and to interpret whether the canal view is okay, it is always better to see the dorsomedial combination. Always see in front and always put your lateral screw first in the compression manner. Don't put the medial screws, and you can see if you are getting more compression on the medial side, that means you are going into the varus. So there are many things as a surgeon, as a general principle fracture fixation protocol, you can understand that whether we are in the neutral position or whether we are going into the varus. But yes, this is valid point. Yeah. So again in next 10 minutes, let's learn about the Lisfranc injury. What is Lisfranc, which we have already gone through few slides, but is the second metatarsal base. This is basically a recess between these two Roman arches. So there is a stone, there is a Roman arch, which are made up of 5 stones, and out of these stones, second metatarsal is considered the most stable. And why it is most stable? Because it is having least motions. Also, if any injury happens, this is the area where all the injuries, where the second metatarsal base is the area which is the injury. You won't get any effect of the injury, or body try to affect this metatarsal articulation, and they try to spread the injury to the lesser metatarsal or to the medial metatarsal, but bones or the foot, they don't want to sustain the injury to the second metatarsal. The basic behind the Lisfranc injury is the injury to the Lisfranc ligament, and this is the only ligament which is a stabilizing structure between your 4 lateral cuneiform and 4 lateral metatarsal and the first medial metatarsal. So there are all intermetatarsal ligament, but the only stabilizing structure between the base of the second metatarsal and the medial cuneiform is called Lisfranc ligament, and it's considered the strongest ligament of the midfoot. Same in the ACL, you will find that the same way it starts from the posterior medial goes to anterolateral. So most often, this is the plantar ligament that provides more structure. So if the injury is happening, the metatarsal try to dislocate superiorly towards the dorsally. So this is how injury happens. So this is twisting as well as the axial loading, which allows the metatarsal to go dorsally. That leads to the injury to the Lisfranc ligament, and you get a widening of the first and the second metatarsal and the widening of the base of medial cuneiform and second metatarsal. Approximately 20% of the injuries are misdiagnosed, and they may have a potential consequences. The same X-ray which we have seen, you will not find anything here, but the 15 days down the line you will find that something is happening on the weight bearing X-ray at the base of the second metatarsal. Again, 40 days down the line when the weight bearing X-ray was done, the injury is very clear. You can see that the tarsometatarsal alignment is gone, which I am just repeating the fewer slides. And here you can understand what is the abduction injury. So all 4-5 metatarsal, they have abducted laterally, and they have created a nutcracker fracture from the cuboid. And this is how you can understand what is the degree of abduction, hyperabduction, and the twisting mechanism at the cuneiform and the metatarsal level. And 4 months down the line, same injury was not taken care. So bad midfoot instability has happened. Another case, 30-year-old male, he had some injuries almost 8 months back, and he presented to me not with any pain, but a frequent wear and tear of the sleepers. Injury happened long back. So you can see that the midfoot is going plantarly, and it is break on the plantar side, creating a midfoot induced flatfoot deformity. And here you can see that he is now walking with the midfoot induced flatfoot problem. So missing a Lisfranc have a consequences like you may have instability, you may have a planovalgoid foot, you may have a early osteoarthritis, and sometimes a chronic foot pain. They keep coming to your OPD saying that, doctor, now 7 months has been gone, but I am still having the pain in my foot. So you have tried everything, you have given immobilizers, crab supports, and various analgesics, but still the patient is coming to you with the chronic pain. So our job is to find out the subtle injuries, as I was saying, because these are the lateral subluxation which are very easy to diagnose on the X-ray. Now, how to avoid missing the subtle injuries? So here I am giving you the 7 tips. So if I'm very much guaranteed that if you go through this hierarchy and if you remember these 7 tips, I'm sure that you will not miss any Lisfranc injury. Although it's not given in any textbook, but this is how we have learned over the period of many years through the literature as well. The tip number first is never underestimate the unexplained swelling. If the patient is coming to you at the 4 weeks, 8 weeks, 9 weeks, 4 months, that if he has a continuous pain and the swelling not subsiding from the previous injury, always suspect midfoot injury. Try to inspect the foot morphology as well and compare to the opposite side. You will find that there is some deviation in the shape of the foot as well. Tip number 2, always look at the sole. So when the patient is presenting to you, sometimes we are in the hurry, we are busy in the routine OPD and we don't see the foot on the plantar side. But this is basically a collection of the bleeding coming from the midfoot. So that is called the plantar ecchymosis sign, and this is 96% specific for the midfoot injury, not specific Lisfranc. It can happen to any TMT fracture. It's just a gravity collection of the bleeding from the dorsal side to the plantar side. But there is keep a high index of suspicion. Tip number 3, don't forget to palpate the TMT joint. Tarsometatarsal joint palpation is very important when you are and Rahul has beautifully demonstrated that how to do the percutaneous percussion and the palpation of all the structures. So tip number 4, always get done the weight bearing X-rays. As you can see here, you may find nothing in this X-ray, but the same X-ray, if you see on the weight bearing X-ray, you will find that there is some subluxation. So always try to do, if you are suspecting the midfoot injury, tip number 4 is do a weight bearing X-ray. Always see a diastasis or the disruption of the TMT joint like this on the weight bearing X-rays. If your medial border of the first metatarsal is not congruent with the medial border of medial cuneiform, same with the up to the cuboid on the fourth metatarsal, you can suspect this injury. Always see the lateral view, as we were in the radiology lecture. Always see the lateral view. So these are the flex signs which are very, very pathognomonic of Lisfranc injury, and they are same like a avulsion fracture of ACL. Tip number 5: if you are not sure that whether it is subluxated or it is normal, suppose if your patient is having hallux valgus or if your patient is having flat foot, you may find widening of the first metatarsal and the second metatarsal. So you are not sure whether it is a Lisfranc injury or not. If you are not sure, just compare with the opposite side and see the distance between the first and the second metatarsal. Normal is 1.3. If the injured versus non-injured, if this distance is more than 2 mm, this is highly suspicious of a Lisfranc injury. When your patient is comfortable after 2 to 3 weeks of the injury, you can do the pronation abduction stress field. Now you can see you have to hold the hind foot on one side and you have to give a whole pressure, abduction force on the forefoot, and see whether you are dislocating the metatarsal, whether you are able to dislocate or subluxate the metatarsal laterally or not. Here you can see on the first X-ray, which is non-stress, on the stress X-ray, you will find that almost all metatarsals they want to subluxate laterally, and this is how you can assess the instability pattern. So tip number 7: if still you are not sure and you have a high index of suspicion, then only you go for the CT scan. Most of the Lisfranc injury you can diagnose on the clinical and the weight bearing X-rays. This is a hierarchy wise. Point number 7: if you are not sure and if you are suspecting pure ligamentous, then only you can go for MRI or the CT scan. CT scan gives us the idea about the many avulsion fractures that we were talking about, associated injuries with the Lisfranc, and MRI can help us to know whether the injury is purely ligamentous or not. And various edema pattern on the ligament can be traced on the MRI. Lisfranc is a ligament which takes 3 months for the healing. So it's not like an ankle sprain. So foot sprain are completely different than the ankle sprain. If you are having any ATFL injury coming to your OPD for first time, you can say 3 weeks to 4 weeks is sufficient for the healing. 5 weeks you can gradually return to the work. But in foot sprain, the minimum healing time is 3 months. Suppose if you are conserving a Lisfranc, 3 months is a minimum healing time, and that's why that is one of the message that don't put a K-wire or the external fixator, because you can keep the external fixator or the K-wires to fix the Lisfranc only for 4 or 5 weeks. But injury itself need at least 3 months of a static environment for the healing of for the complete healing. So these are the 7 tips. If you remember all those 7 tips, I am sure that you will not miss the Lisfranc. Now, how to manage the Lisfranc injury? First, K-wires. Many times in Nagpur, we see many times patient presented to us with the K-wire when they have been treated by the K-wires only, and now still they are having a pain, still they are having an instability. So close reduction in the K-wire fixation is definitely not a treatment for the Lisfranc in any situation except open injuries. So if suppose you are dealing with the open compound injuries, when you have a shattered soft tissue, you can stabilize your TMT joint for some time till you get a restoration of the soft tissue, or if the plastic procedure is needful. Open reduction internal fixation with the screw, for many years they were the treatment of choice, and still in the literature, if you find all the literature of earlier than 2010, you will find that screw fixation is good, but it takes 2 hours to put ideal screws across the joint. Now it's a time of bridge plating. They are the extra articular platings where the mini tiny plates into the picture. We have a workshop also. Rahul is doing a workshop on the Lisfranc, where we have a set of the few tiny Lisfranc plates which are sturdy, which can hold your all metatarsal, and we will learn that how to apply this plate to the dorsal approaches. And sometimes you need a fusion as a primary option, particularly when you are dealing with the injury for more than 6 weeks old. Treatment basically depends whether the injury is subtle or it is fresh injury. So or if with the transarticular screw fixation, as I was saying, it was a treatment of choice for many years. But then injuring the metatarsal, the cartilage again by 6 to 7% of screw damage is creating even more articular injuries. So screw penetration, and if you take a multiple entries through a obliquely placed joint, you may damage, even you can create more iatrogenic damage to the cartilage injury. This sprain itself is a cartilage injury, and creating more cartilage injury with the screw is a problem. So that's why now we have been many foot and ankle surgeons now shifting to a bridge plate or the extra articular plate, because you cannot create more injury across the articular cartilage. This is a 23-year-old male, road traffic accident, 5 days old injury, everything was okay. Soft tissues were okay, was ready for the surgery. This is what has been done outside, and they found that now see the cuneiform and the metatarsal alignment is good, but in the closed injury, as I said, K-wires are not a proper way of treatment. Here you can see the fixation has been done in the rotation, because to reduce the tarsometatarsal joint, you manipulate in the funny direction and you put a K-wire wherever you get a hole. But see the rotation. This Frank is not a hyperabduction injury. Your first TMT and the second TMT, you can rotate in any direction because you are completely unstable from the underlying cuneiform. So that's why without opening and just close fixation in the K-wire is definitely not a treatment. 80-90% of the failure rate are possible with this kind of method. So K-wires were removed, CT scan were done, and this were how the CT scan we are showing after 6-7 weeks of the injury. And this was a instability pattern. You can see even after 6 weeks of the K-wire, there were a lot of intercuneiform instability and lot of instability at the tarsometatarsal joint. So this you can see now, these are all the opening at the second metatarsal base and the middle cuneiform, and this is complete diastasis. This is how we do the tarsometatarsal fixation through the bridge plating, and nowadays various companies have launched various plates. Ultimately 2.4 or 2.7 profile is friendly for the midfoot, and with the dual 2 approaches with the gap of 4 cm you can get a good result. But again, soft tissue manipulation is very important, that we can learn from Rahul in the workshop. So this is 6 weeks, 6 months, patient is doing good, no collapse, no midfoot arthritis, and the patient is doing good. So points to remember: 20% of the Lisfranc injuries are having extension even up to the navicular bone. Don't miss the intercuneiform instability while operating. Avoid the intermetatarsal arthritis and the chronic foot pain by not missing a Lisfranc. Thank you so much.
Thank you, Girish sir, for your excellent presentation. Now I would like to invite Dr. Venkateswamy sir to give a brief introduction about Dr. Kamalakar Rao sir.
Good morning, everyone. I am delighted to introduce my friend and classmate, Kamalakar Rao Rajkonda. He did his MBBS from Kakatiya Medical College, Warangal, and also post-graduation from the same institute. He completed his DNB in 2006. He did his fellowship from Queen Elizabeth Hospital, Hong Kong in 2017, and a AO short fellowship Davos in 2018, and a Smith and Nephew Indian Orthopaedic Foundation fellowship from KIMS, Hyderabad, fellowship in arthroscopy and sport medicine at Aware Global Hospital, Hyderabad. He presented many papers in management of displaced intraarticular fractures in this method in IFASCON 2018 conference. in management of displaced intra-articular calcaneal fractures with the innovative technique of a box technique. About 40 cases he presented about top 2019 conference. Further is excellent academic. He received Dhanvantari Silver Medal paper in conference 2005 and also awarded with the second position for best paper in FOSCON 2018 and a National Faculty in Foot and Ankle Conference. Thank you.
Thank you. It's like a Spider-Man coming back home because total my education is from here and I am speaking before my professor today. So which is a bit tensy for me because even if you become a faculty, you are a postgraduate to your professor. Right? So I will be talking on calcaneum fractures. So on the lighter note, this is also known as lover's fracture. And in Telugu we can call it as Godadunkudu fracture because most of the times it is because of the fall from the height. So what are the key points to in any fracture management is first to know how is it about a bone, that is the normal anatomy. And next how it breaks, that is the fracture pathoanatomy. And next how it can be reversed, that is the reduction and fixation. Okay. So why the calcaneum is special?
So why the calcaneum is special? If you see, as already being anatomy being told about the articular surfaces and everything by Dr. Prakash sir, so I am not going much detail into it. But one point I want to tell is, if you see the alignment, calcaneum is not lying in line with your mechanical axis. Either in the coronal plane or in the sagittal plane, it will be either at the back and to the side. So which makes, if you see the alignment here, it is jumbled again. So it is either at the back or to the side. So it thoda teda hai, but it is our bone. So coming to the imaging, nicely being already told by Girish, I don't want to go much into detail about it. So but the thing is, this is the posterior facet which has to be made out in the lateral view. This is your medial facet, that is the sustentaculum tali, and this is your calcaneocuboid joint. These are the three areas which are more important for a calcaneum in terms of the intra-articular reduction. And the two angles which are normally being spoken of are the bolus and Gissane. Bolar will tell you about the depression and the Gissane will tell you about the interrelationship between these three facets which are being spoken of. And the Harris view already being discussed, and as being already told, you should not comment on a calcaneum in an AP view, but you can comment on a CC joint, that is a calcaneocuboid joint to some extent. The CT scan is the one which everybody is fond of the moment we see the calcaneum, and we try to classify based on this. So these are some fractures where we see everything is gone, but it is like trying to classify a nutcracker when a calcaneum breaks. So sometimes it is very difficult. Some fractures we can easily classify, but some fractures it will not be possible to classify them if the fracture is something like this. These videos are not playing. Yeah, if the fracture is something like this, it will be very difficult to classify where it fits in chambers 1, 2, 3, 4. So let's try to understand the pathomechanics. Pathomechanics of this understanding of calcaneum, I think most of the males will agree it will not be more difficult than this. So it may be
the most common fracture patterns what we see is either a shear fracture pattern or it is a compression fracture pattern. If you see the shear fracture pattern, when the force comes from the top, the talus hits on the calcaneum. As it is being onto one side, the force falls totally on the medial surface, the medial point just below the sustentaculum, and the fracture line crosses from the medial to anterior and to the lateral. It is an oblique line. So it moves from here to here. If you see here, it is going from down to proximal and lateral. So the ground reaction force is the next which causes it to move more up. So the moment this happens, there is a fracture over there and this is moving up, and the second impact happens on the talus. Depending on the line of this, whether it is in the mid, central or lateral, your Sanders classification will be decided. The moment we go there, the fractures happen over there and there is a depression down and this comes back. This movement of this will decide whether your sustentaculum tali is stable or not. That is a constant fragment what we will be talking about. So, and second most force, what happens is this doesn't only happen in one plane. The other plane is this even shortens it and moves laterally because of the fracture plane. So we have almost like all these deformities now. There is a loss of height, increase in the width, decrease in the length, disturbance in the posterior facet, and also increase of the outward bulge of the lateral wall. All these have to be corrected whenever you are planning to do a calcaneum fracture. So if you see here, this is an X-ray where you see the loss of height here. You can see all the forces. The sustentaculum gone down, the heel into varus and proximal migration. There is an articular depression and there is a blowout also. So these are all the deformities which have to be reversed back when we are dealing with them. This is the commonest thing of a shear fracture. The other thing is a compression fracture. Compression fracture pattern is simple. Most of us will be knowing the talus will hit on the posterior facet. Then we have a primary fracture line. If this area it is associated with the secondary fracture line which is coming up here, then it is a depression fracture. If it is going directly down and it is going back, it is a tongue type fracture, which is being explained with our Essex Lopresti fracture. This is the commonest classification which tells us about the Essex Lopresti. This is how we can just simply describe a calcaneum fracture. Most of the times they fit into it. The commonly followed, this is the Sanders classification where we see on a CT where the fracture line goes and everything. But is it more useful for us in the management? It will be only helpful when you want to see the fracture, how many lines are there, how many ought to be reduced. But coming back to the most commonly spoken is a constant fragment. Everybody wants to fix the calcaneum back to the sustentaculum tali, telling that it is a constant fragment. Why it is a constant fragment? Because if you see the ligaments, the structures on the medial side are very thick and strong compared to the middle and central. So whenever there is a depression, the talus takes the sustentaculum along with it down. And because of the strong ligament, it can move up also. Along with that, the sustentaculum comes back, but the articular depression stays back over there. So this is what is the thing. You can see the articular depression is gone down, but the sustentaculum has come back to its original position. So if this is normal, then everything can be reconstructed to it. But if the sustentaculum itself is wrong, then what? So that can also happen. We cannot say that it will not happen. So always be sure that your sustentaculum tali is in the normal position. So if you see this, whenever there is a multiple combination fragments or very small this thing, if you see the parallelity, there is a difference. That means this is not a constant fragment. This can be considered a constant. So in that scenario, you have to rectify this. Otherwise, your fixation, everything will go for a toss. So coming to the management. Non-operative management, most of us, the old school of thought was to conserve everything. But now it has moved away. Only those fractures where the articular surface is being just less than 2 mm step, or when they have a multiple comorbidities, we choose a non-operative management. But those people also, once they become fit, it is better to consider them. Why? Because this will have a decreased functional recovery, subtalar arthritis, calcaneocuboid arthritis and malleolin are all the complications which can follow. Coming to the operative management, where every surgeon is very fond of that, everybody wants to do a surgery. But the points to consider here will be the soft tissue, timing, fracture pattern, surgical approach and the patient demographics. So if you see, the aims to restore will be the length, width, height and articular. This is what I was saying, reverse engineer. The one which breaks, you come back to that. So if you see, this is one principle what I usually follow. I am not going deep into it. It's a 4-column concept. But whenever we see a fracture, if it's an open or a closed, this is where a lot of discussion happens. Even morning we was having the same discussion. The peculiarity with the calcaneum fractures is most of the wounds we see on the medial side. They are not on the lateral side. And these are like burst fractures. The force is in the vertical, it is not from the side. So whenever the burst happens, it's a sustentaculum tali and everything which blows out from the medial side and causes a wound on the medial side. So if you want to just operate it at a later date. I want to close the wound, wait for some time, let it heal and then do it will never happen. The best thing is to reduce it. The moment you reduce it, the pressure on the wound will go down and automatically you will be able to do that. So you can see this is a wound which is there. It was closable because the height was not maintained. But once this is distracted out and fixed, it nicely heals up. Because these are not most of the times infected. These are not contaminated wounds. These are blowouts. Comes next is how to decide. So overlying soft tissue and the timing of surgery, surgical decision, when to go in. When to go in. All the time we are being taught that all the calcaneums have to be waited until 14 days, we have to get a wrinkle sign, then you enter in. So that concept is slowly shifting here and there. So if you see a case like this case we cannot wait because there is a pressure on the back. It might cause a trouble. So it is always better you reduce it and fix it back. Otherwise the skin over there might be having a trouble. So but sometimes we will see cases like this where there are a lot of blisters and everything. So these cases you have to wait. Otherwise if you have a mistiming then it will be a problem. So a small tip whenever we are going for a extensile approach, because it is being spoken about but lot of wound issues and everything. If you see this, there is a incision line over there, right? This branch of a peroneal artery, this is the one which supplies most of them. If your incision falls over there, you are injuring that. Then that is the reason where you get a lot of necrosis and everything. So your incision should be as posterior as possible, near to the tendoachilles, and then go down along the junctional part and lift everything like a single flap. So that is one thing. And in the sinus tarsi, you have a freedom of going layer by layer because you have to protect the sural nerve. How does the sinus tarsi differ from ELA? Because these two are the main things which are being more spoken of. The simple way I want to keep it is, you see that is an ELA where he is coming from there, and that is the articular surface, and this guy is a sinus tarsi. Directly attack the articular surface, it is simple. And the rest of the reduction is done through an indirect means. So coming to few fracture patterns, I just want to show quickly. So this is like a SX slope test, everybody knows that. We want to reduce it, we just put a K-wire here, reduce it and put screws over there. But what is the sequence of the screws? If you put a first screw here, then the problem is you are compressing the articular surface and there may be a problem. So always try to put this screw first, this and then this. This should be just a supporting screw because you cannot compress it there. You want that height to be maintained. Because if you see here the stress distribution pattern, this tells us everything. This is all the tensile trabeculae. This is the TA which pulls it up and it goes down. So you have to counteract this tensile trabeculae. So that is the line, it should be perpendicular to that. So when you go exactly in that way, this is the way we can fix it up. So the second thing is joint depression types. Most commonly seen are joint depression types. If you see back the same tensile pattern, if you see this is a tensile, compressor, and this is the zone which usually gets depressed inside. So when you are doing that, that has to be supported. This is the zone which drops back. So when you are doing the fixation, you try to fix it with this thing, and a supporting subchondral screw is there back, so your articular surface will be stable. You don't need to do anything extra over there. The type, this is the most commonly seen, all the deformities are present, so where we need to fix it, you can go with an SLA, ELA, whatever approach you want, and you can fix that one. So sometimes we see something called as the medial combination. Everything we go from the lateral, extensile, sinus tarsi, everything is from the lateral. Suddenly if you see a medial combination, what to do? So this is one example where you can see the articular surface is fractured totally medial and it is down on the medial side. This cannot be attacked from the lateral. And some things like this, where we have a CT, there is an impaction on the medial side, combination, everything is there on the medial side. If you go from the lateral, even a ELA, STA, nothing will help you. And this is another case where the lateral wall looks to be very good, but the medial total is gone. So these cases we need to go medially only. You cannot go from the other side. And this is one more area where the sustentaculum fracture is there. So all these things we have to approach from the medial. So think out of the box and go on from the medial side. So here we need to go through the medial and then fix them with the two blades. So what are the medial approach? How will you go? This medial approach is this a simple medial malleus, navicular. If you draw a line from here and here, this is the junction will be a sustentaculum tali. So you need to be 2 centimeters behind, and here there will be vessels. So just go behind the vessels, pull the vessels totally to the anterior. And this is the area where it is being opened up. And this is the fracture you can see there. You can reduce it nicely. If you want, you can put a plate there, or you can put a screw from the other side, and you can go back to the lateral and finish the rest of the thing. This is one way. The other way is a McReynolds approach. In the McReynolds approach, it is a straight incision over the sustentaculum thalli, where you can even fix the sustentaculum thalli. The vessels are being retracted here out, where you can extend your incision more anterior and go forward to fix it on the medial side. So sometimes we see these cases also. These are like a nutcracker where everything is gone. So here you can do anything. So most of the times they say that you go with a ELA, fix it to a reasonable reduction and do something, or go for an arthrodesis, leave it and take a second step. But either ways, it is the best thing. Get whatever is near normal and then keep it ready. But the literature, what it was saying is, even if you do an arthrodesis or this, getting a decent reduction might pull time for him. Sometimes they may not come back to you for the arthrodesis also. So always try to fix them to whatever extent you want. The calcaneal cuboid joint, this is one most commonly missed and we even neglected. But if you see clearly, there is a type 3 lateral talar process, calcaneal process fracture with a depression over there, which should not be left over. And this is the other one where it is associated with the regular calcaneum. So most of the times our fixation ends at the posterior fascia. Never end your fixation only for the posterior fascia. It has to be extended onto the calcaneal cuboid, check the joint and keep it back in position. So this is a simple algorithm what we can follow for the calcaneum fracture, just for this thing. And one more thing is the anterior process fracture, which is being commonly neglected, whether it is displaced, not displaced, depending on that it can be type 1, 2, 3. Type 3 always requires a open reduction, but type 1 and 2 can be managed conservatively. If it doesn't work, then it can go for an excision. So what if we left it? Suddenly a patient comes with a malunion. So what we are treating here? So calcaneum is already united. Why we should treat it? The patient might be having some pain, but he will be happy. But if we compare both the things, the thing we can see here is the talus is not in correct position. This fellow will always limp. His limp is only because he will not have a complete excursion of his ankle joint. The dorsiflexion will be automatically restricted. Someday, because of this calcaneum, his ankle is going to go for a toss. Because the talus will not be straight, it will be tilted back, front or somewhere, and then it will have a trouble. But is it? What is the next solution? Everybody would suggest that go for a fusion over there. Are we treating the fusion for sake of subtalar pain, or we have to do anything extra to save this ankle also? That is a small difference here. So all the time try to save the ankle, not only this. Here you can go with an extensile approach. See, now you can see we have put a thick graft over there. This has to be placed so that it can come out, and all the deformities which are left over being rectified and put it back in position. And your talar declination is back. This will increase his dorsiflexion, this will increase his walking power, and his gait will also go back. So this is a similar thing, but this is having a tongue type. So the same thing was done, but here we plan to do an osteotomy to get this tongue back. Otherwise this pressure will be continuing on him and it will cause a trouble to him. So the same extensile approach, did an osteotomy, got it back in position, fused that ankle. So some of the atypical fractures, what we will be commonly missing is a stress fracture. This has to be always keep in the back of mind, and a sustentaculum fracture is the one. The take home message, they are always challenging to treat the calcaneum fracture even today, but operative approach always gives a better results, provided the wound complications have to be keep in the back of mind. No single approach fits all the fracture patterns, it has to be tailor made, and always the options depends on the surgeon's choice, the patient's comorbidities, and what the soft tissue is telling. Sometimes it pretends to be very simple, but be careful, it can be dangerous.
uncommon fractures that we mostly tend to treat conservatively. So these are the fractures we mostly tend to fix conservatively. So my idea from today's talk is just to have a basic differentiation when to fix and when to conserve. So because most of the fractures, yes, definitely can be treated conservatively, but those which cannot be, which should not be, and when they are treated conservatively, they have a very drastic outcomes. So we'll go one by one. We'll talk about the metatarsal base fractures, then we'll talk about the shaft fractures, then we'll talk about the metatarsal neck fractures and the head fractures. Again, we'll go case based. I'll try to explain, taking examples of certain cases where the fixation is must. The rest of the cases we can go with a conservative management. So the biggest question is metatarsal base fractures, when we should be fixing it. So any intra-articular and a comminuted fracture of the base of first metatarsal. Now it is very, very important that first metatarsal and rest of the metatarsal, they are two different entities. We will discuss, like Girish was explaining in his slides, and also Dr. Prakash was telling that in a foot, the medial column is a rigid part of the, the flexible part of the foot, whereas the lateral column is a rigid part of the foot. So we'll go with this. So we have a concomitant Lisfranc injury, we have associated ligamentous disruption, and we have open fractures. So all these fractures, these are the situations where we have to fix the base of first metatarsal fractures. But if we have any stable fractures, we can still conserve. So all these metatarsal fractures, if you see, these are metatarsal fractures, but these are stable fractures, and we can easily conserve them with a below knee cast, with a walking cast. Even when they are very stable fractures, stress fractures, they are not displaced on a stress view, we can even give them a walking cast. But when we don't conserve them, there are certain cases, like this is a 34-year-old male who has got a fracture of base of third metatarsal. Now it seems to be a very subtle injury. It seems that there is nothing wrong with this. So we are going to treat it conservatively. Whereas this is again a 28-year-old male. He also has a base of third metatarsal fractures. But if you see, there is a displacement. Now this is where the value of a stress view and an oblique view comes. So when you take all the possible views, you will see that there is a displacement of the second metatarsal. The intercuneiform lines are broken, the tarsometatarsal lines are broken. If you do a CT scan, you see there is a displacement. It's a part of a Lisfranc injury complex, and these are the fractures that have to be fixed. So these are the fractures which need fixation. Again, one more case, a 27-year-old male. We'll try to look at various parts of this fracture. You see at the base of first metatarsal. It is a fracture of the base of first metatarsal. Is it an intra-articular fracture? Yes, it is an intra-articular fracture. And by our protocol, it has to be fixed. So this is a fracture which needs fixation. So this is how you can fix it. You can just use a CC screw, you can use plates, extra-articular bridge plates, whatever is the mode. But the basic idea is this is a fracture which needs a fixation. One more example. Again, a 32-year-old male. You see there is a fracture of the base of first metatarsal, which has led to the shortening of the base, which is again an indication it is an intra-articular fracture with a shortening of the metatarsal. It needs to be fixed, and now here we have used a bridge plate to fix this metatarsal. Bridge plate is a very good option rather, because it does not cause the intra-articular injury in an extra-articular fractures. Again, a 26-year-old male. Now if you see, this is a base fracture, intra-articular base fracture, major displacement of the metatarsal base, and this is a kind of fracture which needs fixation. So this is a part of a Lisfranc ligamentous injury, and this will need a fixation. So this is how you can fix it. You can use a bridge plate, you can use a compression screw, and associated fractures have to be fixed. Now as we were talking, the medial column has to fix rigidly, the lateral column has to fix with a KY so that it is relatively flexible. So this is how a metatarsal base fracture has to be treated. Now coming up to the metatarsal shaft fractures. When to treat a metatarsal, fix a metatarsal shaft. So it's an open fracture. It's a displaced fracture that causes a skin tenting. There is a dorsal angulation, and there is a severe comminution and shortening. These are the indications where you have to stabilize these fractures. So like something like this. Again, a 33-year-old patient, multiple injuries. It was a run-over injury. Now if you see, there are multiple metatarsal fractures, which also has a base of first metatarsal. So this in a way explains how all the metatarsals have to be treated. So we have to give a proper stability to these fractures so the soft tissue heals. You also give additional stability by the external fixators and fix all these metatarsals by the KYs. Again, this is a 24-year-old female who has a metatarsal shaft fracture. It has a significant amount of angulation. If you see, this causes the skin tenting. Again, associated injury. When we do a CT scan, we could see there was a flex sign. We need to explain what a flex sign is. It's a pathognomic sign of a Lisfranc injury. So when you have an associated injury, you have to fix it. So this is how you fix it. You fix the injury, you fix the metatarsal fracture with it. Again, a 28-year-old male is a basketball player, high-end athlete. Now, high-end athlete, they are altogether different spectrum. Their demand is very high. Our purpose is to get them back to their routine activities as soon as possible. So this patient has a fracture of the fifth metatarsal shaft, if you see. There is a significant shortening of the fifth metatarsal. There is a displacement. There is angulation. He is a high demand guy. He needs a fixation for this. So this is one more indication for a metatarsal shaft fixation. Now when to fix metatarsal neck and metatarsal head? Again, if there is a plantar deviation which might cause prominence over the plantar aspect, which leads to the callosity when he tries to walk later on, it needs a fixation. If it is displaced dorsally or plantarly, causing again a skin tenting. If there is a concomitant shaft and other metatarsal fractures, it needs a fixation. So like this is an example where they had a multiple metatarsal fractures associated with head fractures of first, second, associated with a Jones fracture. So all these fractures concomitantly, they need fixation for the best functional outcome. Now if you see, there is a complete near 100% translations of the metatarsal head of second, third and fourth. Now if you look at closely at the base, even the first MTP joint, it is translated MTP, dislocated MTP. Probably there is a soft tissue impingement. So all these conditions are an indication that this needs a fixation. One more example of a metatarsal shaft. Again, multiple metatarsal shaft fractures, displacement of the second, near 100% translation. This is the fracture which needs fixation. Now, this is altogether different entity, which is a fifth metatarsal base fracture. So when to fix this? This is very important. Before that, we have to understand that just like the Lisfranc joint of the first and second, we have a lateral Lisfranc joint complex, which is between the cuboid, between the fourth and the fifth metatarsal. So this joint complex, whenever it is broken, it has to be treated with the same principles of intra-articular fixation as anyone else. So we have to differentiate it between the three. So if you see the base of fifth metatarsal, you have three zones. Zone 1 is the zone where the peroneal tendons, they come and get attached. Zone 2 is typically that you call as a Jones fracture. Zone 3 is a metaphyseal-diaphyseal fracture. They have different progression of the disease. Usually if you see, an avulsion fracture invariably can be treated conservatively. You don't have to fix an avulsion fracture. Until and unless it is associated with the cuboid intra-articular fracture, you don't have to fix an avulsion fracture. Even if it is a high-end athlete, you don't have to fix an avulsion fracture. It can be treated conservatively, and recent literature is even supporting full weight bearing in a cast for an avulsion fracture. This will heal very well with a very good functional outcome. So, when to treat is when the intra-articular fracture. Okay, just before I say this, I'll go back to this and I'll try to say that the base of fifth metatarsal, if you see, it is not articulating just with the cuboid. It is also articulating with the fourth metatarsal. So when I am talking about an intra-articular fracture, I am not just talking about articulation with the cuboid, I am also talking about articulation with the fourth metatarsal. So whenever the articulation complete is more than 30%, there is 2 mm step up in an intra-articular, like all intra-articular. Is a competitive athlete, there is a KO varus foot because it causes a chronic lateral overload. That is when you can fix it. So one of the example, if you see there is a small avulsion fracture, tuberosity avulsion, and like we said, we do not have to fix that tuberosity avulsion. But if you have something like this, a large displacement, the intra-articular fragment is going right up to the articular surface of 4th and 5th. That is where you have to put it back and you have to fix it. So this is how you differentiate between a tuberosity avulsion and intra-articular involvement of a tuberosity. Another example, if you see, this is a type 2 high-end athlete Jones fracture. You have to fix this because they are very notorious to go for a malunion. Again, now this is a zone 3. These present with the highest chance of non-union, and these definitely needs a fixation. Coming up to the phalangeal, I'll just give a brief summary. Most of the phalangeal fractures, until and unless they are presenting with more than 35 to 40 degree of angulation, dorsal or plantar, or a soft tissue impingement, you don't have to treat them with any sort of fixation. They can be treated conservatively. Plus, if they are associated with a plantar plate injury or a turf toe injury as we call, then they have to be treated with surgery, otherwise they can be treated conservatively. So the take home message is metatarsals having a lasting effect on the mobility. So make sure that there is no plantar prominence, there is no skin compromise, you have maintained the overall parable of the foot, you have maintained the stability, shortening, angulation, intra-articular step up, just like any other intra-articular fracture. If all that is corrected, you don't need fixation. If that is not, we need a fixation for the metatarsal fractures. Thank you. So I'll just continue to bug you with one more talk. I think probably this is the last of the segment. Yeah, this is the last of the session, and we'll keep it small. Talking about the chronic ankle sprain, and our idea of chronic ankle sprain is mostly revolves largely around the lateral ankle ligaments. Deltoid injuries are an entity, but we'll not talk about that because it has multiple variables quite at once. We'll just focus on very common injuries, which is a lateral ankle instability. So we'll be talking about the lateral ankle instability of the ankle sprains. Now these are one of the most common sports injuries. Rather, of late the articles are suggesting that ankle injuries are the most common sports injuries rather than the knee injuries. And the major involvement is the lateral ligamentous complex. Now what is the lateral ligamentous complex? If you see this cadaveric image, we have lateral ligament in the form of ATFL, which is the anterior talofibular ligament. We have a CFL, which is a calcaneofibular ligament. We have AITFL, which is anterior part of the syndesmotic ligament. Now these three ligaments, they constitute a great amount of stability to the lateral ankle. So if you see, there is a lot of literature on what kind of sports are associated with this. But if you, in a nutshell, we can easily say that all the high impact sports, be it basketball, baseball, rugby, badminton, tennis, they are associated with high incidence of lateral ligament injury. Also, a patient who has a biomechanical abnormality like a flat foot, excessive pronation or a hyperpronated foot, a patient with a pelvic obliquity, they are prone to get injury. A patient who, a sports injury who has improper training, whose strength and balance training is improper footwear, and a wrong playing surface. So these all lead to a lateral ligament injury. So this is again an improper playing surface, a cemented a ground where the player is trying to play. He goes, he runs, and he slips. Now, the idea is that the patient is not able to stand up after such injuries. This is indicating that injury is severe, and this cannot be neglected. Because after every injury, like for ACL, one of the important questions we ask to the patient,
Were you able to stand up after the injury and were you able to weight bear? Similar thing is in this lateral ankle injury. Was he able to stand up after the injury? Was he able to weight bear? If he was not, it is significant injury. It is a sign of a lateral ankle instability, which will be leading to a chronic instability if it is not treated. This is just like a postgraduate who had a party last night and missed the next day class. So how you started? You start with an associate, just reminding him. If he listens to him, comes back to the class regularly, it's fine. But if he doesn't, you need the professor to tighten it. So that is how we treat the chronic ankle instability. Conservative management, responds well, it's okay. But it goes again for the twisting injury, you have to fix it. So clinical evaluation, again the patient has a popping, tearing sensation. He has a pain, swelling, loss of support to the ankle, limited ROM, draw test is positive, inversion, plantar flexion and the internal rotation kind of injury history is there. It's a significant injury. Now if you see, this is what you will see in his x-rays. So these are the x-rays, you can see there is significant amount of talus tilt. And if we see, there is a significant amount of opening which suggests that there is a gross instability of the ankle joint. Now if you do a stress radiograph, so these are the stress radiograph of the same patient. So earlier we just thought it might just be a CFL injury, but if you do a stress radiograph, the ankle literally, the joint literally opens up. And the talus is coming out of the ankle joint. This signifies a high-grade ATFL injury. So there's various investigations. We can do endoscopy, tendography, USG, and MRI is your investigation of choice for this ligament. So on MRI, you may see there is a complete obliteration. Now, if you see MRI of a normal ATFL, it's like a thin ligament drawn with a line. It is hardly around 1 to 2 mm of a thin black line. But when you see just something like this, a thick band which has some amount of hyper intensity, it is a significant remodeling changes which are present. It signifies that it's a chronic ankle sprain. And the prognosis, it always depends on the primary management, how it was done. So if improper primary management leads to a chronic pain and instability in up to 32% of the patients. How do we classify? Anatomical classification is grade 1 when only ATFL sprain is there, grade 2 has ATFL with CFL, and grade 3 has even the posterior syndesmosis involvement. If we try to understand and AMS standards, ligament is stretched in grade 1, heals completely with conservative. It is partially torn in grade 2, heals very well conservative 90% of the patients. It is a completely torn ligament, high chance of failure with the conservative management. What is the conservative treatment for this? This is an acute stage, you give a rise. Again, you're casting in dorsiflexion if it is necessary, gradual mobilization, and then USG can help. But surgical treatment is needed for any unstable ankle because it gives a better long-term outcome. So one indication of a very lax ankle is if you just observe, if you just see this ankle, it will just go back medially. It's kind of flail laterally. It is indicative that there is something abnormal on the lateral aspect which is not giving you the stability. Then further you can do an anterior draw test and see how this ankle moves in and out and how the talar tilts inside the ankle mortise. So this indicates that this is a high-grade ankle instability. If you want to see on the C-arm, you can do the stress views of the C-arm and see how the talus tilts inside the mortise. So these are the patients who need the surgical repair. This is just a video of a Boston Gold repair using the speed bridge technique. So we'll not go into the how to do a speed bridge, but the idea is once we are done, we have to examine on table, look for the strength, look for the dorsiflexion, look for the peroneal tendon. They should not be moving out. So this is how things change. A preoperative talus tilt has been corrected post-operatively. Now, while we are talking about the chronic ankle sprain, one thing we should not miss is a peroneus brevis tear. Approximately 200 cases have been reported somewhere here and there in the literature, but the incidence is extremely common. And if you see with the newer literatures in the early phase which are coming up, the incidence of peroneal tear in a chronic ankle sprain is as high as 35 to 40%. So typically the patient will give a history that he has some pain over the posterior part of the fibula which sometimes goes all the way up to the knee joint. So that is what indicates that this patient might have a peroneus brevis tear, and we have to look for it.
how exactly we should not be missing this. So if it is a long standing lateral ligament instability, tendon overuse means the patient is an athlete, is a high impact player, or if he has a cavo-varus foot, sometimes a low lying peroneal muscle belly or a shallow peroneal groove. In all these conditions he can have a peroneal tear. Multiple classification has been done, but like I was explaining to you, so the peroneus brevis tendon, it comes between the peroneus longus and the tip of fibula, and usually in the 15 to 25 degree of dorsiflexion they get impinged and it gets torn. This is the grading. In grade 1 you only have a flat tendon. In grade 2 you have a flat tendon with usually a longitudinal intra-substance tear. In grade 3 you have a bigger tears which are intra-substance and extra-substance, and in grade 4 you have a near complete tear of the peroneal brevis. So this definitely needs repair. So just an example before we finish up is a 36-year-old male professional tennis player and later a coach. Ankle pain for 3 years, 4 to 5 episodes of twist ankle in 1 year. So again we did it and we saw there was if you see there is a hyperintensity in the peroneus brevis tendon all along its course. And before just one more important thing is sometimes the MRI they tend to miss the a chronic ankle instability, especially a peroneus brevis tear. So clinically, if we are suspecting that it is a chronic peroneal brevis tear, MRI is saying there is a no tear, it is a very good idea to go out for a dynamic ultrasound. While you are doing a dynamic ultrasound, the radiologist will try to move the ankle, he will try to move the tendon will come in and go out of the groove, and we can see if there is an associated tear. So it counters that magic angle effect of the MRI, and it is a much better modality to tell us about the peroneus brevis tear. So if it is there, you have to change your even the incision, because at that time you have to not just repair the ATFL, you also have to repair the peroneus tendon also. And if you see, once we have taken out the tendon, such a long tear inside the tendon of the peroneus brevis. This is a very, very common finding. We cannot just miss it. And so we take out any extra or a degenerative ligament, and we did a tubularization of this. Tubularization means we just make it like a round tendon again from its flattened tendon, and we sew it just like a rope. So this is for the tubularization. Then we go ahead with the non-weight bearing protocol. Exercises after 2 weeks, and after 8 weeks we go ahead for the strengthening exercises. So this is after 3 months that patient can go back to the all high impact activities. So the point to note is that you have to have a high index of suspicion when we are dealing with any chronic ankle laxity. Detailed evaluation. Always and always look for a peroneal. Dynamic USG is a very, very good tool to assess this. And before we finish this, in a chronic ankle instability, also make sure that we rule out other instability or other signs which mimic this. Something like is like a chronic exertional compartment syndrome. The patient has chronic pain over the lower tibia near the ankle joint, and it is different from the medial tibial stress or the shin splint. So we always look out that whenever patient runs, it's usually an athlete, there is an increase in the compartmental pressure, the calf muscles they swell up, and that intraosseous pain and the pressure they radiate all the way down to the AITFL, and the patient presented with pain. So you have to differentiate it with that, but commonly we'll just focus on the ankle instability and these two ligaments, and make sure we never miss a peroneal while we are evaluating a chronic ligamentous case. Thank you.
Thank you, Rahul sir, for the excellent presentation. Now I kindly request Dr. Srinivas Reddy sir to take the floor for a few minutes for inauguration and live plan.
Now the inauguration of
राजश्री सोल से सारे अपडेट्स पाने के लिए बेल आइकन दबाइए।
या कुन्देन्दु तुषारहारधवला या शुभ्रवस्त्रश्वेतपला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्मविचारसारपरमा आद्यां जगद्व्यापिनीं वीणापुस्तकधारिणीम् अभयदा जाड्यान्धकारापहा हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थितां वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदाम्
अशोक सर
Sir, please. Friend, sir. Please.
Okay. Okay, sir.
So what are your plans now?
Sir, actually, I'm working for Indian Passport.
objective evidence. So next is a stress fracture. These also can be made out from the simple X-rays, or any neoplastic or lytic lesions can be made out in the radiology. So what is the advantage of a weight bearing X-ray? One I already told regarding the fat pad. The other is seeing for the sagittal alignment and the coronal alignment. Why is this important? Because whenever we have this says that there is an input equinus which causes the type excessive stretch on the medial band, which can also cause the this thing. So this is how it is being explained out. I'll go more detail into it.
Plantar fasciitis may be the most common cause, but it's not the only cause. And a systematic approach to differentiate the cause of pain is needed, and a tailor-made approach should be there to attack the primary thing, not the victim. See the cause and then attack them. And majority are likely to report resolution of symptoms, because when you are attacking them, surgical management is only indicated when you have a very refractory cases. So plantar heel pain is not alone plantar fasciitis. You have to be thinking about the other things and treat the cause, not the victim. Thank you.
Thank you, Kamlakar sir, for the very informative talk. Now I would like to invite Dr. Girish Motwani sir for his topic on endocrine issues.
లైవ్ ఉన్నది, ఆడియో లైవ్ ఉన్నది, ఇంకే ఉన్నది ఎవట్రా నా అంటున్నది.
Thank you, Dr. Kamlakar, for the wonderful talk, and you have really made the plantar fasciitis talk simple, and there were a lot of learning messages from your talk. So I am going to the next soft tissue pathology after plantar fascia, and yeah, so it's basically a video presentation. These are 10 minutes only. Yeah. So what is the management of the basically Achilles tendinosis? But I am more focused on the surgical management because conservatively everybody is aware. So posterior heel pain is basically a combination of all these three problems. You never come with the single problem. Usually it's a combination of all three inflammations. What is happening here is inflammation started from the bursa, creating a bone formation, and that created the impingement of the tendon, and that actually creates a vicious cycle, causing a fragmentation, capillary proliferation, and the fibrosis, and that creates a lot of new bone formation and the soft tissue fibrofatty degeneration, and finally you get a bump kind of deformities. Various calcification I already mentioned that we can see, but in the early form the disease is limited to the soft tissue without the calcification. And the conservative treatment, we all know that the rest, immobilization, ice, heel lift, stretching therapy, as Kamlakar sir has very nicely mentioned. But this is surgical treatment is for those who have not recovered from the previous treatment. So what to do for this 43-year-old female having a Haglund deformity, not responding to anything? So these are like the 7-year-old surgery when we were a lot of extensive about the management of the Achilles tendon, but this is the principle is basically to take out the bone from the medial lateral Haglund deformity, take out the bursa, take out all the calcification from the tendon, and see whether the tendon is completely decompressed or not. But what happens if the pathology is involving more than 40% of the tendon? For example, see, if the tendon is more damaged, 56-year-old female, she has a painless limping. There is no problem regarding the pain and the swelling, but she cannot stand on the toes. Look at the difficulty in going upstairs and the downstairs. These are all the problems, particularly when the middle-aged patients come to you, when not very low demanding, it's a middle-aged patients, walking ladies, and usually they have a history of the Achilles tendon rupture long back, and they comes to you when the disease are very, very chronic and when they develop the difficulty in the gait problem. So how we treat this pathology when the problem is chronic? Best treatment is the flexor hallucis longus, and in my talk I concentrated 7 minutes on how to do the flexor hallucis longus transfer, because there is a surgery which everyone has to do. So it's very important to understand what should be our approach. So I take a paramedian approach, not exactly at the center, because I don't want the scar at the center of the heel. I take little paramedial, posteromedial, I would say. Posteromedial is wrong, paramedian. So the benefit of this approach is I don't see the sural nerve. Tendon is posteromedial and not exactly under on the midline. So I mean the FHL tendon, and here, but just after the gentle manipulation of the soft tissue, you can identify your proximal stump. Take your proximal stump. I use the towel clip, but you can use the Alice. This is how you have to lift it. Usually if you find the fatty degeneration, there's a lot of, and there's a discoloration between the red zone and the yellow zone, and you can identify, no, this is my avascular zone. And where the Achilles tendon was initially attached, the distal stump, you have to preserve it to the some quantity. Why? Because this is, it actually guides you when you are new where to put the flexor hallucis longus, which will now take up the responsibility of the Achilles tendon. Now from the demarcation of the avascular versus vasculars, you have to decide intraoperatively by yourself. Now this is my tendon which I need to compromise. If that tendon length is more than 3 cm, you cannot bring, more than 4 cm, you cannot bring back it to the heel, because you need to take out the heel. Tissues also, you need to take out the Haglund deformity, bump. So after clearing the tissue from both the sides, there is a gap of usually 5 cm when you need a tendon transfer. This is a flexor hallucis longus tendon. Immediately just anterior to the Achilles tendon, you can identify your flexor hallucis longus. You can move the great toe, identify on going towards the tarsal tunnel, so it is posteromedial. Identify the flexor hallucis longus tendon. It's a long lying belly. Move your great toe. If you are new, you can identify, no, this is the moving muscle. Don't go medial to it because there are the neuromuscular structures. Don't go anterior to it. Now try to manipulate all this work through the fingers. Don't use any substance because they are generally the degenerated tissues, and they are usually the old patients, and sometimes with the manipulation with a lot of sharp instrument you may lose the belly, or you may create a new injury to the belly. Now this is your neuroacting. I am going to the tarsal tunnel and just separating, try to get at least 5 to 6 cm of the length of the flexor hallucis longus. This is how you can approach the flexor hallucis longus. You can take a lot of strippers from the ACL set, but sometimes it is helpful, sometimes it may not be helpful. I would advise, in my old video, I would advise not to use any tendon stripper. You can just take a 15 number knife and you can cut it inside the tarsal tunnel from anterior to posterior, so that you will not have posterior to anterior. Otherwise, it may cut the other structures. In a small tarsal tunnel, there are a lot of structures. So try to keep 5 cm of the stump, because that is a tendon which will go inside your bony tunnel. So do the great toe flexion and while cutting the FHL, because it will give you more length. After cutting the flexor hallucis longus tendon, now you can take a Krakow stage, shoelace repair, or whatever you want, so that there should be a good non-absorbable tendon gripper. There should be so that you can easily manipulate the tendon. Just put a finger, try to remove the sheath from anterior to posterior part of the flexor hallucis longus. This will give you more length. Now look at the size of the belly. This is disproportionate. The flexor hallucis longus is having a low function and low demand, but having a more big belly. Why we choose the flexor hallucis longus? They have the same phase of contraction like the Achilles tendon and same length of contraction. So it's locally available, best graft. So don't take the peroneal tendon, don't take any other stuff. Use the flexor hallucis longus, take your stitch. I use the fiber wire 20 ultra weight, but you can use any non-absorbent substance, because the only job of this. Now the people have started taking the Vicryl also, 1 number Vicryl. They don't want any fiber stuff inside the tendon, so they have started using. A lot of Brazilian people, they have started using the absorbent material for this, because anyway you are putting interference through. So take the tendon with the multiple stitch like this, give the tension and try to apply it provisionally. You see this much amount of the tendon, it will go into the tunnel of the calcaneum. We want all the fixation to be done in the equinus position. How much? 10 to 15 degree of equinus position is generally okay. Now distal stump fibers, which will guide us that where you need to put the flexor hallucis longus. In general, you have to start from posteromedial, go little antero, posteromedial to anterolateral. Yes, so these are the ideal way to make a tunnel, so that See, the logic is you have to make an oblique tunnel towards the medial. So when the flexor hallucis longus will contract, it should bring the heel into varus. That same thing what the Achilles tendon is doing. So this is how you have to keep little oblique tunnel. You have to make attachment in towards varus. Nothing logic. You can, this is a theoretical like posteromedial, anteromedial, but the main thing is it should be the oblique tunnel and it should be towards the varus. This is how you need to slide it, put a one size bigger screw, or you can use the same size screw also if you have a doubt about the osteoporosity of the bone. Give a gentle traction, see whether is there any adhesions or is there any. So should be the tendon movements, free tendon movements inside the tunnel when you are fixing. While fixing, I am just using a bolster and keeping my ankle in 10 to 15 degree of flexion and just an interference screw, and this is how you can check the tension and the stability. So don't do the dorsiflexion while testing this thing. Just on the neutral position you can see what should be your tension inside the tendon. The rest of the stump you can just throw it. You don't need the proximal stump, but lot of literatures they have recently come up and they say that if you preserve that stump and if you tie in the tight position, it will maintain a peripheral heart function of the calf. So over the period of 6 months, it's completely take over the function of the Achilles tendon and it completely replaces the Achilles tendon, but still peripheral calf, peripheral heart function, which we read in 12th standard, this function is usually reserved when you preserve the proximal stump. Then gentle dressing, soft dressing and application of the slab in the 15 degree equinus position is the final, or the 15 to 20 degree of the equinus position is the final post-operative protocol. 20 degree in 3 weeks, neutral for next 3 weeks, and then you can start the passive range of motion exercise. 8 weeks down the line you can start the tiptoe ride, because there is a time when by the time the tendon and the bones are completely healed. Thank you so much.
Thank you, Girish sir, for your excellent presentation. Next, I would like to call Dr. Rahul sir for his talk on metatarsal.
So talking about the metatarsalgia, this is like one of the common diagnoses used for any forefoot pain, and let's try to figure out what actually is metatarsalgia, what can be the cause of the metatarsalgia. Going by the word, any painful condition of the metatarsal, that is a metatarsalgia. So we have to learn about what is the important history for it, how and what to examine to reach the probable diagnosis of metatarsalgia, what are the radiological investigations, what is the conservative treatment, and when do we need a surgical procedure for a metatarsalgia. Now, multiple causes, if you look at the lesser metatarsal MTP joints, inflammatory arthritis, degenerative changes, a plantar plate tear, they all are the cause of a metatarsal pain or the MTP pain. Again, the stress fracture of the metatarsal heads, periosteal reactions in response to the stress, AVN, Freiberg diseases, they are the cause of metatarsal pain. Sesamoids, again the stress response to the sesamoids, fractures of the sesamoid, sesamoiditis, degenerative arthritis of the sesamoid, intersesamoidal ligament tears, AVN of the sesamoids, they all mimic the MTP joint pain. The other causes are the soft tissue causes like bursitis, tenosynovitis, con, callosity, scars, the plantar fibroma, Morton's neuroma. So this is a long list of conditions which mimic the pain in the metatarsals, and let's see if we can come to a single diagnosis for it. The most common etiology is a biomechanical etiology. So any secondary forefoot overloading. So like when we started today's course, we were talking about the gastrocnemius to be one of the main culprit for this metatarsal pain. So like gastrocnemius is a culprit for the ankle pain, for the hind foot pain, it is a very important culprit for the forefoot metatarsal pain. So gastrocnemic contracture, because it affects the entire windlass mechanism, it causes over stretching of the forefoot. hindfoot ankle deformity, which is equinus, cavus, varus, pars planus, all the deformities which causes a overloading of the forefoot can lead to the metatarsal pain. First ray abnormalities like hallux valgus, hallux rigidus, hallux varus. All these deformities of the forefoot, especially the first metatarsal, they cause a compensatory change in the position of the second metatarsal. So if you see a long descending hallux valgus will have an overriding second toe. An overriding second toe will cause the plantar deviation of the metatarsals, and gradually the patient will come to us with the plantar callosities. So they are important cause of the metatarsalgia or the metatarsal pain. Any abnormality of the metatarsal cascade, so sagittal pain or coronal pain, whatever is deformity, sometimes the corrective surgeries for the hallux valgus, they lead to the deformity of the foot parabola, they are cause of the metatarsal pain. So if you see in the various phases, so the red is the zone which shows the maximum pressure point at the time of contact. So various phases of a gait cycle. So if you see the heel contact, there is some amount of midfoot pressure. There is very partial forefoot pressure. So a tripod, the foot works like a tripod, whereas the base of your tripod is the heel. The first metatarsal MTP joint is the longest head of your tripod, and the smaller head of tripod is the lateral part of the fifth metatarsal head. So as the gait cycle progresses, you see that the pressure distribution, it starts to go more from hindfoot to midfoot, and at the end of the gait cycle, which is the propulsive phase, you see there is a lot of stress on the forefoot. So any condition that causes that disturbance, that overloads the metatarsal head, that increases the pressure, that will lead to the metatarsal pain and metatarsalgia. So again, what are the causes? Any cause of limited dorsiflexion like Achilles tightening, tibialis anterior weakness, hindfoot varus, cavus, anterior tibiotalar impingement, which restricts the movement. This is a cause which causes an overactive extensor of the toe, distal fat movements, that decreases, leading to the metatarsal pain. Treatment: if you have a tight gastrocnemius, you do a gastrocnemius recession. All the surgical treatment comes after the conservative treatment has failed. This is very, very important. After the conservative treatment has failed, then only we go for a surgical treatment, until and unless it's an acute or a traumatic condition which will not respond to her. And we have already discussed with what are the indications of the surgery. So a gastrocnemius tightness, after the proper gastrocnemius stretching exercises for a period of 6 to 9 months, if does not respond well, we do a recession surgery. If there is an ankle and hindfoot involvement, again, if there is a limited dorsiflexion of the ankle because of probably anterior impingement, we can go for an ankle arthroscopy, do the anterior release capsulotomy arthroscopy. If there is a flat foot or a cavus foot, you have to do a reconstructive surgery of the foot. If it is an arthritic or a rigid foot, you have to do a fusion surgery. If there are muscle imbalances, then you might do a tendon transfer. But we have to understand what is the cause and then deal accordingly. Second, rocker metatarsalgia. Why it has happened is because the metatarsal heads are in a plantigrade position. So it is because the first plantarflex metatarsal, they cause a discrepancy in the metatarsal length, and they cause excessive overloading of the forefoot, which leads to the formation of keratosis or the callosities in the plantar surface, and that lead to the pain. So our treatment here is we have to change the inclination of the metatarsals here, because this is again a rigid deformity. This will not respond until and unless it is responding well to a metatarsal pad. So again, all these patients, you can do a metatarsal pad or a metatarsal bar, which is made up of a silicone or a soft sole, and if the patient responding well, you can continue with that. Once he stops responding to the treatment, you have to change the inclination. There are multiple osteotomies of the forefoot that can be done. Again, we can talk about the third rocker metatarsalgia. Again, it is in the propulsive phase, which causes the problem caused by the metatarsus adductus. If you see the metatarsal adductus causes the forefoot to go into the adduction. So there is excessive overload on the third, fourth and fifth rather than the first and second. And or for some reason, if there is no medial ray, there is a medial ray insufficiency, some congenital problem, deficiency of the first ray, they also cause a similar condition, painful keratosis, callosity, leading to the pain, and then we have to do a corrective deformity surgeries. Common pattern. Now this is very, very important diagram. This is called as a Maestro's criteria of the forefoot. Now it is not very difficult to understand. It just do not go into all the lines that we have drawn over here. Just you have to understand that the whole foot is like a parabola. So you have to see that whole foot is like a parabola. So whenever a patient is walking, he is supposed to walk on this parabola. Any condition that is disturbing this parabola is going to cause metatarsal pain. Ideally, the first and the second metatarsal head, they should either be equal, or the second metatarsal head can be higher than the first metatarsal by 3 mm or lower than the first metatarsal by 3 mm. Any discrepancy more than that is going to change this parabola. So similarly, if you see how you do it, you draw a line which transects the medial sesamoid here to the fourth metatarsal here. It's a straight line you draw, and then you measure the distance between all the metatarsal head from this line. This will guide you if there is any abnormality in the parabolic stance. Sometimes what happens is, if you see, there's a long M2, the second metatarsal is quite long than the first metatarsal. This is a deranged forefoot parabola. Again, if you see, there is a shorter fourth and fifth metatarsal compared to the other. There is a sudden drop in the metatarsal length. This is again a disturbed forefoot parabola. So this is also a disturbed parabola, and this is going to cause the metatarsal pain. So our aim in these conditions is to get somehow to this. So for this, if you have to do an osteotomy and shorten this by doing a Weil's osteotomy, it will correct the problem. Or brachymetatarsia or hypometatarsia, if you have to lengthen this either by a distraction osteogenesis or by an acute graft positioning, you can do that. But once we achieve this, the mechanical cause of pain will be gone and patient will be relieved of his pain. So again, the clinical examination for each and everything: a silver scale test, assess the genu varus, valgus, equinus, cavus, caovarus, tenus, assess whether the deformity is flexible or rigid, any ankle range of movement is abnormal, restricted, we have to assess that also. Do a good gait analysis, all the phases. If you have access to gait cycle, we can use that. If we don't have access to gait cycle, we can use the foot scan. Even if it's not that, we can make the patient walk, record that and see. Expose the patient up to the knee, making walk, record it in video and see how his gait cycle is moving and in which part the propulsion is difficult. That will help us to find out. And finally, do a neurovascular examination. Forefoot examination per se, we have to localize the exact site of pain, whether it is metatarsal heads, whether it is callosities, fat pad atrophy, any clawing claw toes or hammer toes, instability of the metatarsophalangeal joints, any neuroma is there, any disorder, previous surgeries, hallux valgus, varus. All this thing we have to see on the forefoot, palpate each and every metatarsal head, palpate each and every intermetatarsal space, look for the flexibility, look for the instability, like you look in a Lisfranc joint for a piano key sign. Similarly, you have to look for all the MTP joints. Again, standard weight bearing X-rays, hind foot alignment views, sagittal and metatarsal rectus lens you have to see. Look for MTP joint AVN like Freiberg diseases, arthritic conditions. Big toe, you can have hallux varus, hallux valgus, rigidus. Old implant impingement, you can have a cavus and pes tenus. Treatment, again we were talking conservative. Tendo-Achilles-Gastrocnemius is stretching, modification of the footwear, metatarsal pads, metatarsal bars, rocker bottom shoes. Sometimes we can give a 4-foot offloader also. In a 4-foot offloader, the whole of the weight is being borne on the hind foot. So you will have a shoe which finishes here and the entire 4-foot is offloaded. So entire weight is being borne on the hind foot. So we can give a 4-foot offloader also. Then you can give splints for the deformities. Now if they are not responding well, again 6 to 9 months of conservative treatment we have done, patients are not responding, we come to the surgical management. As we discussed, we have to maintain the parabola. We can do metatarsal osteotomy, shortening osteotomy, lengthening osteotomies. For forefoot equinus, you can do elevation of the metatarsals for the plantar flex metatarsals. First ray pathology, you can do a realignment or a fusion of the first MTP joint, or we can do a distal metatarsal osteotomies. For hallux valgus, there are series of surgeries, whatever is your choice of surgery, you can do that. Metatarsal adductus, as we were talking, was the cause of the lateral side of overloading. We can do the realignment and arthrodesis surgeries for them. Some of the examples, how you do, this is examples of a vial osteotomy where we plantar flex. This is an example of a second lesser to distal chevron osteotomy for the elevation. Then third rocker metatarsalgia for the elevation. You can do a dorsal closing wedge osteotomies. Can be done percutaneously open, that is the choice, our choice of surgery, that is not very important. Plantar plate tear, again plantar plate is a suspensory system. It's kind of a shock absorber device or the arch of the MTP joints. So any condition which leads to the tear of a plantar plate, so if you see sudden hyperextension of the MTP joint may cause a plantar plate tear, which is called as a turf toe injury in a big toe. So in a grade 1, you can see there is only slight subluxation if you try to clinically assess it. Instability is there. Grade 2, the phalanx is nearly dislocating out of the joint. Grade 3, it is completely dislocated. Grade 4 is a complete tear of the plantar plate, whereas both the overlapping of the MTP joint is present. So you have to assess with a drawer test, and finally if it is present, we can do a plantar plate repair with or without a MTP joint osteotomy. Tribal disease, again this is a spot question. It might be asked, this is a avascular necrosis of the osteochondritis of the metatarsal head. Unknown pathophysiology, metatarsalgia, usually second to third decades. Second is more common than the third. Again, offloader is the best treatment if it is in the early stages. Stage 2, we can do a Weil's osteotomy. Stage 3 and 4, we have to do a resection arthroplasty. So there are the multiple options which are present for the private disease. Morton's neuroma, again, usually in the third web space, can be in the second web space, mostly, and we can do, patient will present with a burning sensation, more on walking, more on exertional activity. Multiple treatment options are there. We can go for interdigital blocks, we can go for an excision, we can go for a conservative management. So the conclusion, metatarsalgia is a symptom, it is not a disease. So it's a broad spectrum which covers almost everything that causes a forefoot pain. Exact cause we have to find out. You have to understand the windlass mechanism, the rocker concept, and once you have reached your diagnosis, start the conservative treatment, which is focused on that diagnosis rather than just giving a plain forefoot offloading treatment. Thank you.
Thank you, Rahul sir, for the excellent presentation. Now I would like to call Dr. Girish sir for his topic on flat foot. For the topic on arthritis of foot and ankle.
As we are approaching towards the end of the first session, pre-lunch session, there are some important topics left which we are supposed to cover those topics. So coming to the ankle arthritis. So how the ankle arthritis is different than the other arthritis is very important to understand. So unlike the hip and the knee, ankle, the primary osteoarthritis in the ankle is very rare. And in the ankle, whatever we are seeing very regularly is all the post-traumatic arthritis. But we will try to understand that how the ankle arthritis is different than other joints and what is the basic mechanism behind this. There are 25% of the acetabular fracture that can lead to the post-traumatic arthritis, and the 6% of the total hips arthritis, they have some history of trauma. So as such, hip is all primary, less traumatic. If you see the knee fractures, near about 25 to 40% of the tibial plateau fractures, they'll end up with the post-traumatic arthritis. But 25% of the total osteoarthritis of the knee, they have some history of prior trauma. But now look at the ankle. More than 50-60% of the ankle plafond fracture, they develop the post-traumatic arthritis. I mean, the ankle cartilage has a very less sensitivity for the trauma. They react dramatically after the traumatic injuries. And near about 80% of the ankle osteoarthritis, they are related to the post-traumatic. Now, why the ankle arthritis or the ankle cartilage is different? So look at the property of the ankle cartilage. They have a low contact area and the high contact stress, because if you have less area, you will develop more stress according to the Newton's law. Same like the cartilage, if you see, the thinnest cartilage is of ankle. I am making it little simple. So in spite of the low contact pressure and the high contact stress, we are having very less incidence of the primary osteoarthritis of the knee. So the unique characteristic of the the unique characteristic of the ankle is it is the most congruent joint in the body. Now look at this wooden block mechanism. The talus is basically a wedge between the medial, posterior and the lateral malleolus, and it is considered as the most stable structure. It doesn't allow the contact stress to concentrate on the one part, and that's why it disseminates the stress to the whole joint. In spite of the low contact area and the high contact stress, primary osteoarthritis of the ankle is rare. Though there is a property which is called tensile fracture strength. So as we grow towards senility, as we become more and more age, our articular cartilage, it deteriorates, it degenerates. So that is called tensile fracture stress. After 40s, ankle articular cartilage can withstand even better tensile loads as compared to the hip and the knee arthritis. So the primary osteoarthritis in the ankle is very rare, unlike hip and the knee, and whatever we see are the post-traumatic arthritis. Now the ankle arthritis, as we were discussing, is the highly congruent joint. There is a uniform distribution of the load. There is a high tensile stiffness. There is a unique biochemical property also. They are very less receptors for the interleukin 1, so they creates less inflammation. There is a thinning of the thin articular cartilage in the ankle, but it has a very less reparative capacity. So because of this property of the ankle, even 1 mm of the talar shift, we all are aware that leads to 40% decline in the contact area, and that doubles the forces inside the ankle, and that is the reason that even a 1 mm of the talar shift can create a lot of disturbances, or the talar tilt can create disturbances, and patient may end up with the arthritis in 8 to 9 months. And that's why the restoration of all trimalleolar or all the plafond fractures of the ankle are very important. It's very important to get the ankle talus inside the mortise and no deformity after the fracture fixations, otherwise they may not be able to sustain the traumatic situation. So these are all the properties which we have discussed, and this is how various angle of various deformities you can see in the ankle that may lead to the early post-traumatic arthritis. So about the among the etiology of the arthritis, it is basically a post-traumatic, as we have seen, and among the trauma also it is rotational ankle fracture, which Rahul has described in his first lecture. It's considered as the most common cause of the ankle arthritis. What are the other causes? Again, the Rahul has covered the chronic ankle instability. This is also a second most common cause of the ankle arthritis. So if you don't want the ankle arthritis, at least you treat these two situations and don't miss when they are presenting to you in the initial stage. So rotational ankle fracture and the ankle ATFL chronic instabilities, they are considered as a worldwide most common cause. Among the primary osteoarthritis, usually these patients have deformity. So what are the patients comes to you where there is no history of trauma and they have an ankle arthritis? They are usually a deformed patient. Either they have a planovalgus or the cavovarus foot deformity, or they have some congenital foot deformity. They are all according to the literature. Now what are the options for the ankle arthritis? Now generally, if the ankle arthritis is limited and the deformity is present, so when the arthritis is limited and the deformity is present, the patient is young and the involvement of the cartilage is less than 30% of the total plafond, these are the patients where you need to save the ankle joint or you need to delay the fusion. by doing a procedure called supramallar osteotomy. So there are various procedures for the supramallar osteotomy. Sometimes you need a fibular osteotomy, sometimes you just need an open wedge osteotomy of the tibia. These are all completely a different subject, but we are here to consider what are the options when you have these kind of situations. So limited arthritis and the deformity, you need to correct it in the younger patients by the supramallar osteotomy. Getting back the ankle talar motives and getting back the tibiotalar tilt is the final aim of the treatment. What are the options for the ankle? Other options for the ankle arthritis when the involvement of the cartilage damage is more than 50%, and if the patient is old patients, and if the post-traumatic situations are beyond the control of the conservative treatment, then these are the cases where you need to put an ankle arthrodesis. There are again various ways to do the ankle arthrodesis, but this is my favorite procedure. I have put a 2 cancellous screw for the compression of the tibiotalar surface, and on the top of that I apply a plate, unless the local soft tissue condition is not proper. 2 main benefits: rigid fusion, early weight bearing, and this is how you can early return to your work. So this is a beautiful plate. We have this plate in the workshop also, and you can use in your patients whenever you are planning for the ankle arthritis. Various other options, as we have discussed, you can use the CC screws also. They give the equal compression but less rigidity. And sometimes when these plates were not available, we have gone for the distal radius plate, molded in such a pattern that it should hold some tibiotalar rigidity. So there are various options for the extensive arthritis, and this is the favorite approach where I put this is the dead anterior approach, where I put 2 K wires on medial side and the 2 on the lateral side, and I see complete tibiotalar surface. You need to prepare all 2 gutters, I mean the medial and the lateral gutter. But if you have an option of limited soft tissue dissection, at least prepare the medial gutter, because it has a good apposition and it prevents the further deformity creation. So this is how you can use your approach. But sometimes you need to use the different approach. For example, see the case here. She was already operated, fibula was malunited, the ankle was malunited in the valgus. So in this situation, I cannot go for the anterior approach like this. So in this case, anyway, you need to address the fibula, you need to correct the valgus deformity. So and you don't need to put the scar in all the side. Already she had a lateral scar, so we have gone through the transfibular osteotomy, compromised the fibula, used as a graft, and applied same principle like 2 cc screw, 2 or 3, and the plate application on the one side. So plate is just for the neutralization of the for the fusion, but the main fusion comes from the compression, and that's through the 2 cancellous screw. This is how you need to correct the deformity. I try to keep the ankle in always 5 degrees of the valgus, because that prevents the locking of the midfoot. Third option is by Dr. Vinod Panchbhavi. I'm basically integrating his talk also, but we have a paucity of the time, so I'm not going for the ankle replacement, but this is the options. My job is to tell the options only. So these are the options, and this is a video presentation of doing a total ankle replacement. But guys, we are on the basic platform, and just we need to understand that there is an approach, there is a possibility, but we don't have to go in this detail. Again, in the India, we don't have availability of this implant. So there are usually the good result if your patient selection is good, and this is how their patients they return to their work, and they get the benefit of the limitations of the range of motions. So these are the ankle replacement option. I will not go into details. So there are various articles which are showing that ankle replacement is an option for the patients who are more than 50 years. They have less demand, but the survival rate is 10 years. So simultaneously you have to think of the other possibilities of not having the complications of the ankle replacement. So selection of the patient is important. There are various literature where they have shown that even for 14-15 degree of the deformity, the ankle replacement is an option. But let's talk about the practical option. This is my patient where I have done an ankle fusion, and guys, this is really not a compromise. See, even after the ankle fusion, the talonavicular joint, when you have to shave the talonavicular joint as well through the anterior approach, and this is just a 2.5 months post-op, and there's a reasonable good range of motion. You can get it from the talonavicular joint. This is considered as a most reasonable option, cost-effective option, and many literatures showing that both the results are almost same. So don't jump to the ankle replacement directly. Ankle arthrodesis is not a compromise surgery at all, and there are many literature show. And this is just I am sharing a WhatsApp chat with my patient who has undergone the ankle arthrodesis for more than 2 years, and you can see that with your blessings, Preeti has completed a 5-kilometer marathon. So she has undergone the ankle fusions 2 years before. So guys, this is definitely not an option, and there are many things which you can do. Can we get a voice? So there is a very good voice. So anyway, this is really a very good video. I am not showing that this patient has undergone the ankle fusion, but this is how you can enjoy the most of the activities of your life, even in the senile age group, after doing the ankle fusion. So not a compromise. Still many activities can be done, and life is not compromised after the ankle fusion. I have seen that many of the senior orthopedic people, they explain to the patient that your movement will be locked and you have to walk like this. So they have completely wrong belief that the ankle fusion, after ankle fusion, a whole limb will become locked. Even you have a reasonably good degree of dorsiflexion and the plantar flexion. So get the right patient, get the proper surgeries, preservation of the ligaments, soft tissue, and it's get an easy one to start with. Thank you so much. Okay, so my next talk I am continuing it's a adolescent flat foot. Okay, so what to know about the flat foot? So my job is to talk about when the patient is in the adolescent age, and the Rahul will tell you about the treatment options for the adult acquired flat foot deformity. Anyways, so just understand what the patients tell to us when they have a problematic flat foot. So he's a 16-year-old guy, adolescent guy. He's coming to me saying that, doctor, I have a bad flat foot, foot pain on the sports activity. Now I want to know the symptoms of the flat foot. Any 5 symptoms. One is pain. Any 5 symptoms of the flat foot, because we are since morning. Yes, any PG student can tell. What are the 5 symptoms of the flat foot? Any PG student. One is pain. Second?
You have to point out.
Sorry?
You have to point out who should be answering.
Achha, I don't know the name. Anyway, the girl at the center. Yes, you only. So what you expect? What is the symptom of the flat foot? You are seeing after the Rahul's clinical examination that this guy have a bad flat foot. What are the symptoms you can have? What symptoms you can have? Only pain? Sorry? Restricted range of motion. Okay, wrong answer. Any other person? Adolescent guy, flat foot. Sorry? Gait disturbance.
Just walking style or excessive wear of footwear.
A 16-year-old male patient is coming to you with a flexible flat foot, having a pain on the sports activity. What are the other symptoms you can expect? Foot deformity. 16-year-old guy. You might have seen many of your relatives saying that, doctor, iska pair mere ko thoda flat lagta hai. What answer you will give to them? What the symptoms you will ask? I am sure that everyone has gone through this answer. Doctor, iska pair thoda flat dikhta hai. What are the symptoms? Yes, you. Yes, please. Pain is one, done. Pain is done. Second? Cannot run for the reduced sports performance. Yes, this is very common symptoms more than the pain. This is very common. She said the right thing. Reduced sports performance. This is first complaint by the parents. ये पहले जैसा नहीं दौड़ता और ये रामू के कंपेयर में मोनू छोटा है दौड़ने में. Yes, third symptoms. I want the third answer. All from PG guys. Yes, you please. Yeah, you. Please. What the symptoms you expect? Yes, you. Black shirt. What symptoms you expect? One is pain. Second is reduced sport performance. What complaint they can say when the foot is like this? What can happen? Can it hurts the knee also? Knee pain is the third common symptoms of the flat foot in an adolescent age. I want a fourth answer. Then I can start my lecture. Otherwise, we have to stop here. Fourth answer. What other symptoms can have? Cramps. You have heard cramps. Gastric tightness. We are learning from lot of good speakers. Cramps, gastric tightness. So these are all the important symptoms. So first important symptom is pain on the sports activity, on exertion. Second is reduced sport performance. Third is knee pain. Sometimes the patient comes to you, primary complaint as a knee. They don't have any problem in the knee. Adolescent patients. Third is calf tightness or the nocturnal cramps. And what is the fifth problem? Wear and tear of shoes. These are sometimes first complaint of the parents. That is के जूते ही घस जाते हैं बार बार. So anyway, so these are all the symptoms that you need to see whenever you are seeing the flat foot patient, and then only you need to go for the X-ray. If the patient is not symptomatic, 45% of the Indian population, they are almost 45% they are having some pes planus deformity, but they don't all doesn't need the treatment. So what are the cases where you will advise the X-ray? When they are symptomatic, when they are you are suspecting some pathological problem. So anyway, this was the X-ray of that patient, which was showing that there is a classical subluxation at the talonavicular joint. The talus is looking in the medial way, and the whole of the forefoot is abducted laterally, and you can see there is a drop of the talus, which is called loss of the Meary's angle, and the heel is in the severe valgus, is almost 20-25 degree of the heel valgus according to the tibial axis. So these are all the parameters which can give the problems of the symptoms. Anyway, you try to manage every patient with a conservative line of management, number one. When you see that there is no improvement in more than 1 year of the treatment, then these are the cases where you need to do surgery. Now, what are the things that you need to do on the surgery? The first parameter we correct is we balance the Achilles force. Now, how can you balance the Achilles force? Is by doing a medial sliding calcaneal osteotomy. So you can shift, you can do a percutaneous or a minimal invasive osteotomy from lateral to medial cut. As I use the mini saw, but you can use the osteotomes also. Shift it medially, get aligned with the tibia. Usually this shift cannot be more than 1 centimeter due to the soft tissue restriction, but yes, you can get alignment with the tibia. And the first deformity is heel valgus, which you need to correct, and this is how you get a correction. Now after the 20 degree correction to the neutral, this is how you need to fix it. This is a old cases where I have used a CC screw. Now we have used the headless screws, and this is usually the osteotomy cut, because you have to be proximal to the Achilles. This is how where the Achilles tendon is attached, and this is how you have to do the manipulative job. 1 centimeter of the shift is usually complete and usually sufficient. Now the next procedure is to control the hyper abduction of the forefoot. Now usually the adolescent or the pediatric foot which are born flat, they generally have a lateral column shortening. So in adults you may or may not require this procedure, but in pediatric or in the adolescent age, you always 100% you need this procedure, that is called Evans procedure, where you can see that the whole of the shift of the talonavicular from the lateral side, you can shift it to the neutral side. So this is the advantage of doing an Evans osteotomy. Look at the lateral column shortening, and you can put a wedge on 2 centimeter proximal to the CC joint, and you can lengthen it, try to get the talonavicular coverage. So that is the only advantage of doing an Evans osteotomy. We want a talonavicular coverage. This is how you can use bone graft, or you can use this cage also, metallic cage, to get this or to lengthen the lateral column. So this is the second incision. We have done osteotomy, open wedge osteotomy, and this is how you apply a bone graft. So I use a fibula stud many times in the pediatric age group because the fibula get the remodel, and this is a strong hold on the lateral columns, but you can use the bone graft from the iliac crest as well. And this is generally Evans procedure, Evans osteotomy, where you may need the fixation. I use the 2.7 mm blocking T-plate, and by doing the medial sliding calcal osteotomy and by doing a lateral column lengthening, usually you can see the Evans is usually the talonavicular coverage is complete, and this is the radiological parameter which we want from the surgery. Sometimes when the forefoot, after correction of the hindfoot deformity, usually soft tissue correction is not required in the pediatric or the adolescent age, but yes, in the adults, Rahul will explain you how to do the spring ligament reconstruction and the medial soft tissue reconstruction. But in the adolescents, usually this is not a procedure. So third osteotomy which you may require, because it's a childhood deformity, is a forefoot supination, because they are born flat. So forefoot gets supine, forefoot becomes supinated to control the hindfoot valgus. So after controlling your heel valgus, after controlling the talonavicular uncoverage, this is the third osteotomy you may require, that is called Cotton's osteotomy, the open wedge osteotomy of the medial cuneiform. And this is how you can put a bone graft there. Now we have a wedge plate from the various companies where you can use a wedge plate. This is how you get a correction. Look at before and after. So when you do the open wedge osteotomy of the medial cuneiform, you will get enough correction of the forefoot supination. That is the final fixation of this procedure. So these three procedures are usually the complete set of osteotomy in a flexible adolescent flat foot deformity, and this is how you get a correction. Meares angle, which is now corrected to neutral, and this is a posture of the same patient which is corrected to neutral position. Case number 2 is a 17-year-old boy, similar deformity, flexible, no rigidity. He's having a significant flat foot as well as the genu valgum, but has all the symptoms to the foot. Here, just medial sliding is not possible, and is not possible to get the correction of the heel valgus. So we have done a rotational as well as the medial sliding osteotomy, where you can see that the distal fragment is rotated medially. So this is called needle shortening, but rotation gives you the good correction of the talonavicular coverage. No need of Evans procedure here. Just the rotation and the sliding is sufficient to bring the talonavicular coverage. But this patient was having some laxity. I was suspecting some soft tissue problem, so we have done a soft tissue repair. Just the medial plication by using the anchor to the navicular bone. This is another patient, 20-year-old male patient. Doctor, I have a pain all around my heel. So this patient is having a pain all around the heel. That patient was having a pain on the medial side, but this patient is having a lot of stiffness also. He say that, doctor, I can move my right foot in all the directions, but I cannot move my left foot in any direction. I can do only dorsiflexion and plantar flexion. Rotation and circumambulation is not possible. So when you get these kind of patients, usually we are dealing with stiff flat foot. We are dealing with some collision disorders. So what are the type of collisions? We have learned already from Dr. Prakash's lecture that there are three type of collisions very common, but the commonest one is a subtalar collision, where you get a medial sustentaculum stuck to the talus. And here you can see that this patient, although he was just 17-year-old, but he presented with a subtalar arthritis because it was degenerated cartilage, collision at the medial column, and there were a lot of calcaneofibular impingement. Obese patient, so he was having a lateral pain as well. These are the patients you cannot do the reconstruction. These are the patients where you need to do a fusion, and he was a 17-year-old, so you can treat this patient like an adult. So this is a common scenario generally in this age group, and this is how this foot is reconstructed. Sometimes the last case, 16-year-old male patient, they have a medial foot pain after a simple twist. This patient was he was giving me the history. 6 months before, I have just a small twist and then my pain is not going through this way. So all the pain is basically located on the medial and the plantar aspect of the navicular bone. On examination in the X-ray, we find that this is the accessory navicular bone. What is the treatment for the accessory navicular bone syndrome or the painful? It's offloading. When you have given a sufficient period of offloading and your patient is not recovering, you need to take out that extra bone. But if you just take out the extra bone, 80 to 90% of the cases, accessory navicular bone, painful I am saying, they have an associated flat foot. So if you just remove this bone and if you don't correct this deformity, your purpose of the treatment will be incomplete and patient will have a recurrent pain in next 6 months. So this patient was treated with this technique which is called sinus tarsi stent. There are now the availability by few companies. Now this stent is freely available. You can use in the adult or in the adolescent or the pediatric cases. I don't use in the adults. And my limitation is only up to the flexible deformity, just to reduce my other stuff of the flat foot like Evans and the medial sliding osteotomy. If I want to bypass those procedures, I can use in adolescent, but still it is in the infancy. I cannot conclude the final message, but this is definitely a very good way to correct the deformity. You can see, just putting a sinus tarsi stent of right size, you can control the abnormal rotation of the talus and you can get a Meary's angle and the talonavicular subluxation. But on the top of that, because I have removed the accessory bone, so I have repaired the tibialis posterior towards the back to its accessory to the main navicular, and this is how you get a correction. This is preoperative heel valgus, and this is the neutral position after this removal. So take home message is, flat foot is a complex problem. Again, we have a continuation of the talk. Pre-operative assessment is very important. Perfect osteotomy is very important. Improper application of the principle may lead to the funny deformity creation. And case-based selection of all the implants and the stuff is important. No one implant for all flat foot, and not all flat foot require the similar implants. Remember, osteotomy are just a part of the correction. There are some soft tissues which Rahul will take care, and these are also the important part of treatment. Thank you.
Thank you, Girish sir, for the excellent presentation. Now I would like to call Dr. Rahul sir for his next presentation.
Okay. So we'll proceed from adolescent flat foot to the adult flat foot. None of the PGs are looking in front. So I'll not ask you anything, we'll just proceed to the talk now. Okay. So my idea of the talk is, at the end of this presentation we should have known that what are the structures that are involved in the pathology and what are the structures that fail that leads to the progression of this flat foot. We have to recognize the stages of the adult acquired flat foot, what is the clinical and radiological workup, and how to plan the treatment of this. Now we started calling it an adult flat foot or an adult acquired flat foot, and gradually it kept changing the names, and then it became a progressive collapsing flat foot disease. So the nomenclature is changing, and this changing nomenclature is also causing confusion. So what we'll do is we'll try to find out the basic cause, basic pathology and basic staging of this. So adult flat foot, it could be because of the inflammatory arthritis, it could be a primary midfoot arthritis, because of any neglected Listerine kind of fracture dislocations. Muscle spasm, usually the peroneal muscle spasm causes in case of a neuromuscular disease. It could be a neuropathic deformity like a Charcot foot, which presents as a flat foot, or it could be secondary to the coronal plane deformities in knee or tibia or the ankle. So multiple causes. But the most important cause that we will discuss today is the adult acquired flat foot disease, which is because of the tibialis posterior tendon dysfunction or the posterior tibial tendon dysfunction (PTTD). This causes a progression of the flat foot disease, which starts from one particular stage. Gradually, with time, it increases in severity, progresses in severity, and finally we lead to a disease called as a flat foot deformity. And this is the new nomenclature now, which is called as a progressive collapsing foot deformity. So there are various stages. So it was classified by Johnson and Storm into stage 1, 2 and 3, and later on Meyerson, he gave his own addition to the Johnson-Storm classification at stage 4. So what is the stage 1? It is stage 1 is the early stage where there is a pain and swelling over the posterior tibial tendon. Arch may be completely obliterated, may not be obliterated, maybe just a low arch. There is no deformity in the hind foot. There is a pain which is only on the medial side, and that too also when the patient is walking or trying to go for a heel raise. Patient is able to do the single leg heel raise, but on repeated single leg heel raise he will have some weakness. Radiologically, if you see, it will be a normal patient. So again, how a tibialis posterior tendon, just like any other tendon will present, it can be in an early stage where only tendinosis is there or a tenosynovitis. Then gradually, if the deformity continues, if the pathology continues, it converts into a partial tear and finally into a complete tear with a severe deformity. So the stage 1 treatment is basically a conservative treatment, which is with a cam walker boot, a pneumatic brace or a POP, anti-inflammatory modalities, strengthening exercises, proprioception exercises, stendoachilles stretching, gastrocnemius stretching. If the patient is not responding well, we can give an adjunctive therapy in terms of a shockwave therapy, ultrasonic therapy, bone marrow injections, PRPs. The list is long. And all these different kind of braces have been advised, have been named. You can use a SHC stiff shoe heel counter. You can have a UCBL brace, custom ankle brace, AFO, Arizona brace. This is a long list. You can use either of them. But the basic idea is to offload the tibialis posterior tendon and compensate for the overfunctioning of the tendon. Now, still sometimes some patients in the stage 1, they do not respond very well to this, and these patients, they need debridement or the repair of tibialis posterior tendon. Either the debridement can be done endoscopically, which is called as a tendoscopy, or you can do an open debridement. That is the choice of the surgeon. So this is how things change. So a foot which looks like a normal foot on non-weight bearing suddenly turns into a collapsed foot on weight bearing. Why? Because the tibialis posterior tendon, it functions as a sling. In a disease or a damaged tendon, a normal looking foot on a non-weight bearing suddenly turns to a collapsed foot when the patient is weight bearing. So this is the stage where the stage 2 begins. So when we saw stage 1 had no deformity or a low arch maybe but not complete obliteration, stage 2 will have a complete obliteration of the medial arch. So this is how it happens. If you try to force it down, the tailor's head will try to come out of it, the heel will go into the valgus. This is what you will see. So you saw in the previous lecture when Girish was explaining the heel valgus from the hindfoot alignment view. This is how a heel goes into the valgus. And this is what we are supposed to correct. So in a straight normal foot, that is the hindfoot alignment where the that the axis of tibia is in line with the axis of the calcaneus. Whereas in a collapsed foot, the axis of tibia goes, rather the calcaneus goes into a valgus heel as compared to the axis of the tibialis posterior. The tibia. But again, how we will differentiate is if the patient is going on his toes, like this. So we have to see while the patient is trying to go on the toes, standing on the toes, does this axis becomes back to the normal or the arch is restored? If yes, it is a flexible flat foot. If no, it is a rigid flat foot. So that is how we differentiate between stage 2 and stage 3. So a stage 2 patient will have medial pain, will have a loss of arch, but it is a flexible foot. The hind foot is coming back to the neutral position on going on standing on the tiptoe. So this is how we see, that is how we take a hind foot alignment view. The patient is made to stand, the cassette is right in front of the patient, he is on a wooden stand. The x-rays will come from 20-degree capillate position to the downward. And this is how we will see the lateral view, and that is how we will see the hind foot alignment view and the axis. So again, in the stage 2, there are multiple stages, stage 2A, 2B, 2C. Now, if we have progressed from 2A, 2B and 2C, we were talking about the forefoot deformity or the compensatory forefoot supination. I will not go into detail because Girish has explained already about the forefoot supination. We will only talk about the involvement of the tibialis posterior and how we will treat it. Now, stage 1, we saw that we tried to treat this deformity by the conservative treatment. It did not, the tendinosis of the tendon by the conservative treatment. If it did not respond well, it progressed to the next stage. We do an MRI, we see that there is involvement of the tendon, there is insertional tears in the tendon is going into the pathological state, degenerative state. The ideal treatment is decompensate the tendon. That can be done by the medial sliding osteotomy of the calcaneus, which was beautifully shown by Girish. So once we have done the medial sliding osteotomy, we have decompensated the tendon, what we will do is we will do a transfer. And the ideal tendon for the transfer is an FDL transfer to compensate for the loss of a tibialis posterior tendon. So what we do is we do an FDL transfer for the degenerate tendon. The principles of tendon transfer is still the same. We will keep the same tract. We will attach on the plantar surface of the navicular, through the navicular. The mode of attachment can be the interference screw, can be a suture anchor, can be right through the tunnel and stitches back to it. Middle side osteotomy we have already seen. It shows the mechanical pull tear medially. Let's not talk about it because we have seen this. Cotton's procedure, again Girish has described already. It is an adjunct procedure for stage 2C when the patient has developed the forefoot supination and we are correcting the Cotton's by the Cotton's osteotomy. Again, as I told you in the first lecture, the gastrocnemius is the culprit in almost always all the pathologies. So if this patient also has a gastrocnemius contracture and we leave it like this, because we have just did a reconstructive surgery, there is a high chance of recurrence of this disease. So we will always start this procedure with a gastrocnemius fascia release or a gastrocnemius recession. If there is a contracture at the Achilles and the silver scale test is negative, there is contracture at the Achilles, you will do a percutaneous or an open tendo-Achilles lengthening. You have to correct the hind foot alignment also, because if the alignment is not wrong, there is a chronic subluxation of the subtalar joint. It causes rotation of the calcaneus. It keeps going laterally, and now comes the third stage, where because of the abnormal pull, if you see on the rightmost side, the heel valgus is so more increase in severity. It has started impinging on the lateral structure. This is the stage where you have a subfibular or a sinus tarsi impingement. So now the characteristic of the stage 3 is the pain of the patient is not medially. The patient will present with the lateral pain. He will not complain of any pain on the medial side because the degenerated tendon has gone, the disease has progressed to the third stage and the pain is on the lateral side because of the impingement. Medial pain is gone down and lateral pain is there. Okay. So this is how the forefoot abduction, we have already seen by the Girish how to correct it. We will not talk about it. Now the important structure after the tibialis posterior tendon is the spring ligament. Now advanced disease of the flexible flat foot, once we have corrected the forefoot abduction, one important ligament which is again functioning as a suspensory or the shock absorber device is the spring ligament. Now it is just beneath the tibialis posterior tendon. We went ahead with the previous planning. We did a medial sliding osteotomy of the calcaneus. Then we did an FDL transfer. Now for the young patient, early 40s, stage 2, when we are doing the reconstruction, spring ligament is to do surgery. You have to do a spring ligament repair. Now the ideal way to do it is by an internal brace where the two ends, the superior and inferior band of the spring ligament. If you see a spring ligament, from substenticulum there is a superior band which goes all the way to navicular, and there is an inferior band which is on the undersurface. So we have to reconstruct both the bands of the spring ligament. So we can have two limbs of the internal brace or a fiber tape which originates from the substenticulum tali, the superior limb going all the way into the superior surface of the navicular, and inferior limb goes right along the FDL which has been transferred to the tibialis posterior. So we have to do a spring ligament repair. This, what will it will do is it will help you without doing a lateral column lengthening, and then check that if still you need a forefoot abduction correction, then you can go for a lateral column lengthening. Okay, some patients have a severe instability of the medial raise, and there is sag not just at the talonavicular joint but also at the naviculo-cuneiform joint and further above. So for these patients, sometimes we have to add on a few fusion surgeries because only the reconstructive surgeries will not help these patients. So pain is on the medial side, plantar side, and medial column fusion or arthrodesis can be done for these patients to relieve them of the pain. So like we are talking, the stage 3 or the rigid flat foot deformity, it has more the lateral sided pain. The deformity has gone much ahead in the severity. If you see the talus is nearly 45 to 50 degree plantarwards. The uncoverage is more than 50 degree. There is arthritis of the subtalar joint. So the procedure of choice is not reconstruction but fusion. So we can go for a subtalar arthrodesis, we can go for a double arthrodesis which includes a subtalar and a talonavicular. You can go for a triple arthrodesis. Now almost all the recent literature have shown that double arthrodesis gives equally good results like a triple arthrodesis. So we can go ahead, we can do a talonavicular and a subtalar arthrodesis, and if calcaneocuboid joint is good in your CT scan and MRI, we can leave the calcaneocuboid joint and we can get the deformity correction. Apart from that, TL lengthening, a gastrocnemius recession, medial osteotomy, if we have to do, it has to be decided on the case-by-case procedure. But the procedure of choice for a stage 3 adult acquired flat foot deformity is an arthrodesis. So some of the examples where we have corrected the talar declination, we got it back to the normal, and we have fused this in situ by a triple arthrodesis procedure. And we were able to correct the hindfoot alignment if you see in the hindfoot alignment views. Stage 4, this is the recent stage which was added by Meyerson, which says about the rigid flat foot deformity with the ankle involvement. So now the medial ligaments have gone along with the deltoid incompetence. The last ligament has failed. So there is a significant amount of talus tilt into the valgus position, and this is where we have to do either the entire flat foot reconstruction with triple fusion or double fusion with a deltoid reconstruction. And sometimes deltoid reconstruction is not possible in such patients which have a very severe deformity and arthritic ankle, and we have to go ahead and do a pantalar fusion or a pantalar arthrodesis in such patients. Again, a word on the progressive collapsing foot deformity, new classification. Class A is a hindfoot valgus, Class B has a midfoot forefoot abduction, Class C has a forefoot varus, medial column instability, Class D has a pantalar or parietal subluxation, and Class E is the advanced which has an ankle involvement. So we will not confuse this right now, just a name. What we have to look is we do not miss a tibialis posterior tendon dysfunction in our OPD clinics, because the patient will present to you with a flat foot and you have to stage it, and you have to explain that this is a very treatable conditions. Most of the patients, they are being told that nothing can be done, wear a night shoe, wear whatever comforts you and carry on with your life. But these are very, very rewarding surgeries. Depending on if you have chosen the right surgery for the right staging. If the right surgery has been done, the patients are really happy and they can get back to near normal activities in their life. So do a good history, good assessment, good clinical examination, find out all the medical comorbidities and treat it accordingly. The treatment modality has to be as per the staging. Deal with the patient's expectations, explain what all you can offer to the patient, do a good radiological clinical assessment of the patient, and then finally decide the treatment. Thank you.
Thank you, Rahul sir, for excellent presentation. Now I would like to call Dr. Girish sir for his talk on charcoats.
Thank you, Rahul. Good presentation. And you have almost covered complete flat foot. Now I'm going to the quick slides for the my last talk for the today's session. So, what should be our understanding about the Charcot arthropathy? These slides I really love whenever I talk on the Charcot arthropathy, because if you see just the right side of the foot, just where the foot, where you can see the midfoot area on the right side, which is dusted. God has not made this area for the weight bearing. So this is the patients where you need to understand that now these are the high risk patients. These are the cases which they may land up with this kind of situation. They may be the pre-ulcer condition, and our job as a surgeon is to identify the patients in the early Charcot so that it should not be the pre-ulcer condition, and that is actually the mainstay of treatment in the Charcot. If the infection is already happened, then it's completely a different treatment option. But let's prevent the ulcer first by predicting by selecting the patients where they need a treatment in the pre-ulcer stage. Now this is a beautiful paper which is talking about that what is it basically indicative of pre-ulcer condition. So always take a lateral view of the patient and see the lateral talar axis and the first metatarsal, same like a Meary's angle. And they say if this angle is more than 27, these are the patients which are very, very high chances of having a plantar ulcers. You may have this kind of ulcer formations. So whenever you see the Charcot or diabetic patient having the deformity, always get done this X-ray and identify if it is more than 27 degree. These are the unstable and the non-plantigrade foot which needs some treatment. So we cannot reverse the Charcot process. The Charcot goes through the process. It's a metabolic bone disease. Charcot is a problem of bone, and it is the deformity is aided by the tight muscles, but it is basically not a diabetes which is causing anything. It's a neuropathy which creates the abnormal metabolism of the bone that leads to this kind of deformity, and that leads to the rocker bottom deformity. So anyway, what are the hallmark of the midfoot Charcot? So they are generally having a rocker bottom deformity in midfoot break. So they have a severe midfoot valgus. They are more likely to ulcerate, and they need a relatively shorter period of immobilization. But at least they need a immobilization for 1 year. What are the hallmark of the hind foot? Hind foot, they create a lot of bag of bones formation, persistent instability. They are less likely to ulcerate as compared to the midfoot, but they need very, very longer period of immobilization, maybe up to 2 years. And this is a very important slide, that these are the degeneration. I mean, this is the midfoot is a bone which is degenerating. It is creating fractures and deformities. But it's basically the tight gastroc which is creating more deformity. And try to take the midfoot more towards the plantar side, and that leads to the various ulcer forming condition on the foot that we have seen. Now, what is the goal of the treatment is to prevent the patient in the pre-ulcer condition, as we have discussed. Now, what are the indications of conservative treatment? When the early Charcot is detected, when the foot is stable and not progressive, when the patient has an arterial perfusion problem, vascular problems, or when they have acute, early, stable, undeformed foot doesn't need the surgical correction. Now, what are the treatment for the acute, early, stable foot? Is definitely the offloading. There is a various way to offload this. I believe on the total contact casting, which is a very safe and the effective method, and there is a specific technique of applying this TCC. And you can learn from the YouTube that how to apply the total contact cast. It reduces the plantar pressure and reduces the chances of ulceration. Crow walker you can use, but it's unnecessary costly. But for the poor patients, you can go for the casting. It's still a viable option. So look at the example here. It's a 45-year-old male having some Lisfranc injury in the midfoot. No pain, no sensation. The deformity was progressive, and this is how the patient presented to us with the ulcer over the cuboid, because that is the area where most of the ulcers deform. So either the ulcer form on the cuboid or it's on the talus, because they are the most important deforming forces. This is how the patient presented to us, and they were plantar exostosis. So in the first stage, because it was infected Charcot in the first stage, we have removed the infection, we have removed everything, exostectomy, ulcer, protruding bone that needs to remove. And the second stage, when everything was healed after 6 months, the bag of the bones were collected from the hind foot, and all the bones, they were taken together to get a stable pseudoarthrosis by using the plates which were available at that time. So ultimately the aim is to stabilize the hind foot and to stabilize the midfoot, so that it should not create a ulcer formation. And this is a 3 months, 6 months follow-up, and the patient is walking pain-free without any problem, and there is no any ulcer creating condition. So this is a 6 months follow-up of this patient, but you need to protect these patients for at least 1 year. So 2-stage protocol is good when you are treating a patient with the infected Charcot. Now look at another example. 45-year-old female with the hind foot Charcot, and she has a pes planus. She has no pain, no deformity, significant deformity, but these were the pre-ulcer conditions, like a non-resolving or the recalcitrant callus on the medial aspect, because they are walking on the hyperpronated foot. So these are the cases where sometimes if you are not treated properly, they may create some big ulcers. And these are the patients which were treated with the gastroc tightness and the triple arthrodesis, by which the Rahul has already explained. And this is how the talonavicular preparation and the fusion is done through using the various implants. So these are now one more patient, 60-year-old woman having hind foot valgus on walking, and you can see the talus is almost resolved, and there is a lot of bag of bone creations in the hind foot. There is a clawing of the toe, which is a sign of the neuropathy. This patient was treated with a percutaneous T lengthening and transfibular osteotomy, and doing a tibio-talocalcaneal nail fusion by the TTC nail. So this is how you put a TTC. So this is a nail which is designed for only the subtalar and ankle fusion, particularly helpful in the Charcot patients when you have a dissolution of the bone in the hind foot, and you have to create a very stable environment so that a stable pseudoarthrosis will create, and put a extra screws if you have a less bone stock. So this is a patient where there was a very less bone stock of the talus, and that's why we have used the extra articular screw as well. Now what did I learn from the hind foot Charcot? The pantalar fusion is a good option, and the joint preparation is very important. Now the last but not the least, 42-year-old male having a simple ankle twist, and this has created a neuropathic bone disease, and this has been treated by approaching pantalar fusion by dual approach, and this is how the fusion has been done. The ultimate goal is to prevent the plantar exostosis. Last case, 60-year-old male, already the fusion was done by some other surgeons, but he entered into the Charcot, so very poorly salvageable, but this patient was already having the total knee replacement done 10 years back, so we didn't want to disturb the knee to take out that nail. So there was luckily no vasculopathy, so this patient was treated using the dual approach. The viable fibula was taken with the nail in situ, and we have done a very long defect of the bone was created after the joint preparation. We have taken the fibula as a bone stud, and we have used a 12 cm of the fibula as a bone stud as an intramedullary nail. So sometimes when you don't have a bone stock, you have to create a fibula as a bone stock, as a nail as well as a graft. So this is how the fibula was inserted, and it has been used as a graft, and on the top of that the plate was applied and the patient is walking. Luckily everything is healed. So my experience about the Charcot is intramedullary fibular stud is a viable option for the huge bony defects. Immobilization, wound care and the sugar control is likely to success, and the vasculopathy is the enemy of doing any surgery in Charcot. Thank you.
Thank you, Giri sir, for your excellent talk on Charcots. Now I would like to invite Dr. Srinivas Reddy sir for his topic on resistant clubfoot treated by Ilizaro methodology.
Yeah, good morning. I don't take much of time because the time we are running late, and I don't know whether I am a fit person into the faculty of foot and ankle, but I have taken the advantage being on the organization side. I included myself as a foot and ankle in the foot and ankle faculty. I am basically an Ilizaro surgeon who do Ilizaro cases, and I have done a good number of these clubfoot cases. So we'll be presenting. So briefly, I completed my MBBS and MS from Kagadia Medical College, Warangal, and after that I have been to Akola, Maharashtra for the fellowship of Ilizaro in 96 and 97. After that I had advanced fellowship in Ilizaro from Lecco, Italy under Maurizio Catani, and from then onwards I am working as a consultant in the same Rohini hospital, and I am also a professor of orthopedics from Prathama Medical College. Okay, this is a resistant clubfoot treated by Lizaro method. And in history, it is well described. Even in the mummies, it was seen in the mummies, the clubfoot, and even in the Egyptian civilization, it is there. It was described in the pictures, the clubfoot, and even in the literature, it is described as characters by certain characters by clubfoot. People were there. And next, it's really, one of the difficulties in foot and ankle surgeries. And because of multiple deformities, the treatment is going to be defect, and also the long-standing, because of the long-standing nature of the disorder. It's why it is difficult, because of the chronicity and fixed contractures out there, and multiple joints of the foot were involved, and the bones deform into abnormal shapes because of the chronicity. They go into abnormal shapes and the treatment becomes difficult. Apart from this, added to that, the neurovascular problems would be there, and also the skin healing problems would be there. All these things will make the treatment of the resistant clubfoot a difficult task to the surgeon. And in the morning we had a very nice clinical examination by Dr. Rahul, and so it applies to every foot and ankle disorder. The clinical examination is very, very important, and you have to assess the severity, how severe it is, and we have to have a gait recording. Okay, we should have a gait recording and also proper X-rays, and the most important thing is counseling should be done. Last week, right? And it should be in the main slide itself. It takes a lot of time. Okay, that's gait recording. We have to go for it before resorting for the treatment of the clubfoot. Back. And counseling is very important. And what are the goals of the treatment? One is the plantigrade foot, which is very important, and functional foot. It should be painless, stable, chewable, and cosmetically it should be an acceptable one. These are the goals of treatment. And what are the principles of treatment? And even though Elizaro, we need to do limited soft tissue releases and essential tendon transfers, especially tibialis anterior tendon transfer, and then we have to go for the mounting of the fixator. And the basic thing is differential distraction, the forefoot and the hind foot. Medial side you have to do more distraction than the lateral side. Both sides distraction, but medial side should be more distraction. And the basic principle on which we are working is law of tensile stress, the basic philosophy of Elizaro methodology, and this produces soft tissue histoneogenesis. Newer tissues will be regenerated by gradual distraction, and that makes our job easier. That makes the foot supple, rigid to supple. So, and bony procedures, not that much essential, but whenever we need to do osteotomies, wedge resections, fusions, and generally talectomy. It's not that essential to do by Elizaro method. And the surgical procedure is a stringless release, we have to do it, and tendon transfer if essential. Posterior soft tissue release if the foot is too rigid, or in the adult we can go for a limited soft tissue release. And the fixator application, 2 full rings in the tibia and 1 half ring in the hind foot,
and one half ring, and sometimes we may go for a full ring also in the forefoot. That is a construct. That is a construct. Okay, and it's an unconstrained frame without hinges. Generally, what we do is we will distract without keeping any hinges, because foot is such a foot and ankle, such a complex joint where we have to go for the hinge, where the movement occurs. It's not that easy. We go for an unconstrained frame, and distraction will start after 4 days from the date of surgery. Distraction hind foot and forefoot, ankle, and also the subtalar joints. We go for distraction after sufficient distraction, meaning there is a clear space in the ankle joint, subtalar joint. So then in the forefoot also, in the midfoot, forefoot, when there is ample space between the joint, then we will remove the interconnections and we go for the correction and realignment of the foot and ankle, and the fixator care as usual. Fixator, Ilizaro fixator, definitely the patient will be very much, it's a difficult thing, and it's not that comfortable as that of internal fixation. We have to go for the fixator care, and pin track infections is a major problem. So, and what are the complications? Incomplete correction, recurrence, and forefoot adduction. And fixator removal is generally, it differs with the age and the severity. Generally it will be 4 to 6 months. And how to calculate this? I follow this method. Soft tissue distraction time plus 2 into soft tissue distraction time. Maybe if you distract for 1 month, we add 2 more months. Or if you distract for 2 months, we add 4 months. Like that, because immediately after distraction, it won't be really, tissues won't regenerate. It will be tension, under tension. So they go back. If you give some more time, maybe double the time of distraction, like the bone consolidation, we have to give for the soft tissue also the time for consolidation, then only the recurrence rate will be less. After that, still we have to go for POP cast for 1 month, depending on the situation, 1 or a couple of months. And clubfoot shoe for night sprints and clubfoot shoe you have to maintain for 3 years. And results grading excellent, good, depending on the outcome. And some of the case reports. This is a college going lady, 18 years lady. This is the severity of the clubfoot with walking on the lateral side. Callosities are there. Callosities are walking on the lateral side. And this is X-ray picture. Fixator is applied on the right side. In 2 different sittings I have done, because to reduce the difficulty to the patient. Right side done first, and left is done later. That is outcome, and the length of the foot would be maintained. And that is the podogram, and that is the outcome. And 12 years she is like that, except for the left side. The hallux varus deformity has developed in due course of time. Videos. So that is 12 years follow-up actually. She got married and had two children. Okay. This is a syndromic child, 4 years child. And 2 different sittings it is done, and just 6 years follow-up. Walking a little bit different gait, but anyway we could achieve plantigrade foot. I don't know how much I am right. She is a syndromic. She couldn't walk at the time when she was presented, but in due course she started learning. She started walking. And the next case is a failed case after surgical procedure, and fixator is applied, and this is the outcome. Okay, this is a more or less a pure equinus, more equinus. Is a podogram only on the walking on the forefoot. This is a final result. Could achieve plantigrade foot, nearly plantigrade foot. And this is a arthrogryphotic child, bilateral, and and we could achieve a reasonably good result. And finally, it's a difficult clinical situation, and we need thorough evaluation, proper counseling, and we have to do necessary whenever we feel. Everything depends on the circumstance, what should be done, soft tissue procedures, tendon transfers or osteotomies. They have to decide based on the clinical scenario. And Elizaro honors biology, skin and soft tissue safety is there, and a lot of neurovascular safety. Length of foot is well maintained. Apart from some of the disadvantages which are inherent to the methodology, they are there. And to conclude, Elizaro method, it needs expertise in its application and some difficulties in its follow-up. It definitely a preferable solution in the resistant clubfoot. Thank you.
Thank you, Srinivas Reddy sir, for the excellent presentation. Now we have case presentation.
శ్రీరామ్ ఇట్లా వీళ్ళంతా ఆడ ఆడతారు కానీ రోడ్కి ఎక్కువ రోడ్ పైన ఉన్నాడు వాళ్ళు
లైటింగ్
This is a 20-year male patient, complains of pain in the right ankle since 4 months, painful walking since 4 months. He cannot walk more than 1 kilometer. He has increased pain and swelling with running. History of trauma due to twisting of ankle while playing kabaddi 4 months back. Initially treated by crepe bandage for 20 days. Later physiotherapy was done. He had multiple orthopedic consultations but no decrease in ankle pain. On examination, he has tenderness over the anterior syndesmosis. These are his ankle X-rays.
What was the mechanism of injury? What was the mechanism? Twisting.
Twisting.
Can you ask him to tell what is the mechanism? Like how it is twisted, medial, lateral?
ఎలా పడినా ఒకసారి మళ్ళీ కబడ్డీ ఆడుతున్నప్పుడు ఎట్లయినా చెప్పారు
క్యాచ్
కబడ్డీ
Later MRI was taken. MRI shows grade 2 sprain of the ankle. Now I would like to invite the faculty to examine the case and give orientation to the delegates and solution to the patient.
when it was taken? MR when it was taken?
अभी आ जाओ
అక్కడ అక్కడ వెళ్ళు దాన్ని కూర్చో
After 5 months.
सीढ़ी चढ़ने उतरने में तकलीफ होती है? ऐसा फील होता है हो गया एंकल एंकल लूज लगता है ऐसे करने में पेन होता है ऐसे करने में पेन It's only while doing this you are getting pain. Any pain over here? Push my hand. Push my hand. Push my hand. Push my hand. Sir. Push my hand. Like it. Anyway, so this is a patient of 4 months post injury. He has a non-resolving ankle pain. So he twisted the injury while playing a kabaddi and he has a non-resolving ankle pain. His main pain is coming when he is doing some poor activities. On routine walking, he is not having pain, but going upstairs and downstairs is difficult. He is having a feeling of loose ankle. I mean, this ankle is different than this ankle. He cannot run fast. So on the use of the ankle, he is having problem. He is not having resting pain. So one thing is very sure that what we are not dealing with any nerve issues, because or we are not having any infection issues or where the pain is all the time. So here the pain is only on using the limb. If he is sitting, he is comfortable, right? Yes, sir. You are comfortable. On my examination, when I see this patient, whenever you see any post-sprain or post-injury, there is very important to see where is the tenderness. Okay? So he has classically located. So he has classically located the syndesmotic space. Okay? So this is the anterior syndesmosis, and also he has a pain over here. Yeah, so he has a very classical pain on the anterior syndesmosis over the tibiofibular space. Now the second thing is to see where number one is the tenderness. Okay. Number two is to see any deformities. If the patient is having any visible deformity. खड़े होके दिखाओ इसको. खड़े हो जाओ. पैर दूर रखो. पैर दूर रखो. उंगली के ऊपर खड़े होके दिखाओ. उंगली के ऊपर. टोस के ऊपर. एडी के ऊपर खड़े होके दिखाओ. हील के ऊपर. So if my patient is doing, I am telling you the quick examination. If my patient is doing these two things, it means overall the stability of the foot is good. I am not dealing with any tendon issues, right? Because he is able to do the forced plantar flexion and a forced dorsiflexion. He can stand on the toes as well as he can stand on the heel. Now after looking at tenderness, we have checked the strength of the foot. So he is able to do the full dorsiflexion, full plantar flexion. There is no restricted range of motion. The tendon is only located to the one point. Now we have checked for the syndesmosis. So full dorsiflexion and external rotation, forceful external rotation. But because I think it's a 4 months down the line, so he's not having any pain. Pain hai? Second, sorry. Yeah. So one thing we have checked for the syndesmosis integrity. So on checking the external rotation, forceful external rotation by giving the internal rotation to the tibia and external rotation. So I am basically what I am doing is I am trying to shifting the fibula. So he is not having any pain. So probably it's a settling injury. That's why. Second thing, squeeze test, very important. 4 months down the line. So on the squeeze test, when I am pressing what is that ligament? Interosseous ligament. So he is not having any pain at the site of inflammation. It means probably he is settling the previous injury. Okay. Now the very important thing, very next to the anterior syndesmosis is the anterior talofibular ligament, which is again a sign of instability. Okay. Having a feeling of loose ankle, less strength of the foot, cannot go upstairs, downstairs is again a sign of anterior talofibular ligament, which is 4 times more common than the syndesmotic injuries. So he's having, his problem is he's having a pain only on inversion. Only on inversion. So he's not having, so I think this finding is not matching, but when I'm checking for the anterior talar shift, it is normal. So you have to compare with the opposite side. So how to do the anterior talar shift, anterior tower test? Tell the patient to hold the knee in flexion and then just give the anterior flexion, and same you have to compare with the opposite side. You have to give the anterior force, both are same. Second is a talar tilt test. Tell the patient to do the full dorsiflexion and then you rotate it internally. Same you compare to the opposite side, so it's giving us the equal talar tilt test. So it means we are not dealing with the CFL, calcaneofibular ligament. So what is the diagnosis? Pain on the anterolateral area, settling pain, not provocated on the stress examination. So usually syndesmosis ligament. It takes a long healing time, as we have discussed. So high ankle sprain, they have a high healing time. So probably he is having problem with the syndesmosis, and then it is a time to look for the imaging, advanced scan. Now let's have a MRI scan.
I think there is a small speck on the X-ray. Posterior side, you can see a small speck. Is there any? These are scanning. These are not scanning. These are not standing. You don't have standing.
MRI is just showing the inflammation around the anterior syndesmosis. You can see there is some inflammation going here. Probably this is the. So in the MRI, we are able to see that there is some inflammation. There is some edema in the axial cut at anterior syndesmosis. Okay, so it's probably a resolving sprain. As we have discussed, that high ankle sprain, it has the longest healing time. Foot sprain, it has a 3 months healing time. And a normal ankle sprain, where the ATFL and CFL are involved, 3 to 4 weeks is generally the healing time. So whenever you are suspecting the non-resolving ankle sprain, and after the thorough clinical examination and imaging, you can easily conclude that this patient is not requiring any special surgical intervention. Also, it's a 4 months, so you don't need immobilization. But now the question is, suppose this patient is coming on day 1, then what should be your examination? And what should be your investigation of choice? Suppose now he is 4 months old injury. Suppose he is coming on day 1. What should be our protocol of the treatment? This is really important. So can we go for the MRI on day 1? So suppose on examination, if you find that the patient is having a significant tenderness on the anterolateral, he is not able to touch you, his feet. What should be our next? What should be our next protocol? Weight bearing X-ray. So there should be, because even though the patient is not able to is not able to give you the permission for the stress, but he is able to give you the permission for the weight bearing. So at least a weight bearing AP and the lateral X-rays of the ankle can give us the idea about the stability. Also, the test which we have looked for, the external rotation stress test and a squeeze test, these are more provocative if you see on day 1 or if you see for first 1 or 2 weeks of the injury. So this is how you treat the high ankle sprain. Anything to add, Rahul?
No. I think most likely it's a case of high ankle sprain, and as I was discussing, any high ankle sprain means there is involvement of all the 3 ligaments. That means ATFL, CFL and the syndesmotic ligaments along with that. So now the syndesmotic ligaments will have involvement of anterior syndesmosis, interosseous, and maybe posterior syndesmosis. So if initially, if we are suspecting this is a high ankle sprain clinically, we are doing the investigations and we think it's a high ankle sprain, we have to make sure that we immobilize it for a period as long as 6 weeks. 6 weeks of rigid dorsiflexion. Now, one thing important in this patient is, I think he has a progressive collapsing foot in pelvis.
कौन सा साइड अफेक्टेड है?
There is a very mild pronation kind of thing on the right foot. So that might be post-injury, that might be pre-injury also. So we don't know that status. But if pre-injury, we know that this was the same kind of foot and there was a more pronation, the immobilization needs to be on a mildly inverted position and for a longer duration. So I think right now there is no invasive procedure that we are supposed to do.
So lateral ankle sprain, 3 things to look for: anterior syndesmosis, ATFL, and CFL. So if these 3 things are okay, it means you are not dealing with any instability.
Thank you, sir. Now I would like to invite Dr. Prashant to present the next case.
Good afternoon, sir. My name is Prashant. I am from Prathama Medical College, sir. Thank you for giving this opportunity. Sir, this is a case of non-Indian tibia, sir. In fact, non-Indian tibia treated with Ilizaro, sir. There is a union of the distal tibia, sir. So, while presenting the orthoPD, the patient with non-Indian of distal tibia with extruded talus with calcaneal osteomyelitis, sir. So, we treated the distal of tibia, sir. But the question is how to stabilize the ankle joint with extruded talus, and how can we the persistent calcaneal osteomyelitis. And how to go with
Yes, osteomyelitis.
Sir, with persistent wound development,
How many post-injury? How many months post-injury?
Post-injury it's 20 months, sir.
20 months.
Yes.
So what is the main problem? Like dealing with the infection is the problem, or
Dealing with the infection and the stabilization of the ankle joint, sir. Hind foot and mid foot, how to...
then how is the vascularity of the foot?
The vascularity is good, sir.
Are we dealing with any concomitant medical conditions like diabetes?
No, sir. It's a young guy, sir, with 40 years of age.
Any history of smoking or anything?
Yes, smoking is
Tobacco and smoking?
Smoking is present, sir, alcohol, sir.
Do we have a discharging sinus on the foot?
Yes, sir.
The basic thing is, first you need to check out whether the infection is persistent. As far as you are saying the infection is persistent, the infection is persisting till 20 months. Right? After debridement and it is coming back. Yeah. So the possibility is the sequestrum is still there. So the first and foremost, the sequestrum has to go. So the primary thing comes with the infection, because you are saying the tibia is united. So our main goal is to get a stable and a plantigrade foot. So first you debride that part. What if the bone goes, don't worry about it, because anyway it's not going to have an ankle movement. You want a hind foot where it can take the load. So we want the tuberosity of the calcaneum. It looks to be good, but the central part, what the calcaneocuboid junction is there, that is all bad. So whatever is bad, knock it off, put a spacer or something, and then the second stage, you can fuse that tibia to this and this, and make it a tripod. Make a tripod of it. So that should be your solution, because once you do that, it will be happening. And if you want, anyway, this part is intact. So this part is intact. Usually this part is intact, and this is turned like this. So you can use this for the weight bearing. So this can be turned down, kept it like that and fused to this. This can be brought down and fused. This part, if you want, you can grab. So you will get a tripod at the end. But this has to go. So you have to be very radical on that. When you are debriding, you have to be radical on that. No other way. Because 20 months repeated coming is not an acceptable. This all has to go. Once this all goes out, then you will have a void definitely. You put a spacer if you want initially, and later on you can fill that with a graft, get it down, your toe, cast toe, heel pad, everything will be there. This all can be fused. But anyway, your rings are still there.
Yeah, to remove. You have to rings are there. Have to.
You can use the same ring down. Extend the ring.
But it's infection. Because of infection. First we have to get rid of the infection.
So this has to go.
Right.
Thank you, sir.
So there are a couple of more things that I would just like to add. With 20 months down the line, he is alcoholic, he is a smoker, and a persistent discharging sinus. One thing is, we have to explain patients even up to the need of amputation. We have to be very clear from the day one. And while yes, the first attempt can be for the curettage, for the clearance of the infection, and I think if you get an MRI for this, you will have entire calcaneus involved. Hardly the posterior tuberosity might be saved, but entire calcaneus will be involved and you will have to take it out. So entire calcaneus that we see just below the tibia, that is involved, that will go out. Once you have taken it off, you can put cement spacer, antibiotic cement spacer, and wait for the infection to settle down. Once it has settled down and you think you have substantial amount of calcaneus,
Strategies for preventing progression of osteoarthritis. Etiology of osteoarthritis, we know there is a genetic predisposition, increasing age, overweight, and biochemical factors. All these cause increased matrix degradation and decreased matrix synthesis. Inflammatory mediators play an important role in the pathogenesis of osteoarthritis. There is a systemic low-grade inflammation in conditions like metabolic syndrome.
When we are treating these patients, they are not very. That's what I mean.
In conditions like metabolic syndrome, there is a systemic low-grade inflammation. These inflammatory mediators are released into the joint. So when the systemic inflammatory mediators are released into the joint, it in turn activates inflammation into the knee joint and it aggravates the inflammatory response. The inflammatory mediators released from the joint, when entered into the circulation, it causes systemic effects of osteoarthritis like Alzheimer's, strokes, and myocardial infarction. So strategies for the prevention of osteoarthritis in people who have obesity, weight loss, and neuromuscular and proprioceptive training programs, secondary prevention, and muscle strengthening exercises, and personalized prevention strategies. Current approach for the treatment of osteoarthritis, today we focus mainly on the pharmacological therapy. So there are potential pharmacological blocking therapies. They mainly block the pro-inflammatory cytokines and matrix degrading enzymes. So major inflammatory markers are interleukin-1 and TNF. They stimulate the production of matrix degrading enzymes. So we have products called nutraceuticals. They provide counter protection. So current pharmacological treatments in osteoarthritis, they do not alter disease progression. and prolonged consumption results in severe adverse effects. So consequently there is an urgent need for osteoarthritis disease modifying therapies. So nutraceuticals, these are food products, they provide medical or health benefits and have less side effects. So these are the commonly available disease modifying nutraceuticals in osteoarthritis. So the most commonly used are glucosamine sulfate and chondroitin sulfate, but you can see side effects with these drugs. So this glucosamine sulfate has long-term use, potentially has effect on glucose metabolism, insulin resistance, salt form affect blood pressure and renal function. This prolonged use of chondroitin sulfate tablets leads to epigastric pain, diarrhea, heartburn and nausea. This Boswellia serrata prolonged use leads to gastrointestinal symptoms. So aflatoxin causes nausea and headache, curcumin causes dyspepsia, GERD symptoms, and rosehip extract in randomized controlled trial there is no improvement in knee flexion. So now we have a product called native undenatured type 2 collagen. It protects the cartilage degradation by inducing oral immune tolerance, and other brands have more side effects. So we have shell coil joints. It contains native type 2 collagen along with calcium, vitamin D3 and minerals. So the mechanism of action of undenatured type 2 collagen is it is taken up by the Peyer's patches of the intestine and it's
you can now easily identify where is my posterior malleus, periosteum. Now, periosteum is very important to do the reduction of the posterior malleus. Posterior malleus reduction is always migrated superiorly. So what you have to do is, you have to cut the periosteum because it is very thick. So posterior malleus periosteum, once you cut the periosteum, you apply a periosteal elevator, and then you identify where is the apex of deformity. Always use the tip of the index finger. Just roll the index finger over the posterior malleus so that you can identify where is the apex of the fracture. Wherever you found the serrations or the disturbances on your tip of the finger, you can identify this is my apex. Now, wherever you find the apex, always put a small Homans or any small osteodome and just try to disinfect it. Once you disinfect it, there is a periosteum that you have to shift it downwards so that it covers the talus. After covering the talus, you can put some K-wires and you can do the reduction of the posterior facet. Now, how to see whether the posterior facet reduction is perfect or not? Apex of the fracture is the key of reduction. So if the apex of the fracture is smooth, here you cannot identify how much amount of the posterior facet I have shifted down. We cannot assess. But if the apex is now smooth and if your finger is running very smoothly over the fragment and the proximal part of the tibia, that means your reduction is done. Now there is a plate specially designed for the posterior malleus. This plate is generally, till today we have used the distal and radius plate, and usually you need to give a mold, but now this is a beautifully designed plate and you don't have to give any mold. This plate have 2.7 mm screw below and 3.5 mm screw above. Now generally, if your posterior malleus reduction is not coming to the place, then what you have to do? Then you have to retract the peroneal tendons posteriorly, and then you have to see whether your fibula fracture is overrided or not. If your fibula is suppose overrided, you will not have a reduction of the posterior malleus, because the lateral malleus and the posterior malleus, they follow each other. They are the close friends of each other by the ligament which is called syndesmosis ligament. So if suppose the fibula fracture is not properly aligned, there is malreduction, or suppose there is a loss of the length of the fibula, your posterior malleus reduction is not possible. So it is a general advice that you mobilize the posterior malleus, you mobilize and reduce your fracture of the fibula, and then only you do the fixation. Whichever you want to fix first doesn't make too much difference. People say that if you apply a plate on the fibula, that creates radiological disturbances for the posterior malleus plate, but it's not a problem. Just 20-degree more internal rotation, you can see whether the posterior malleus is in place or not. So if you want to apply the plate on the posterior malleus, this is fine. If you want to apply the plate on the lateral malleus, this is okay. Easy is to apply the plate on the posterior malleus first. So my posterior malleus reduction is done, my lateral malleus reduction is done, and now I am fixing the posterior malleus. In the posterior malleus, the first screw is always the apex of the fracture. So what is the principle of buttress plate? Buttress plate means buttressing the apex of the fracture. Don't fix the distal fragment. Always buttress the apex of the fracture and put a cortical screw. When you put a cortical screw, your the posterior malleus fracture, it completely buttresses and it doesn't go more superiorly, because the plate resists to shift it proximally. So once you put one cortical screw, leave it there, apply a 2.7 mm or the 3.5 mm locking screws, and just put one locking screws. So one cortical screw, one locking screw is generally enough for the routine posterior malleus fracture. we are fixing the posterior malleus through one cortical screw and one docking screw. Always try to drill in the halfway. Don't drill the full way, because generally the distal tibia have a cancerous bone, so your fixation may be loose because the first screw is always cortical. So this is how you have buttressed the posterior malleus, and then you can do your lateral malleus plating. So just as any plate, any single plate. Done. Okay. Sorry? That screw is bicot. Is bicortical. Usually the 32 is a good number for the Indian patients. 32 is a good number. Any plate. Okay, so now the posterior malleus fixation is done. Lateral malleus fixation, everybody know that you have to apply the plate on the posterolateral surface. Now my job is to teach about the syndesmosis. Once you apply the posterior plate, you can shift the peroneal tendon now down posteriorly, and immediately you can see the fibula. Here you can apply a small fibula plate on the posterolateral surface, not on the lateral surface. Why? Because generally the rotational angle fractures, they are spiral oblique. So if you apply a plate on the posterolateral surface, exactly on the apex of the fracture, and it becomes strong construct. And if you apply the plate on the lateral side, then you need to put one interflex screw, and it acts as a neutralization plate. And if you apply the plate on the posterolateral surface, where the apex of the fracture lies, it acts as a buttress. So there is a difference if you are using the plate as a neutralization or the buttress plate. Anyway, our posterior malleus fixation is done, our lateral malleus fixation is done. Now we are keeping the patient to supine position. Don't close the wound at the level of syndesmosis. You can close the wound here, you can close the wound here, and then you can turn the patient to the supine position, because in the last you want to know whether you need a syndesmosis screw requirement or not. Okay? Anyway, now you have done a medial malleus fracture fixation either by the TBW or by the CC screw. This is also done. Now the important thing is how to check the syndesmosis instability. For that you have to rotate the tibia internally, and you have to externally rotate the foot, so that you can shift the fibula posteriorly. Now how to check whether the syndesmosis is unstable or not? See, this should be the force. So whole of the foot, you have to make it stable. Whole of the foot you want to externally rotate the fibula, and you want to shift the fibula posteriorly. If you find there is a widening of the tibiofibular space in non-stress view and the stress view, if you see that there is a widening of the tibiofibular space or there is a widening of the medial clear space, that means it is unstable. In the lateral view, how can you understand that the syndesmosis is unstable? Usually when the syndesmosis is broken, the fibula is shifted anteriorly. So in the lateral view, the fibula should be in the posterior 1/3 quadrant. So suppose this is the whole of the distal tibia, so the fibula should lie on the posterior 1/3 of the tibia. If you find the fibula in the middle or in the anterior, that means it is anteriorly or sagittally unstable. Now, how to fix the syndesmosis? Once you have diagnosed that this is unstable fracture, another way to know whether the syndesmosis is stable or not, various what our now see. Syndesmosis. So you have the 2 centimeters above, and then one person will hold the fibula, the whole leg, and then you have to apply a rotation, just a extraction force. If one person is not helping, or if he is keeping the leg in the internal rotation, generally our habit is if somebody is standing from that side, they rotate the foot like this. to see what is happening here. It creates a stiff pressure and it will not go laterally. So that creates a false negative syndesmosis test. Okay, so this is one test, and the beautiful test which is like 100%. And what is 100% diagnostic, not dependent on the hand, not dependent on the position of the hook, is put a corpse or a small periosteal elevator, put a anterolateral incision, always see the joint, always see the joint. Don't understand the syndesmosis by any means. Always put a anterolateral incision, mini incision, see the joint and see the space. Apply a corpse elevator and just try to distract at the level of syndesmosis. If you find that there is the opening of the fibula, that means it is unstable. This is considered as a most diagnosis. It's called probe test. So you have to probe the syndesmotic space and just you have to rotate it. If any movements are happening, that means it is unstable joint. Now how to fix the fibula? How to fix the syndesmosis? Yes, post-orthopaedic. Yes. So clamp the neck. Now there are two ways. Small anterolateral incision. You can see, you can feel the tip of the finger whether it is reduced inside the tibial incisor or not. If you do the open reduction, there are the 16% chances of malreduction. If you do the closed reduction, there is 50% chances of malreduction. So in spite of doing good posterior malleus, good lateral malleus, good medial malleus, still there are 50% chance that your ankle will go into arthritis if your syndesmosis fixation is not good. So in this situation, if suppose you are using clamp, so how to apply the clamp? Usually we apply the clamp like this, but it is not a right application. Both the prongs of the clamp should be visible on the C-arm. So medial malleus is anterior, posterior malleus is posterior, lateral malleus is posterior. So clamp application should be in the oblique axis. It should be parallel to the transmalleolar axis. Both the prongs, both the sharp end of the clamp should be visible, and it should be at the level of 2 cm above the syndesmosis, and it is the parallel to the transmalleolar axis. If you apply the clamp like this, it malrotates the fibula. If you apply the clamp in more oblique position, it rotates the fibula more anteriorly. So that leads to the more chances of syndesmosis malunion. So the best way is you have seen it, you have feel it, now the syndesmosis, now the fibula is inside the notch, and now K-wire. So before you do the reduction, before you apply the K-wire, always put one K-wire anterior to the fibula. This is called derotation wire. So whenever you are fixing the syndesmosis, don't put the wire directly into the fibula. Always keep one anti-glide wire, because what is the most common syndesmosis malunion? Anterior translation of the fibula. So this will not allow the anteriorly translate, because you have applied a small incision, you have feel it, but now you have preventing the anterior subluxation. At any cost, now it cannot go anteriorly. Again you can check, because you have to reduce that 16% of the malreduction. Again check with your finger, and then you take another K-wire. The another K-wire is posterolateral to anteromedial. So it should not be like a transverse wire. It should always be the posterolateral to anteromedial. As I said, both the malleolar are not in the one axis. So this is the ideal application of the K-wire, and now you can see your syndesmosis is perfectly reduced. Okay, so just continue with this K-wire and see the reduction again in the AP and the lateral. Now it's a time to fix syndesmotic tight rope. Now I am putting a tight rope because screw, anybody can put a screw because the direction is same across like a K wire. But I am using a syndesmotic tight rope to fix it. So it's the same little internal oblique position, 3.5 centimeter above the joint line, posterolateral to anteromedial. So once you come medially, don't come directly through the skin, because there are the superficial nerves and the vessels which you can damage if you are just coming out. So put a small incision here, skin and the soft tissue separation. Once you separate your cutaneous nerves and the vessels, and then see everything in front of you. Now again, before putting a tight rope or before putting a screw, again check the position. Now you are going in the 100% that there is no chance of syndesmosis malignant. Then you can apply the tight rope. Applying the tight rope is very simple. One direction we have understood, posterolateral to anteromedial. Then you have to drill with a 4 mm wire a little bit. If there is a fibula fracture, we are going through one hole of the plate. If there is no fibula fracture, we are going through the fibula directly. But it is always better to apply a 2-hole plate if the fibula is not broken. So the idea is basically if you are under 5 centimeter from the joint line, your syndesmosis hold is great. Above the 5 centimeter, it is very less strength. So you can go even through the comminution also. If you have a comminuted fibular fracture, you can go through that comminuted fibula also. No problem. But try to be at 3.5 centimeter above the joint line. Now see, when you remove the guide wire, still your 2 wires are helping you to keeping the syndesmosis in the reduction. Then you can take a tight rope. The tight rope are already having a 4 fiber wires. They have a needle also. So you can take the needle from the opposite side. Make sure that you have to be in the stretch position so that the button should not rotate inside the tunnel. Just come out from the anteromedial side. And once you come out from the anteromedial side, then you can flip the button. Just flip the button. Yeah. Okay. Then one person is just holding the other 2 threads of the wire. So just take out the threads and with the simple flip-flop movement, you can you have to apply the button only through the flip-flop movement. Usually you have to apply a force only up to the extent that you can apply through the thumb only. You don't have to use the clamp. And in the last, you can take needle holder. You can check your strength with the needle holder. So I always do this because generally we have a glove, so we may not be able to see whether it is tight or not. So just give a full pressure, flip-flop movements, and that is done. can cut from this side. So it is usually knotless. You just have to cut up to the end. You don't have to keep a knot there. And then you remove everything. Once your reduction is done, you can remove your derotation wires. And this thing, if suppose your fracture is unstable, you can put one more tight rope, or if your fracture is stable, you can remove this reduction. And here you can see this is the ideal application of the tight rope. And the syndesmosis is well reduced inside the joint. The beauty of this tight rope is when you do the dorsiflexion, there is no restriction because it allows the micro movements of the fibula. If there is a screw, usually there is a chance that you may over-compress it, and that's lead to the restriction of the dorsiflexion. After 3.5 months of the surgery, you can remove the screw if you feel that the dorsiflexion is restricted. While applying the tight rope or the screw, one thing is very important is always keep the ankle in neutral position. Don't keep in the dorsiflexion. If you dorsiflex, it shifts the fibula away from the tibia. So always keep the neutral position. If you are applying a screw, the position is same. You have to go from posteromedial to anterolateral. The screws are generally 3.5 mm fully threaded screws. They are not a compression screws, and they are just a lat screw. They are just a holding screw. They don't have to. You don't have to apply the screw in the compression mode. Screws are generally 3.5. 2 screws are enough. But if you are dealing with Mason-Avery fracture, like when you have a proximal fibula fracture and the increased medial clear space, you should put at least 3 screws. 1, 2, 3, because it's a long rupture. So you put 3 screws. Don't apply the tight rope for the Mason-Avery fracture because it's a long disruption. Tight rope is for the routine fractures. For the young patient who needs more movements, who need flexible position. Screws and tight rope both are equally good in the function. Screws is a 50 rupees, tight rope is a 20,000 rupees. But it is only okay when you are dealing with young patients, high demanding patients, or when you have a good insurance cover, you can easily go for that. Only advantage is it allows the micro movements. So this is as considered as a flexible fixation. Thank you. The weight bearing is supporting to the fracture. Syndesmosis has no relation with the weight bearing. It is only the healing of the malleolus which allows you for the weight bearing. If you are only going for the pure syndesmosis, 6. Order of fixation. Order of the fixation is posterior malleus, lateral malleus, medial malleus, or lateral malleus, posterior malleus, medial malleus, and lateral and posterior malleus are like you can fix any of whichever looks easy. Then we are allowing weight bearing completely. We have to remove syndesmotic screw and other. If it is causing the restricted dorsiflexion. If your patient says that, doctor, I feel this ankle is a tight, it looks like restricted range of motion, you have tried everything, then you remove the syndesmotic screw, it improves the dorsiflexion. Weight bearing syndesmotic screw does not cause fracture. So the current guidelines are don't remove the syndesmotic screw if you have put in the right direction. Let it break. And always put a tetracortical. Now there is a confusion, tricortical versus tetracortical. Tetracortical. Why? Because suppose if it is broken, you can remove from the opposite end. If it is tricortical, your end is inside the bone. How can you remove it? So tetracortical is better. Let it break. Tell your patient, if your body wants the movement at syndesmosis, it will break the screw. If your body wants some movement at syndesmosis, it will break it. Because I have not put a screw to fuse that joint. I have put a screw just to make for the stable healing of the ligament. And once the ligament is healed, because of the movement, it will break. Explain to the patient that breaking is not a complication. It's a routine procedure. It's a need of your movement at that joint. Okay?
Recommend syndesmotic screw for the patient's transfer?
No. The current guidelines is better not to do any extra intervention unless you have a restricted dorsiflexion. So routine screw removal is not.
if you want to keep for the second surgery for insurance benefit, yes. Sorry? It should sit on the plate. It should sit. So there are two kind of tightrope. They say tightrope with fracture, tightrope without fracture. So there is a tightrope which directly slant on the bone, like this. There is a tightrope with the fracture which is fixed on the screw head. I mean the screw head. All right. Thank you.
फुट का प्लेट का फुट फिजन
Okay, so we'll just have a quick look at the list rank fixation techniques. And we'll be using plates. So we will show how to use a plate fixation for the list rank. Only be focusing on the first and second AMT joint. Ideal way is to use the pen and do a proper surface passing, so that you will know where to put your incision. So palpate your first metatarsal with the tarsometatarsal joint and we have to go proximal. Similarly, palpate the second metatarsal. And since we are only doing a single incision technique, we will go directly over the list rank. Yeah, so we have to have a direct dorsal incision over the first and second metatarsal AMT joint. We have done that. Gradually try it. Now, the first structure at risk that will come at this point is what is versus pedis. That's not the first structure. The first and important structure that we at risk is a dorsal cutaneous branch of the superficial face. Comes here, comes from this, and then it's a plate. So you will see a lot of patients on whom you do a surgery, you don't safeguard this nerve. They keep complaining of numbness of forehead. So you have to safeguard this nerve. It is a very thick nerve. Just make sure that you see. Now just below the nerve there is a sheath. You will see if you go proximally there would be tibialis anterior sheath. So you have to safeguard the tendon also. It goes and it attaches on the uniform. While you are applying the plate, you have to make sure that. Then once you have reached there, now this is your periosteum. joint. If you see, this is your first TMT joint. We can extend our incision a bit more. Once you extend your incision, between the first and second will be your neurovascular part. You have to make sure you don't just go inside it directly, either by artery forceps or any of the instruments, because you have to safeguard this. Now once you have seen this, then you have to safeguard using the right angle retractor, and then gently start exposing the joint cartilage, joint articular surface. Now you know it is there. Gradually you space it, make space for it, and expose the second TMT joint. Now since you have exposed the second TMT joint, I have just show it to you. Shoulder bigger. Now if you see, this is the first TMT joint. This is the first TMT joint. This is the end of base of first metatarsal, and this is the end of base of second metatarsal. The second metatarsal is further deep. It is further deep inside. The ligament which connects the tarsal metatarsal, and then there is the plantar transverse ligament. When you have a complete fracture dislocation, you can easily, when you do it, this is a piano key sign, something like this. So when you try to install the instability, press it down, you can easily move the ligaments, which should be actually like this, strong. Because in a strong tethered ligament with a capsule, it is very difficult to find out where exactly the joint is, unless you see it is so rigid. Once it is broken, it's like a piano key. So if you just do like this, you can easily move this. So that is how it is broken. Now, if we see...
Just one repeat, sir.
Yes.
You are not saying. Just start from there.
Okay. So now we have seen this. This is your Lisfranc joint. This is the second metatarsal base, the first metatarsal base, the cuneiforms. So you have a medial, middle and lateral cuneiform. We will focus upon these four structures right now. The second metatarsal, first metatarsal, medial cuneiform, middle cuneiform. And we will try to fix it, considering this is a purely only the Lisfranc injury pattern with the fracture. Okay. Now we have isolated the four. Now what is the standard practice when we are putting a screw is that we pass the screw from second metatarsal to the medial cuneiform. Earlier we used to pass it the other way from medial cuneiform to second metatarsal, but now we have changed it because the studies are showing it is a more rigid structure. It gives a better compression across the ligament. Now when you are doing that, that is the force of compression from second to medial cuneiform. Now we have made the plates. Give me the plate. Otherwise we will use this machine. This is a okay, so we will be using this plate now. So these are the low profile 2.7, 2.4 mm plates. Our idea is to cover all the four. Again, this is quite small. So we'll make space for this cuneiform, make space for the first metatarsal. These are thick wires, so it is very difficult to shift them over here. Okay. And this is the position that we are supposed to fix this up. Is it? Give me a KY. What is that bundle? KY. So now since we have expressed this in so now you see that is what we are talking about. So cuneiform. Mike, the gravity. We have first metatarsal base, second metatarsal base. We have to make a rigid construct here. All four of them. Yes. Okay. So we have to place plate somewhere here so that we can hold it. One more plate with a wider. This way. So we'll change it. Smaller one. Just explain what kind of plate it is. Just like this is a start. This is for 2 joints, not 4 joints. We also have a plate which is like this.
Box, square.
It's like a
square.
It's like a cone.
Yes.
Goes like this, and this.
సామాన్యునికే తోడు రైతే రాజైతాడు మహిళలంతా మహాలక్ష్ములైతారే మార్పు కావాలి కాంగ్రెస్ రావాలి చేతి గుర్తునే గాని
Do we have a
మార్కర్?
ఏందిరా మీరు తెచ్చే మార్పు? కాశారం బాలేక రైతు చచ్చిపోతే ఆ కుటుంబం మొత్తం బజాట్ల కీడ్చుడు ఆ మార్పు. ఇప్పుడు రైతు చచ్చిపోతే వారం రోజుల్లోనే రైతు బీమా కింద 5 లక్షలు బ్యాంకులో జమ చేస్తుండ్రు. ఈ మార్పు మంచోళ్ళతోనే వస్తది, మీ లెక్క ముంచటోళ్ళతో రాదు. ఆ మంచోడెవరో మీకు ఎరికే. కేసీఆర్, ఆయనకే మా ఓటు.
కారు గుర్తుకు ఓటేద్దాం, తెలంగాణని గెలిపిద్దాం.
Both materials.
So we'll just use this one for the time being. We'll mold it later. Okay, that is the best way, and that can be used. Now give me the mold.
Stronger. The holding. Player.
Very low profile. There is a plate better actually. It's fine.
One more plate. Use.
యాంగిల్ ఉంటే యాంగిల్ ఉంటే
This is just a temporary wire that I have put in. Wire holder. Here level wire holder applicants will come. Here pass. ठीक है सिंगल कुछ सब है. So I'll just put in another holding wire before moving ahead. Give me a minute. So now my main aim is, before fixing it, I can use a clamp. Give me a small clamp. छोटा नहीं, tall clipper sir. I'll try to hold and compress the second metatarsal with the uniform. That is the position that we are supposed to. Once you have hold it here, then now you can apply all the 4 neutral screws. Not an issue. Keep it tight, compress, and apply all the neutral issues. So while we are holding the wiring, give me a 30 screw.
30 screws.
30 locking. I'm just putting a neutralization. I'll just explain how to put up a cortical screw on a give it to छोटे हाथ पे लगेगा. Very unstable. So you can place it. I load it. Yes. Already should be measured. And normal Indian adult, this is screws on the side. Then we'll go for the second screw now.
బరువు ఉంటుంది మరి మార్నింగ్ అంటే కెమెరా మీద ఎఫెక్ట్ పడుతుంది మాకు బ్యాటరీ కూడా ఛార్జింగ్ కంటిన్యూ రికార్డ్ అంటే ఎట్లుంటుంది సార్ దాని గురించే కదా
ఇలాంటి అవసరం ఉంటాయి కదా
అవసరం ఉంటాయి కానీ మాకు ఏంటి మాకు ఇప్పిందే మాకు 2 hours 3 hours అవునా
So once we have put it, now we have to put the final 2 screws. So there's one more plate which is ideal for this. So it has 1 compression and 1 locking screw.
Okay.
So what we do is we'll apply the first locking screw here, and we'll use a bigger bone to achieve a compression bone. So once you've applied a locking screw, you can apply the other cortical screw and the compression bone. And when you do it, it will give the same force the screw gives you, a transarticular screw. So while we are doing it, it will put both of them together. So we don't even have to use the clamp in that way. But in this case, when we don't have, we are applying all the 4 neutral screws, and it's better to hold with the clamp. So we can take one out and we can put the other wire.
But if you don't have this hook, whatever plate, mini T plate, whatever.
So ideally in this case, this is also not the best plate. But what we can do is you can put 2 consecutive plates like this.
What I'm asking is
straight plates.
So and with
if you don't have plate in your inventory, so shall we put screws?
Yeah, transarticular is the standard pattern that I will tell you how to put a screw also. So we'll take it out. I'll just show you how to put a screw. Now once we are done, we can just put
That's okay, sir. Yeah, so screw.
Just put in the drill bit. Rather take it out, then I'll remove these wires.
both the wires. एक वायर होल्डर था ना विशेष में, अच्छा उनका था, ये वालों का ले गया लगा दो.
మనం ఇక్కడ రెండు ఉన్నాయి కదా, మిడిల్ వీటిలో ఒకటి చేసేసి ఫస్ట్ ఇక్కడ నుంచి బేస్ కదంటే సెకండ్ మెటల్ బేస్ అనమాట, దాన్ని దీనికి కొద్దిగా రావాలి. అక్కడి నుంచి ఒకటి వేసేసి దాని కొన్ని వీళ్ళు కొన్ని పంపేసేసి మళ్ళీ ఇంకోటి ఏంటంటే దీన్ని నేను గ్యారెంటీ మీడియం
आपने कलर डिवाइड का छोड़. So now when we are trying to put screws, the ideal position is to put at least 3 screws. Without plate.
Yes.
Just forget about the plate.
Yes, sir.
So we need 3 screws to be put. Just give me a screw first. I'll just show. Maybe just give me any screw.
Because more than
Just to show the position. So the first screw is the second metatarsal cuneiform screw. Then we have to stabilize the first TMT joint, and finally a intercuneiform screw. These are the 3 minimum screws that we have to use, and they have to be 3.5 millimeter cortical screws.
Right. So first screw is dorsomedial to volar lateral, sir? Or?
Yes. From the second metatarsal base,
Yes, sir.
dorsomedial to plantar.
Volar plantar.
Not exactly plantar, just dorsomedial. So that is the direction. So you can put a Hohmann detector inside, make some space for you, making sure that the neurovascular is behind our flap. And then this is the direction. And then we have to make sure that we try to achieve it in a single way, because we are going through the articular surface. Minimum is better. This is a rigid, we will not get much space. I'll try to make it.
Reduction, we have to keep it.
Yes, you have to. Yes. At the time of screw placement. It's just because I don't have space, so I'm just making a space here. So this is how we can come out. Rather, we should be coming out more this side.
More darker.
I'll just make it change for you. Yeah, this is the right place. Okay. Then we have to measure it. Vertical screw. 3.5 today. 3.5. अभी दे दो, कोई भी दे दो, जो भी है पास. 3.5 के लिए ड्रिल बिट चेंज करना पड़ेगा. So this is your first screw that we try to put. And all this while we are putting it, we have to make sure that we are holding the compression. This is a smaller screw, but this is the right size. So usually this is the size. Now once we have put in, we have a stronger. So other structures, what we have done is, what this is doing, a temporary K-wire. So after achieving the compression here, put a temporary K-wire here, a temporary K-wire here. The next screw that we'll be putting is a dorsal screw for the TMT joint. And third screw will be a intermetatarsal screw. That is the entire construct for this frame. Okay? Thanks. You try putting screw? Better you take it out, you'll get a better visual.
Executive Director of Romania. I would like to thank pharma companies like Pulse 11, Alchem, IPCA Laboratories, Eugene Pharma, Torrent Pharma, Corona Remedies, Anansa Life Sciences, and excellent workshop by the Nebula and Depusynthesis.